Hello. Yeah. Thank you. Good morning, all of you. Uh, since we are already a bit late, let us start with the first session of this thematic session. We all know in ICU we have various kinds of patients with anemia, let it be a medical case or oncological case or surgical case or a case of trauma. Rather than understanding when to give blood, I think it is very important to know what not to do and when not to give the blood. So we have none other than Dr. Suresh Ram Subham sir, who will be speaking on the transfusion triggers. He is a senior consultant pulmonologist and critical care physician, Apollo Multispecialty Hospital, Kolkata. His major achievements include he survived till present age without comorbidity despite working in CCM. So, welcome, sir. Over to you.
Don't read it aloud.
Yeah. Before we start, I would like to call our expert panel today. Dr. Lulu Fatima Wali, Madam, Professor Anesthesiologist, GMC Nagpur. Dr. Rajdeep Chaudhary, sir, Consultant Physician, Bhandara. Dr. Soham Ghormode, Intensivist, Amravati. Dr. Anand Bendre, Physician, Chandrapur. Please. Over to you, sir.
Thank you. Good morning, everybody. And had a little scare about the slides being there or not. Finally, thanks to the AV team for restoring my slides. So I think great organization, Deepak, because at least your IT team is good enough to restore the file. Otherwise, we would not even have started. All right. And Reshu, this is how it turned out. Yesterday, we did the, this is, co-pilot making this slide for us. So transfusion triggers in ICU, and it actually did a good job. It summarized what the topic is going to be very nicely for me, RBC, platelets. So I don't have to say what my objective is. My objective is going to be prove that hemoglobin 7, platelet 10,000 restrictive is better than liberal. And that's the message that Copilot was able to generate very nicely for us. All right, so as I said, this is the evidence. The objective of this talk is going to be to use the appropriate use of blood products in critically ill patients. The rationale for blood transfusion has always been oxygen delivery. People who attended the first critical care, this thing in when Professor Schumacher came in India in, I think, 93 or Bombay, first ISCCM meet at that time. And he was a big proponent of high oxygen delivery and keeping hemoglobin more than 10. And his papers on supranormal oxygen deliveries were very good. But we know that the at rest, you have a delivery of oxygen as compared to VO2 is almost fourfold. So if intravascular volume is maintained, if I were to bleed you, but at the same time keep your volume okay, you will be able to be absolutely fine from a cardiovascular point of view till you drop your hematocrit to 10. And that's pretty much all pregnant women in India, isn't it? So they do pretty well. So it's not, so be afraid of anemia is not really necessary. So isovolemic reduction, that is the key word. If you isovolemically reduction, hemoglobin up till 5 gram is very well tolerated. There is an association between anemia and mortality. There is no doubt about it. But that's an association between albumin and mortality. There's an association between nutrition and mortality. But if you improve nutrition, if you improve albumin, if you improve hemoglobin, does it improve mortality? And the answer is probably no, is what we understand. So if you look at, this is the very old study from Carson et al. From 1996 published in Lancet. We looked at people who had declined blood transfusion for Jehovah's Witness or for whatever reason, and the odds of death were much greater in patients with underlying cardiovascular disease. So this is something which is well ingrained in our mind. If you don't have cardiovascular disease, you might be okay, but if you have cardiovascular disease, you might be a problem. And today, with the presentation of the talk data, and if your hemoglobin is 7.81 to 8, your chances of mortality is 0.9%, 5.1 to 7 is 9.2, 3.1 to 5 is 26.5, and less than 3, 62.1% mortality. So what it again goes to say is 8 is the upper limit that you really need to worry about. After that, you really don't need to worry about when you see data like this. So there are complications of transfusions. TTBI, transfusion-transmitted bacterial infection, transfusion-transmitted viral infections, parasitic, and so on. We have had many cases of malaria after transfusions, and it's not very uncommon to see that. You have immunological reactions like TRALI, you have circulatory overload like tacos, you have hyperkalemia, and of course in chronic transfusions you get iron overload. So with all these things, and most important immunological reaction is not TRALI, but a small graft versus host disease that happens, as a result of which your immunity goes down and you become alloimmunized, and you have a problem of mounting a good immune response when you have. So there is one of the biggest things for not transfusing thing. So when you transfuse, you obviously need to have an institutional policy. It's very important that all hospitals should have it, and any hospital which is NABH approved will probably have a hospital policy for when to give blood and what is the purpose of giving blood. So if you were to look at RBC, so there are indications for RBC can be divided into either an acute bleeding patient or a non-bleeding patient. You can divide into two categories. If you have acute bleeding patient, a massive blood loss, and your expected hemoglobin is less than 7, you go ahead and transfuse. But if you started off with a 15 and it's not a massive bleeding and you're okay, you can probably still give volume at that particular point in time and do source control for control of bleeding. But if you're in hemorrhagic shock, go ahead and irrespective of what the hemoglobin is, transfuse packed RBC, because the best volume, as I said, because the idea is packed RBC, hemoglobin won't make a difference, but volume will make a difference. So when you're actively bleeding, it is better to give volume in the form of not normal saline, but in the form of packed RBC. Ideally whole blood, but we have moved away from component therapy. We have moved towards component therapy, though we are coming back to whole blood again. At least in the United States Army now you have what is called as blood buddies. So that means if I get shot, you know you are B positive, and like then you have Amar Akbar Anthony happening, that we have blood coming from one person to another, and that is very much back in the vogue as far as what is called as blood buddies. Or I know that whoever is B positive, please raise your hands. We go have a drink after this breakfast is over. So if you're non-bleeding, then your only indication to transfuse as of now is hemoglobin less than 7, and I'll show you data for that, or anemia contributing to hemodynamic instability, which is what most of us surgeons will feel that this is what the patient is, and we have to be careful about this thing. So the transfusion strategy, now the term is restrictive transfusion strategy, that is transfusing less blood and transfusing at a lower hemoglobin threshold. And most of the cases will transfuse at hemoglobin less than 7, and that's what the data is. So if you look at the recommendation from various society, the American Association of Blood Bank, they are very, very categorical at transfusion at hemoglobin less than 7 for hemoglobin hemodynamically stable without acute myocardial infarction. And we will talk about this controversy of myocardial infarction in two major trials published in 2023 and 2024. And we will talk about the top trial which got published today. Will clarify what is happening in this group of patients. But if you look at all the other things, stable cardiac disease, transfusion at hemoglobin, acute coronary syndrome, in this one is not mentioned, but a lot of people will use 8. And acute gastrointestinal bleeding, again, there is no indication for urgent transfusion unless less than 7 or hemodynamically stable, or you think the hemorrhage is very significant anyway. This is the first trial, the TRIC trial. 838 critically ill adults were randomly assigned to a restrictive strategy or a liberal strategy. 7 versus 10 was compared. A statistically significant improvement in survival with restrictive strategy in two predefined groups, and that is in less severely ill and age less than 55. So young patients who don't have too much of illness don't transfuse this thing. Obviously, this has, from the 1999, this has become the standard of care. There is a Cochrane meta-analysis based on these number of studies to look at restrictive versus liberal, and you can see that at the forest plot, this really favors restrictive, favors liberal. It's bang in the center. So there is absolutely no reason that restrictive is worse than, to say that restrictive is as good as liberal. And this is what I said, the risk ratio is 1.6, and it's absolutely fine that you can go ahead and do restrictive transfusion in your group. So this is the algorithm that we again mentioned. If you're less than 7, you transfuse. 7 to 10, you do only if you have acute MI. And if you have greater than 10, you only do it if you have a rapidly declining hemoglobin because of some active bleeding. There are certain higher hemoglobin targets like in ACS, and we'll talk about this, hemodynamic compromise, traumatic brain injury, where you want a higher oxygen delivery, and again, active bleeding and rapidly dropping hemoglobin that cannot be adequately assessed and treated using serial CBC. So this is one of those few areas, gray areas, where you can show it. These are the main studies that got published in the last decade or so. And the last one, the MINT one, is the one which controversy was created as far as hemoglobin with less than 10, what do you do? And the FOCUS trial, the Titer 2, TRICS 3, I'll talk about. MINT trial looked at restrictive versus liberal, and there was a restrictive group death was 9.9% versus 8.3 in the liberal group. So there is a composite outcome of death was slightly higher in the restrictive group, and that's what is this thing. This is in cardiac surgery. TRIX 3, Titer 2, and TRAX both looked at 7.5 versus 8.5 versus 9.5. So in OR, again, no difference. So again, everybody is now at 7, but in cardiac surgery, still the number 8 is somehow there. And this is in orthopedic surgery, again, restrictive 8, 7 versus 10, 8 versus 10, 8 is okay. And this is the one which got published today. This is called the TOP trial, which looked at liberal transfusion versus a restrictive strategy for major operations in patients at high risk of adverse cardiac events. Liberal transfusion 9.1% versus 10% in restricted transfusion. So a composite of all-cause mortality, myocardial infarction, coronary revascularization, nothing changes if you have even at patients at risk for major cardiovascular events in a patient undergoing a major non-cardiac surgery. So the goals are non-cardiac surgery, which was 8. For cardiac surgery was 8, orthopedic surgery was 8, 8.5. And every other ICU patient was 7, but now everybody is moving towards the 7 to 8 bandwidth is what it is. So when you order RBC, we need to have certain modification occasionally in the ICU, and this is irradiated blood and platelets we use if you have a hematopoietic stem cell transplant, or you're doing CAR-T, or you're doing ATG or antithymocyte globulin and things like that, but routinely we are not doing any of these things. You can prevent and treat other causes of anemia, basically nutritional. The more important thing is, this is something very interesting, that's why I put it, is what is called the STRATUS trial published in JAMA in 2023, which looks at using small volume blood collection tube versus standard tubes to prevent anemia, because everybody feels that we are blood suckers. We are vampires, we suck in enough blood to cause anemia. So if you use a small tube, 1.8 to 3.5 ml, then standard volume 4 to 6 ml, use of resulted in a small reduction in RBC transfused per unit. But this is something which a quality initiative most of us can move towards. It's not a great, as I said, cost intensive support. There are non-transfusion approach. We know only thing is that erythropoietin is harmful in the intensive care unit because of the risk of infections. IV iron is also not to be given in the presence of active infections. Other than that, there are certain oxygen carriers which became very vogue, especially in trauma patients, but still not, as I said, not really a thing. The other thing that we want to quickly go through is about plasma and the transfusion triggers for plasma. We all know that plasma is the liquid portion of the blood that contains the clotting factors, and fresh frozen plasma is frozen within 8 hours of collection, and most plasma used is frozen within 24 hours of collection, which is called PF24. That's what is commonly used in blood banks, not the PF8. And this is what it is. Again, the indications are massive transfusion, severe liver disease or DIC with bleeding. Again, active upper GI bleeding, INRs are not to be used, and this has become a standard exam question, I would say, for a lot of examples. Like if you don't use INR anymore to guide transfusion of plasma in acute liver failure, because they don't really tell you what is happening. You use plasmas during plasma transfusion, during whole plasma exchange for say in immune TTP to correct the ADAMTS13 deficiency. You can use for warfarin reversal, or you can use for factor deficiency. We use obviously the massive transfusion protocol. This is very standard in trauma. Whenever we expect that more than 10 units are going to be required in 24 hours, or more than 4 units are transfused within the first 1 hour, and the ratio is 1:1:1, and is typically used in transfusion protocol. And that's why I'm saying most of the American war hospitals are now transferring to whole blood to kind of make sure that this is kind of to overcome this kind of a problem of getting components all together at a particular time. There is inappropriate plasma use. We suspect, when you suspect a clotting factor deficiency, reversal of anticoagulation, we'll talk about why there are better one. Bleeding of unclear etiology, just because somebody's hemoglobin has dropped, surgeons will ask for plasma. Unexplained abnormal clotting tests. Again, you don't treat an INR, you treat a supratherapeutic INR in a warfarin patient only when they're actively bleeding. Even if the INR is 6 or 7 or 8, you don't need to treat it. Only about 10 INR in a patient on warfarin you need to treat. So again, as I said, if you have a specific thing like hemophilia, von Willebrand disease, then you can use it. For reversal of anticoagulation, the reversal agents PCC are much better, and unexplained, as the British Society, there's no evidence supposing the use of FFP for a non-bleeding raise in INR or APTT. So this is very, very clear. When we order, the plasma dose is always ordered by a unit. Dosing is typically matched to the number of units of RBC and platelet 1:1:1. Otherwise, it's 15 ml per kilogram. 15 to 20 ml per kilogram is a standard dose. There are, when used for therapeutic plasma exchange, you use it 1 to 1.5 times the total body volume. Types of plasma includes FFP, PF24 is what, as I said, which is used again in the American blood banks, thawed plasma and liquid plasma. The third one is the platelets, again indication for transfusion or treating bleeding, invasive procedures and prevent bleeding. We in dengue, I think all of us are at some point in time criminally liable for transfusing, even when, because depending on the status of the patient, we transfuse rather than actually the platelet count of the patient. And that's something, but again, the indications are very, very clear. Even in malignancies, it's very, very clear. The 10,000 is the go-to cutoff unless you're actively bleeding. So indications for transfusion are treat the bleeding, not the number. And that's the message, is that you don't need to worry about the number. And again, when you're doing invasive procedures, and the problem is the prevent bleeding. Can you, if your platelet is 22,000 with an AML, if you give platelets, can you prevent an ICH? And the answer is probably no. But unfortunately, we will all be at risk of doing it. The risk of bleeding does increase when the platelet is less than 50,000. Spontaneous bleeding occurs only when the platelet count is less than 10,000, is where the data. MD Anderson has got a huge subset. One of our colleagues is actually defending himself in a court of law, trying to say why he did not transfuse 22,000 K. And we use this data to say that it's okay not to transfuse till 10,000 K. And if bleeding is present at higher platelet count, if you're actively bleeding, then most of us would take 50,000. And if you're actively bleeding while on antiplatelet, we'll probably transfuse. Again, there's no data, at least in ICH, to transfuse even in the presence of antiplatelet. But if you're actively bleeding, yes, we will be thinking. Platelets for invasive procedures may vary depending on what procedure is it. For a central line in the subclavian, we'll use 50. IJ and femoral, we probably can get away with a little less. But again, there's no real numbers that I can give you for this thing. For central venous catheter, as per the AABB, that is American Association of Blood Bank, they say platelet count is less than 20,000. But most of us, as I said, would use a little higher, especially if you're using a non-compressible site like a subclavian. But if you're using a compressible site, then 20,000 is okay. Lumbar puncture only if platelet count is more than 50,000. And major elective non-neuroaxial surgery, the platelet count is less than 50,000, then only you transfuse that. Platelets to prevent bleeding, as I said, for platelet less than 10,000 in oncology patients, higher if other bleeding risk factors such as fever, sepsis or ECMO circuits are being used. Again, platelets are ordered from donated units. One apheresis units, which is a standard practice in America, which is a single donor platelet, should raise the blood platelet count by about 30 to 35,000, 40,000. And platelets are generally ABO and RHD compatible. Further cross-matching is not required. So platelets are very easy to get because you don't need to have to waste time for it. There are other approaches which I'll just touch on for two things. One is cryoprecipitate, which contains factor 8, 9, 8, 13, 1 millibrand factor and fibronectin. One dose comprises of 5 to 10 units. In our hospital, it's 10 units and contains 2 to 2.5 gram of fibrinogen, which will increase the concentration by about 70 to 100. So we use fibrinogen in transfusion when your fibrinogen levels are less than 100 and you're actively bleeding. And 70 to 100 milligram per deciliter is the increase will happen with a dose of 10 units of this thing. These are the things which are obviously there. If you have a warfarin or a DOAC related bleeding, instead of using plasma, obviously the thing is 4-factor Kcentra, Octaplex or whatever is the brand that you guys are familiar with is available. It contains the inactive forms of 4 factors 2, 7, 9 and 10. And the FIBA, which is the factor 8 inhibitor bypassing agent, is used for dabigatran before the whatever the idorosumab or whatever is the reversal agent which is available for dabigatran, which is 6.5 lakh rupees. By the time you get that, you might as well get a FIBA into the patient to try to save the patient. Hemostatic medicines, tranexamic acid has, when we were in the residents and fellows, tranexamic acid had a very bad name. in the sense like it was you in trauma, it was considered that you will end up having an MI. But then the CRASH 2 trial came and then it said, okay, there's no increased incidence of thrombosis with this thing and there might be actually a benefit. And so the initial dose of 1 gram and followed by an infusion of 1 gram over 8 hours. But unfortunately, we continued for 7 days to ensure that the patient who had a traumatic SAH dies of a traumatic iatrogenic heart attack. But the dose is only for about 8 hours and then we should stop. DDAVP, again, cardiac surgical anesthetists, and they use a lot of epsilon aminocapric acid. DDAVP are used for basically for renal failure. It helps in that. And there are obviously certain antidotes. Obviously, the complications we just mentioned. So I'm going to finish on time saying that the data now is very robust for critically ill patient that we should not transfuse unless hemoglobin is less than 7. The cardiac risk or a cardiovascular high risk or a recent angina, the MINT trial said maybe 9 to 10 might be better, but we now know that it is not true. So the American Association of Blood Bank says 8 for people who are actively having cardiovascular disease, and otherwise plasma, otherwise for orthopedic surgeries, every other surgery, restrictive transfusion, that is keeping between 7 to 8 gram per deciliter is work. And the top trial that I showed you just now very categorically said there's no risk of cardiovascular events in non-cardiac surgery if you keep the hemoglobin less than 8 gram per deciliter. And so the message is 7 to 8 is the goal that you really want, but you want to transfuse the patient in critically ill only when it's less than 7. Plasma is only indicated during a massive transfusion protocol or with active bleeding in DIC or in plasma exchange. And platelets are to be transfused only for either a procedure or prophylactically only if it's less than 10,000. Thank you very much for your kind attention.
Thank you, sir. Very lucid talk. I just had a question, sir. In the massive transfusion protocol, as we know, 1:1:1. What is your take on 1:1:1 considering cryoprecipitate? Should you give it or you should check the levels first? That was my question.
So if you give most of the data on giving cryo without looking at it as far as is not really available that I am aware of. So in transfusion, if you want to add cryo empirically versus checking the fibrinogen level and then doing it, or this thing, I think because plasma does contain some amount of fibrinogen levels, which will be okay. So I don't think the recommendation is there for doing that as of now. So we either end up doing a, like say whenever you do a what we call as a coagulation profile extended, we have a fibrinogen level, so it makes it easier for us to do it in a tertiary care hospital. But I don't know whether in a periphery, in a trauma active bleeding, should you add a cryo? I'm open to suggestions. I think it's an interesting question, and I think maybe is my answer.
Fibrinogen levels are not frequently available. It takes almost 2 days to get a report. So
Correct.
I think it's very difficult to
Correct.
get.
So that's why it depends on where you are.
Yeah.
So for us, it's an instantaneously within an hour we'll get it. But for a non-tertiary care hospital, it might be a different issue.
So another thing is, what are the transfusion triggers at present for a patient who's admitted with malignancy for any other reason?
For malignancy, is a critically ill patient, even with sepsis, whatever reason, the hemoglobin is 7, platelet less than 10,000, and nothing else. You don't check an INR. If you are suspecting DIC, then you do that, and then the INR goal should be less than 1.5.
Any other questions from the audience, please? We can take.
I wanted to know, sir, what is the role of vitamin K in a non-hepatic patient?
No, vitamin K is a nutritional deficiency. So if you're nil by mouth for more than 7 days, so what happens is we would give 1 milligram as the drops through that as a nutritional supplement. But otherwise, again, the problem with vitamin K, it's an extremely long acting. Once you give it, say a 10 milligram dose, which is a elephantine dose, it will make you very thrombotic for quite some time. So you have to be careful as far as that is concerned. So no, in a if you're not suspecting either a nutritional deficiency of the liver synthesized vitamin factors, then there is no point in. If you're going to use it, it is 1 milligram orally is what the nutritionist in US would do, is to give every 7 days. Somebody is on TPN, they'll give 1 milligram of a nasal drop of vitamin K in these patients. That is a nutritional supplementation, but not a 10 milligram IV as a regular for a non-bleeding patient. But for emergency active bleeding, reversal of this thing, again, for if you have a mitral valve replacement and you are now a supratherapeutic INR, we strongly recommend not giving vitamin K because then it takes you 10 days afterwards to get back to therapeutic INR. So you come in with a 7 and you are not bleeding and you give him FFP, it's all right. But if you give him FFP plus vitamin K, he goes back to 1.5, then for 3 or 5 days the valve is at risk because you cannot get it up.
Right.
So strongly recommend not going up on vitamin K for any condition. If you have to give it 1 milligram, that's the max.
Yeah, that's what I wanted to know in pre-op patients especially. Thank you.
As a role of romiplastin in case of sepsis-induced thrombocytopenia is
Which one?
role of romiplastin is there any
I know. There's a lot of people are, again, these are all agents which are being adapted from outpatient practice to this thing. So is it a sepsis-induced immune thrombocytopenia? And maybe there might be some role for that. But again, there's no data as of now in critical care medicine to say whether it will help you or not. Sheila, what about your experience in hematology? No, I don't think any of us have any experience doing that.
Any particular guidelines which have said the use of TEG and ROTEM as transfusion triggers when we are transfusing? Any of the guidelines, does they mention that those are compulsory, especially?
So what most of the thing is like, it's like using advanced hemodynamic monitoring. So when your clinical regular testing is not able to give you a result, these tests are to be utilized. So in liver disease, a very strong recommendation, post liver transplant, major surgery where there's a risk of, where there's a significant bleeding and transfusion happening, the indications are very, very clear because you get a composite picture for using TEG or ROTEM. So it is like but again, the facility, if it is available, it should be used on a routine basis. Not on a routine basis, but on a routine basis in high risk surgery is what would be the recommendation, or liver failure and liver transplant patient for sure.
Fine. So thank you, sir. We come to our next session now. We all know India is an emerging and growing in the field of extracorporeal life support modalities like ECMO. The technology is available in select centers, outcomes are improving, and awareness and training programs are also been increasing. However, with wide scale access, there is a problem with multiple problems like equitable distribution and funding, the regulation. There's not much nationwide data. So to throw the light on this topic, may I call upon Dr. Ajit Kumar sir. He's a lead consultant in critical care medicine, Astor Whitfield Hospital, Bangalore. He's a lead consultant on critical care medicine. His major achievements are Vice Chancellor, Indian College of Critical Care Medicine, past Secretary and Accreditation Secretary, Indian College of Critical Care Medicine. He's a past Chairman of ISCCM Bangalore chapter, current Treasurer Association of Medical Consultants Bangalore. He's editor of StatPearls Medical Database, USA. Sir, over to you.
Thank you. So the topic is extracorporeal therapy. Where do we stand? Basically, it's a very, very vast and exhaustive topic. And my only concern at the moment I depicted here, the time is an issue because completing in 20 minutes is going to be extremely challenging. And I'm worried that I may have to talk much faster. So I'll be just going through the quick review of current ECD modalities, evidence-based discussion, quick, and explore future reduction and directions, and finally take home. So obviously we have a single organ failure or multi-organ failure because of various reasons, from infection to sepsis to CIRS to major surgery, trauma, shock, and big list. I don't want to read that. We all know that. And we all know that, when you have with the intensity and the severity of, the organ dysfunction, whether it is number also increasing, obviously the mortality is going to be high. And, the extracorporeal therapy by definition is a process where the blood is taken out of the body, treated outside and then returned to the patient. So predominantly, the extracorporeal therapy, what we are using is for clearance, as we do for dialysis, and gas exchange, as we do for ECMOs, hemodynamic support, supposing we go for a V ECMOs, etc. And obviously, sometimes you try to remove the toxins and inflammation by extracorporeal circuit. So what we are doing is, we are trying to buy some time for the native organ recovery, or it's a bridge to transplant. So extracorporeal therapy spectrum, just quickly seeing, because I can say that maybe renal, intermittent hemodialysis we all know, the SLED we all know, the CRRT, all of us do that. Respiratory, maybe VV ECMO, obviously extracorporeal carbon dioxide removal, and cardiac and cardiopulmonary, VA ECMO, the tandem heart, and liver support systems are also definitely evolving. It's MARS and DP MARS. And toxins inflammation we have in a hemoperfusion system, hemoabsorption system, we have Plex and all, which I will be coming to my coming PPTs. Coming to extracorporeal renal support, because we all know that, I want to go faster. The transport mechanisms, we know the diffusion, ultrafiltration, convection, and absorption. The diffusion is the process where, the solute with a higher concentration is going to a lower concentration, moving to lower concentration to a semi-permeable membrane. So naturally, the solute in a dialysis, intermittent dialysis machine will be the smaller solutes. And ultrafiltration is the process where the water is removed. And when you talk about water removal with the intent of removing the solute, more solute clearance, like the solvent drop, we call it a convection, and obviously absorption is again one insignificant process which can sometimes help even in dialysis. And obviously, as I mentioned to you, the smaller mole solutes are definitely less than 500 Daltons removed by the dialysis, like sodium, phosphorus, potassium. The smaller molecules are definitely by the routine dialysis. Obviously, when you go for the continuous veno-venous hemofiltration or continuous CV, VSDF, naturally you go for not only the up to 1000, the 500 Daltons, you go for bigger molecules. These middle-size molecules are predominantly the inflammatory mediators in sepsis. So this could be one reason, maybe if you go for a continuous renal replacement therapy, there is a possibility that these middle-sized molecules are removed, and the patient is likely to have a clinical benefit, which is again debateful. And obviously, sometimes you do the dialysis part, for the removal of certain toxin. I don't have to read out of everything. Different alcohols, medications. There's a big list of medications we all know, which has already been mentioned there. And obviously, technically, we have intermittent hemodialysis, SLED, and CRRT is there, because CRRT most of the time we use. Definitely, I believe that, at this point of time, we can only say that the patient who is hemodynamically unstable, and you have any kind of patient who is having you have a concern regarding the ICP. These are the conditions which can be strongly recommended for CRRT at this point of time. And obviously, CRRT, there is something called effluent volume. You need to calculate that, the CRRT dose. There are two major trials which are coming in this is the renal trial and the ATN trial. The ATN trial has shown that if you go for a higher level of removal, the CRRT dose, higher removal, it can even increase the mortality. But what I mean to say is that based on these trials, the renal trial and the ATN trial, what has been shown is that the ideal dose of CRRT by the kidney disease improving global outcome is around 25 to 30 cc per kilogram body weight. Per kilogram body weight per hour. That is what I want to tell you. And obviously, this IVOR study, we all know in septic shock, which I mentioned to you, because the middle molecules are largely removed by the continuous filtration. And when you go for higher filtration, whether it's going to make a difference in the mortality and morbidity, it has been shown that there is no differentiation between higher CRRT dose and even a lower CRRT dose. And obviously, there is another meta-analysis which I don't have time to read that. But again, in 2020, it has been shown that there is no difference that you go for the volume of CRRT is not going to make any difference to the patient's mortality. And coming to the anticoagulation, but the only thing I want to tell you is that when you talk about the CRRT, the kidney disease improving global outcome is strongly recommending regional citrate anticoagulation, which most of us, including myself, we are not using that regularly. And obviously, because it can reduce a lot of interruptions which can happen in CRRT, a lot of bleeding manifestation. It can be used in patients who are recently bled or maybe actively bleeding to many extent. So the current recommendation for this dose is regional citrate anticoagulation for all CRRT interventions as per the KDIGO. Obviously, another meta-analysis again it is showing that there is there is a superiority of regional citrate anticoagulation for CRRT. Again, one Indian study again showing that it has come in 2025. That's when nephrology, the Journal of Indian Nephrology, Indian Journal of Nephrology again, the regional anticoagulation is more superior to CRRT patients for anticoagulation. Again, regarding starting off, the initiation of dialysis, I don't have time to read everything. There are various studies are there, Align study, Akiki study, Idealize study, STAR-AK study, START-AK study, Akiki 2. All these studies, except for Align study, all the studies have shown that there is no benefit of very early initiation of hemodialysis, renal replacement therapy, except for you have some kind of acute and life-threatening complications are the type of complication when we initiate dialysis in our regular practice. This is the EKG2 study which has come in AGM. Again, among critically ill patients with acute kidney injury, accelerated renal replacement was not associated with a lower risk of death in 90 days than standard therapy. We all know that. Again, in a Vermont meta-analysis, which I'm just showing you, again, it has come in, the Clinical Kidney Journal 2022, again, it's showing that, there is no difference in mortality if you go for a very early, this one. Again, one more, this one I am showing that you can see that the product float, there is no, the diamond is definitely the central, there is no difference in treatment. And coming to the lung, heart and heart-lung support systems, we have the VV ECMO, because I cannot read all the indications. I will roughly say the severe refractory hypoxemia, we do that. And obviously the initial major trial was the CESAR trial, where patients referred to an ECMO center had a better outcome. And obviously there's been so many flawed designs in the system. You know that many patients who have been referred to the higher centers where no ECMO centers or not even ECMO was put. And maybe the ECMO center with those centers, higher centers maybe having more expertise in the management of ARDS, but that could be the difference in mortality. Subsequently, the EODIA trial, which has been failed to show any mortality benefit between ECMO and the conventional ventilation, ARDS ventilation, in the outcome. But again, this is a very interesting trial because around 28% of the patients have been, there's a crossover has happened. And obviously, I would like to say that around 35 patients went to from the regular ventilator, this one crossover to the ECMO group. Of the 35 patients, almost 25 have survived. What I mean to say is that, though the EODIA trial may definitely say that there is no difference in mortality when you compare when you compare ECMO with the conventional ventilation, but the ECMO in severe hypoxemia, ECMO did save life. That's what I want to convey to you. Again, nowadays there is a lot of research of the posterior, the Bayesian analysis. The posterior probability analysis are coming a lot. Obviously, that time itself, after the ad hoc analysis shown that there is some benefit for ECMO. I mean, with that, again, there is a Levina Munchi again, but meta-analysis again, something like 2019 shown that the ECMO is definitely going to have a mortality benefit, though there is a risk of bleeding. Again, about ECMO and proning in ARDS, ECMO with proning has not been known to have any kind of a mortality without ECMO, without proning. And obviously, it is again extracorporeal carbon dioxide therapy. Every patient who is having a carbon dioxide more than 60, these patients are put on extracorporeal carbon dioxide removal, and they found that there is no difference in mortality and any clinical benefit when you regularly just remove the extracorporeal carbon dioxide in these kind of patients. And it's already mentioned there. Sorry, yes. So coming to the VA ECMO, so obviously we know the indication, we know that we are receiving a cardiogenic shock of any origin, we use for it. Obviously cardiogenic shock is almost always associated with pulmonary edema, we do that. In my practice, I just want to highlight one thing. It's about aluminum phosphate processing, because previously, maybe around 10 years ago, it used to be extremely challenging. Nowadays, we are also getting more and more good results, in a VA ECMO. Aluminum phosphate, that it can cause myocardial necrosis, and obviously shock will be there. And if you treat the patient at the right time, preferably within 6 hours, the outcome is going to be more. This is a meta-analysis which has come from Morocco. It has been shown that there is some definite difference there in the mortality. Again, one more article, this is in 2016 observation study. Based on this, the outcome depends on the initiation of the time of initiation of VD ECMO and the basal, the LV functions. And again, there is an Indian study, even after delayed presentation, in this particular study case report which is coming in the Indian Journal of Critical Care Medicine, even with 24 hours delay, this patient has been put on VA ECMO. This patient has got a patient could be saved. That's what the thing was telling. And survival on ECMO significantly changed, because at some stage people used to believe that ECMO is of no use, but after the COVID epidemic, in spite of all the negativity, one good thing which has happened is that ECMO has proved useful. In our own experience, we have around 50% outcomes even at this point of time. And generally, world over, I will say that VV ECMO has got a mortality, survival of around 55 to 60%, where the VA ECMO may be around 50%. That is the current stage where the ECMO is standing. Again, one more paper, I don't have time to discuss. Again, this is showing that one of the studies, this study has shown that, when you do an ECMO on a higher volume center, rather than a lower volume center, and you go for, early initiation of ECMO, before the organ, when you have an indication, without further delay, without the onset of further organ failure, you do the ECMO, it is going to, the outcomes are going to be better. And obviously, I cannot, just to avoid ACPR, which is increasingly used, at least in some centers in India, I would like to say that, because the patient, there are major trials out there. These are the 3 major trials: the ARREST trial, the PRAGUE out of hospital cardiac trial, INCEPTION trials. These 2 trials, whatever it has been shown, obviously they have shown that at least some group of patients can be definitely saved with the neurology intact. That is one thing these trials have shown. Another major important message from these trials is that if you use the ECPR, a non-shockable rhythm, it's of no use. That is one thing which the trials are proved. Obviously, we can discuss so many things, but non-shockable rhythm, if you do ECPR, are fast. But again, these patients can be saved. Some of the patients, though, maybe the number may not be very great, but still these people can be saved with the intact neurology. That's what the ECPR has shown. And in South India as well, because a couple of hospitals are starting, putting the patient affordable so-called corporate hospital. Obviously, they are putting the patient on ECMO after 10 minutes of CPR. And obviously, another important extracorporeal support nowadays is organ retrieval, because patient is having cardiac arrest. You suddenly put the patient on ECMO. So the problem is, you can maintain you can have a regional normothermic hypoperfusion, some kind of local support. So these patients, the organ can be, you can keep safely intact for a long time. Retrieval time can be prolonged. And this is another thing, the organ retrieval, it is going to be definitely useful. That is another potential indicator for ECMO. And just for conclusion, I want to say that it's called ECPella, which has been increasingly used nowadays. ECMO has been used with a Impella. Impella is not extracorporeal device, but ECMO can increase the LV afterload, but Impella can reduce the LV afterload. In this reason, because in the US, some of the studies are routinely using, for high risk and angioplasty, coronary intervention, we are using this combination of ECMO with Impella, that's called ECPella. And in a tandem heart, I don't have time to explain, because this also can be left atrially, just pumping the blood to the right femoral arteries. And obviously extracorporeal toxin removal, because we have a lot of modalities are there, plasma exchange. We know the indicator for plasma exchange, there is no time to discuss more. And obviously hemoperfusion of the toxin removal is very, very important. The very common things what we have been seeing is the torrimixin, extracorporeal, the removal of polymixin and episode polystyrene fibers. You try to remove the endotoxin, or you use a cytokines by the cytosol. So basically, when you come to the extracorporeal removal, torrimixin, again, there is the very important thing, the initial trial was UFAST trial. This is a patient with severe septic shock for the intra-abdominal sepsis. After the control of the intra-abdominal sepsis, these patients are divided into two groups. One is with the support of the extracorporeal, what do you call this, endotoxin removal, torrimixin. Other thing without torrimixin. The initial trial was very promising. There was a significant difference in mortality, around 21% difference was there when the torrimixin was used and endotoxin was used. But subsequently, the Euphrates trial or the Abdomix trial, which is again randomized control trial, trying to prove any kind of benefit, and that is what it was. But again, this is some of the recent review about cytosorb and even about in other previous situations. This is around just 1 year old. What is generally showing that at this point of time there is no strong evidence. Evidence is extremely weak. Evidence is non-existent to recommend these modalities in the current practice of treatment. Just like Dr. Suresh was updating you, I want to update you one more thing. One new thing which has happened about extracorporeal endotoxin removal. There is a trial called Tigris trial. This Tigris trial, I think, is going to be released soon. So this trial, what I understand is that it has shown that there is a mortality benefit. But interestingly, just like any other trial, the analysis is Bayesian analysis. The posterior probability which is looking at that, I'm happy to discuss it if there is time is there. Again, the Bayesian analysis, this trial has shown that the extracorporeal endotoxin removal, the torrimixin, is going to be reducing the mortality. It is going to be FDA approved very soon. Obviously, initially the torrimixin was a Japanese product. We know that it is going to be there. There was a press conference was there a couple of days ago, because here the spectral medical and Vanji announces that the success has been there. So the posterior probability of the Bayesian analysis, this has been shown to be useful. That's what I want to convey you, and that's going to be there. Again, I cannot stop, just this discussion without just mentioning of HA230 filter, because which was recently introduced to me. I know people are using that. It's a resin absorbent kind of filter. What we have been using was that it has been a lot of applications. What we have been using for paraquat poisoning, because patients almost used to die without any kind of thing. That's been our experience. I had some couple of patients who said I've been 5 times in the ICU and finally passed away. These kind of things have been happening. But studies have been, there is an increase in evidence, even from most of the Chinese papers that are showing that 50% outcome is there, because when it's initiated within the first 6 hours and more than 6 hours, there is no difference in outcome. Even as an Indian study I could see in the literature, which are showing that the outcome is more than 6 hours, less than 6 hours, the outcome is the death is, mortality is significantly more. So this can be used. In my experience, we are used for 3 patients. They have been very early, 4 hours to 6 hours, and obviously 2 patients survived. It's too early to say, but I just want to give a food for thought for the audience to say that this is also one thing in HA230, this the so-called Jaffrin filters. These filters are available for Jaffrin filters. This is also another way probably it is going to be there in the future, which can be of some hope, in paraquat. And extracorporeal reverse support is again, rapidly evolving. We have the Mars system. We have, the deep Mars system. The Mars system is, molecular aggregation recirculation system, and DP Mars is basically double plasma absorption system, molecular absorption system. And obviously it has been used in acute liver failure, the kind of conditions. What I'm trying to say is that it has been known to reduce encephalopathy, it has been known to reduce the level of the bile salt, it has been known to decrease the level of ammonia. All these benefits are there. Though there is no mortality benefits, we could see in that. Though there is some kind of a recent trend in literature. I know that I don't believe in this kind of literature, but there is a recent trend, International Journal of this one, and even in chest, there is an increase in trend that these are going to be useful. There is an increased trend for a better, outcome, even mortality-wise also in these kind of, interventions. So again, this is all bio-artificial liver. The liver is kept, this artificial liver is kept outside the body. There are a lot of hepatocytes are there. This is going to be there. This is going to avoid the transplant, may not be there in the future. It's will be small, compact devices kept outside the body. It is, hepatocytes will be there. This is working like a liver. And even, this thing can happen. For example, if you look at that, even the kidney, the bio-artificial kidneys are very small. It's just like, within the thumb. It's just going to be released in another 5 to 10 years. Maybe even the transplant may not be required. These kind of patients. That is what is going to be there. And what are the challenges in implementing extracorporeal therapies? Lack of awareness, the lack of availability, economic constraints in procuring as well as treatment, evolving evidence, needs expert training and ethical dilemmas. For example, VV ECMO, you put the patient on VV ECMO, the patient is not improving, you already started, there is a lot of financial constraints, whether to continue or not, is it ethical or not, whether the patient is going to improve or not, it's very difficult to say, it's definitely going to be an ethical thing. And basically, what is the future direction? We are going for a smaller, mobile type of integrated devices. Automated closed-loop feedback system will be there for fluid balance, anticoagulation, gas flow. And when wearable artificial kidneys, bio-artificial liver, totally implantable systems. For small compact version of ECMO, it won't be that big, it may be small. These are going to work, outside the body. My take home is very simple. There is nothing very extraordinary. Extracorporeal therapies are increasingly used across the globe, either for a single organ support or multi-organ support in potential reversible organ failures or as a bridge to transplant. CRRT is the modality of choice for CRRT in patients who are hemodynamically unstable or having concerns regarding increased ICP. Initiation of renal therapy should never be late in potentially life-threatening acute kidney injury complications, though early or very early initiation prior to these has not been proved to be of clinical benefit. Early initiation of ECMO before the onset of multi-organ failure, that's very, very important. Once there is an indication is that you cannot wait for that, there is no waiting and watching. In high volume centers brings the best outcome in refractory life-threatening hypoxemias. And obviously nowadays there's a trend of the posterior approach is happening nowadays, because what I mean to say that the posterior probabilities, what is happening is a Bayesian analysis. I told you the two trials, the EOLIO trial as well as the Tigris trial. This is all based on the posterior, only the posterior probability analysis, the Bayesian analysis, where the analysis about the probability is on about the data. You see, basically in the frequentist analysis, what we are doing is we are studying looking at the data for the hypothesis. Where in the Bayesian analysis, you're looking for the hypothesis in the data. So there is a difference is there. Which is better, nobody knows, but there is a posterior analysis there. One major trial, even in critical care, which has been approved for the Bayesian analysis was the CMAP, the CAP trial, whatever, that's which I know that. In ECMO CPR, ECMO assisted organ retrieval and preemptive ECPELA, support for high-risk interventions are rapidly evolving. Early use of hematosome system, including HH230 resin episodic, gives a new ray of hope in paragut poisonings. Liver support system rapidly evolving across the globe, though we need further well-designed trials for a better conclusion of their efficacy. The future aims at small mobile integrated devices, wearable artificial or bio-artificial organs. Thank you very much for patient listening. So where we are standing, we are conquered so many things. There requires a lot of fine-tuning is required. Obviously, because there's always a better scope to do the things better. There are more and more organs are going to be supported. Thanks for listening.
Thank you, Ajit sir. The vast topic is covering in 20 minutes very difficult, but you have touched upon almost all extracorporeal systems. Over to chairpersons. If any.
I wanted to know your opinion about a patient on ECMO. Should the patient be sedated or should the patient be kept fully conscious?
So in our practice, obviously, we give a mild sedation. Most of the very minimal sedation will give just to see that the patient is comfortable. The patient does not require any sedation, we will not give anything. But
yeah, what is the need of sedation?
Any discomfort is there. If the patient is absolutely comfortable, we will not give anything. Any pain, itching, any anxiety, those kind of to reduce anxiety, pain, itching, whatever.
Unless the patient is in pain or patient is anxious, anxiety.
Unless it is required, we will not give. And paralyzing agents, and after the initiation, usually within first 24 hours, we'll stop the initial paralysis, whatever we are doing. By 12 hours, next 12 hours, we'll be stopping.
Initially, when you are putting lines, so that is important.
Sorry, madam?
Initially, when you are putting lines, so that time the patient needs to be a little
initially
sedated.
these kind of patients, they'll be in ARD, severe ARD as bad, so we are sedating, we are putting the ECMO, we are sedating. So that time the paralysis will be there initially, so that will continue for the overnight or 12 hours, then we'll stop the paralysis, but the sedation, minimal sedation will continue.
Okay, thank you.
Yeah, there's a question. Yeah, please, madam.
Sir, regarding the extracorporeal CPR, the ILCOR guidelines 2025, they have recommended that they should not be used as routine, but only in special considerations where the CPR is not effective. So your comment on that?
Yeah, so that's a very difficult to see. What I'm trying to say is that, I am not, at least in our hospital, we are not using extracorporeal CPR, but what I understand when I was talking to my friend in Hyderabad, in that hospital, they have been using that. And there the issue is that if the patient, in a witness arrest, you know the patient is arresting in the emergency. And if you don't do that, the people may be Googling and asking for, people used to call from US why the eCPR was not used. So basically, the only thing I can tell you is that, so there is a difference in neurological survival. There's a recent meta-analysis which has come in 2025, I think, Journal of Critical Care, where the survivors, the mortality was, 7 versus 14 survival. That means 7% of the routine thing survive, but in the routine CPR, and 14% survive in the eCPR. I mean to say the eCPR, I want to stress that it is eCPR with a neurology. You know what I'm trying to say? That difference has been maintained. So there is an evidence, and obviously whether this could be used on a community basis, whether we can recommend or not is a very doubtful thing, because it all depends on the individual preferences, obviously accessibility. And in those hospitals where it has been done, the issue is that obviously you should be very sure when the time of the CPR given. So if he is witnessing it, we immediately, the patient is in CPR and emergency, they inform the people to the ECMO team, the transport ECMO team will be ready. After 10 minutes, it is continuing. They automatically they're putting around the 15 French catheters on the artery and the 22 on the vein. And obviously they do that, and one practical thing what they're telling, the patient survives and the patient's family is ready to pay the bill. Patient don't survive, they won't pay. These kind of social issues are also there with that. And obviously, as you said, the non-shockable rhythm outcome is bad, and it is not at all recommended.
Yeah, I think we do agree, ma'am, with that. Ki standard recommendation for all cardiac arrest initiating a eCPR is not at this point of time is a standard of care. But in special situation where a young, otherwise healthy individual had a reversible cause of cardiac arrest and you are having a bridging to a recovery, and your center has all the facility, you have a eCPR team on board, you have to see that to believe. And this happened to me when I saw a patient who came to me in a CPR state. Husband was a doctor. The procedure was a oophorectomy extraction in a laparoscopic center or an infertility center. The wife collapsed. CPR was done by the anesthetist, transferred her. We were doing continuous CPR. After a few minutes, when we went back and told the husband, who is a doctor, that see, we have tried 20-30 minutes, it's not happening. He said, please do something. Doesn't matter. He was saying, put an ECMO, do something. I said, are you serious? And we initiated ECMO on that lady because that was at 10 o'clock. My surgeons were available and there was an arterial cannula guided through a guide wire. And that lady went home. After that, I believed that probably eCPR is possible. Not in all cases. In special circumstances, we have to see to believe. And we have been almost doing 25-30 eCPRs. Yes, it's not as great as always in the same way. We lost many. We had many complexities like that. But it is an evolving science.
CPR, we gave up and she woke up and she went home. So that is why evidence is important. So do not...
eCPR or CPR?
No CPR. We stopped CPR also and said 45 minutes, nothing happened, and rhythm came back, we restarted CPR and patient still survived. So what I'm trying to say is that anecdotes are good, but at the same time, the data you're showing is that for the logistics of doing eCPR in India, plus the fact non-VF, asystole, bradyarrhythmias, we have to take it with a pinch of salt. Young people, whether you do...
There it is strongly discouraged. Non-shockable rhythm is strongly discouraged.
ILCOR guidelines has got a strong...
My other question was, VA ECMO versus Impella for cardiogenic shock.
Sir, see, actually the ILCOR guidelines has got a strong indications for ECPR. It is a low flow time wherein within less than 60 minutes is considered. But it has to be considered mainly in high volume centers. I don't think like in India we have a high volume centers where you are already ready with prepared all the required gadgets, the personnel and everything. In abroad and all it is, you have even ECPR retrieval models. There are high volume centers where they have proper indications and they will put the patients immediately as soon as they come. But it is the low flow time which is very important. That is less than 60 minutes.
Thank you, Ajit sir.
Yes, yes.
Thank you, Ajit sir. Because of short time, we should move on to the next lecture.
Yeah. Since its first description in 1967 by Ashberg et al., ARDS remains a major cause of morbidity and mortality all over the world. The understanding of the management of ARDS has evolved dramatically from high tidal volume ventilation and routine use of steroids to lung protective strategies and prone positioning and extracorporeal support. To discuss the outline of the evolution of ARDS, who is the best person to speak on is Dr. Ashit Hegde sir. May I call upon him on the stage? As we all know him, he is the director of Department of Critical Care Medicine at PD Hinduja, and he's a teacher par excellence, and almost everybody knows him. He's a national figure in SCCM. Over to you, sir.
Thank you. Just major achievements. I mentioned nothing that I'm proud of, but they've changed it somehow. I don't know why. So we're going to talk about the evolution of management of ARDS, and in the earliest part of the 20th century, basically every patient who had come with bilateral infiltrates, it was thought that it was due to fluid overload or atelectasis. Nobody even thought about ARDS, of course, at that time, and it was only until this paper by Ashberg and colleagues in 1967 in Lancet that this whole concept of acute respiratory distress or ARDS was first described as an entity separate from fluid overload and atelectasis, etc. We all know that, and then of course in those days it was thought that you need to ventilate them to get proper blood gases. So in those days they used to be ventilated with high tidal volumes, high oxygen. As a result, obviously barrier trauma, VLI, everything was there. There are high mortalities because the aim in those days, at least in the earliest part, just after ARDS was discovered or described, was to get normalization of blood gases was thought to be paramount. But of course, towards the later part of the 19th century, 20th century, people began to question this approach, and then people began to describe the problems associated with mechanical ventilation. It was that time called not called VLI at that time, it was called respiratory lung syndrome. And basically there were papers which showed about the problems associated with artificial oxygen therapy and artificial ventilation. So actually then there were two papers that appeared in the NEJM in the late 1990s, which talked about so-called, first probably of the papers which appeared about the so-called protective strategies, one from Brazil, which showed that basically there, if you look at what was there, conventional ventilation until then was the lowest possible PEEP, tidal volume of 12 milligram per kilogram and a normal PCO2. But protective ventilation, what these people tried was a PEEP about, at that time they used the lower inflection point. They used a tidal volume less than 6. That time they talked about driving pressures even in early 1990s. And of course they used permissive hypercapnia and a higher PEEP. And they found that this basically achieved better outcomes. Whereas of course in the same journal, there's another article which said that the outcomes are not so great. They were probably the same whether they used protective strategy or not. So there was still some debate, but until of course then we had the landmark study, the Ardna study, after which probably all debate ended, which clearly showed that ventilation with low tidal volumes clearly improved mortality. And so after that, probably that's where evolution of tidal volumes has stopped. Because for now, for all of us, we generally tend to use 4 to 6 ml per kilogram of predicted body weight. Now, of course, this was comparing 6 ml with 10 or 12 ml. So we don't know whether the group in between where 7 or 8 might be okay. But at the moment, at least as far as tidal volumes are concerned, there's no more evolution. We all restrict to 4 to 6. Maybe we need to know some patients who might do better slightly high tidal volumes, or some people who actually might require even low tidal volumes. We're still not sure about all that, but this is how it is at the moment. So that's where the evolution of tidal volume ends. Then, of course, in the same Ardna study also showed that basically using a pulmonary artery catheter doesn't help. also showed that basically restrictive fluids probably are better than using liberal strategies in ARD. So those things also now there is no debate. Probably most situations, unless the patient is clearly volume depleted, you will probably use a fluid restricted strategy in patients with ARDs. Again, there's not much debate. That has not evolved beyond that. That's the end of the evolution about fluid strategies. By and large conservative, unless clearly there is some reason to give more fluids. Again, there was this, again around the same time, there was this article about neuromuscular blockers in ARDs. The first study was the accuracy study, which clearly showed improvement in outcomes with at least in severe ARDS with the neuromuscular blockers, cis-atracurium. There was another study published a few years later after that, which actually was a negative study, which showed there was no benefit in outcome when used neuromuscular blockers. So then, what was the main difference really in the second study with the negative study is that very few patients were turned prone in the second study. And now we know that if you want to turn prone, you have to paralyze patients. So clearly the second study, without proning, there was a little problem in that study. So basically still most of us probably, especially in these days when you're going to prone people, most of us will probably recommend, turning the patient prone, or paralyze the patient. The only thing, of course, the recommendations, one, of course, the ATS says that you probably need to use neuromuscular blockade, but the Europeans, they sort of qualify that you can use neuromuscular blockade, but don't use continuous neuromuscular blockade. That's the only evolution. You can use it, but you use intermittently and maybe use, and of course, by and large, I think both everybody is on the same page that you should use, especially in severe ARDs, especially considering proning, but maybe you should not be using continuous neuromuscular blockade. You only use it as required. So that's about the neuromuscular blockade. Of course, in the same 2013, there were two papers which said that we were trying to maintain this. In those days, the main thing was trying to maintain oxygenation without too much damage to the lung. So, of course, people were trying HFNO because, not HFNO, high frequency oscillation, HFOV. And it was thought in theory supposed to be, so this is one more example where everything that sounds physiologically sound in actual practice has usually worse outcomes. So HFOV sounded physiologically sound, you're using very, very low tidal volumes. You're opening up the lung into it made a lot of sense, but actually both the studies, the Oscar study which showed no change and the Oscillate study which actually showed increased mortality. After that, of course, that was the end of HFOV for ARDS management. So that went away out of the basket. And the same year, in 2013, was the ProSeva trial, which probably everything has changed after that. Probably that's a landmark. So we talk about ARDS management, we talk about before ProSeva and after ProSeva, because that's probably the real landmark, which has made things much, much easier for us nowadays. And clearly, we all know that extended proning clearly improved mortality. Now, there were many, many studies before this. I'm sorry, this has not come properly, but I'm sorry, but basically there were many major proning trials before the ProSeva trial. But all of them were more or less negative or very little positivity. So what were the main differences in the ProSeva trial which showed such a great outcome? One, of course, in the earlier trials, they were using much higher tidal volumes. They were using 10 or 12 kilos, so they were not using protected lung strategies. Second, they were using patients who were not that sick. Even at 300 PO to FI2 ratio, they were turning them prone. Three, they were probably proning them a little later in the day, later. And four, of course, they were using only 6 or 7 hours of proning, whereas in the ProSeva, they used patients who were much sicker, they did it earlier, they used tidal volume of 6 ml per kilogram, and they used extended proning, 17 hours. So this is probably what made the big difference as compared to the, the earlier trial. So now at the moment, that probably is what it is. So if you want to use it in patients really sick with the PA to FI ratio less than 150, use it as early as possible, use protective lung ventilation, and turn them prone as quickly as possible. That's where proning probably has now evolved. What about recruitment manuals? So these are all things that we do when we are desperate for oxygenation. When we have been, recruitment manuals are very, in the past, because our priority, to some extent, was trying to get oxygenation right. And quite often people used to use recruitment manuals. This was recommended. Basically, they used to give CPAP of 40 for 40 seconds, or used to do a step-up recruitment, different types of methods. But it was shown that actually recruitment manuals, actually prolonged recruitment manuals. Most of the recruitment of the lung occurs in the first 10 seconds. When you give a high pressure, most of the recruitment occurs in the first 10 seconds. If you prolong recruitment is beyond 10 seconds, probably the more going to be more hemodynamic imbalance, more instability rather than any benefit in oxygenation. So therefore, basically, if you want any recruitment, ideally, of course, you don't use them, but if you have to, maybe just a short recruitment manual is as good as a prolonged recruitment manuals. And most of the recommendation now, at least for as recruitment manuals, basically saying is no use of, as far as possible, avoid recruitment manuals. But if you are forced to, in a desperate situation, don't use a prolonged recruitment manual, probably certainly not more than 30 seconds. And probably if I would recommend just 10 seconds, because like I told you, most recruitment occurs in the first 10 seconds. After that is only hemodynamic consequences and no benefit with improvement of opening up of alveoli. So, but This is again one more practice which over time, especially because now when you are refractory hypoxemia, proning is so much easier. So all these other so-called salvage therapies like protein C, surfactant, nitric oxide, all those have probably now gone out of the way with time because we have learned it's become much easier. Refractory hypoxemia, just turn them prone. Reverse ventilation, all those things have gone because proning is so much easier and so much safer. So that is all now out of the way. It made life much simpler for us. One other thing, of course, I was talking about oxygenation, but more very important thing is what is the actual target for oxygenation? We know we want to correct oxygenation, but what really is a target in somebody with ARDS? Initially, of course, we talked about oxygen toxicity contributing to ARDS, so our targets for SpO2 were relatively lower. We were more conservative. We were accepting a SpO2 of 88 to 95, or even 88 was acceptable. So you use the lowest FiO2 to maintain a saturation of 88 or so. Even a PO2 of 55 to 58 was acceptable. But over time, this is one major study which showed that actually in patients who had hypoxemia, there was long-term cognitive effect if this patient was slightly hypoxic. Therefore, now our targets for oxygen are slightly more liberal, not very liberal, of course, but because you want to avoid long-term cognitive or functional deficits, probably what they say that maybe you can't only look at SpO2 because SpO2 is it's a wide range. When the SpO2 is 90, the PO2 could be anywhere from 55 to 200. You really can't, or to 55 to 120 or whatever. So once in a way you have to do a PO2, though of course it's not possible to do PO2, blood gases all the time, but at least once in a way, you need to make sure your PO2 is above 60 or 65. So it's slightly higher because like I said, the PO2 is less than 60. They have found that cognitive defect, long-term outcomes are really worse. So maybe now actually the oxygen targets have been slightly raised. So don't go only by SpO2. Once in a way, make sure you kept your PO2 above 60, 65. Not more than that. There's no point going above that. But at least this is what is mentioned. Okay, so because SpO2 has its own drawbacks. Of course, so this is only about oxygenation. So the one aspect of ventilation, of course, is maintaining oxygenation. But of course, probably the most important really is avoidance of lung injury because ultimately whatever we do, our main aim is not just oxygenation. The main aim really is to prevent lung injury caused by our ventilation. And so, of course, the one thing that we supposed to be adequate PEEP because on the PEEP on one hand, you want to open up the lung, you want to maintain oxygenation, but the second hand, you don't want to over-distend. You want to, basically prevent over-distension, prevent more lung injury. And of course, in the original ArtNet study, they compared high versus lower PEEP, and they said as long as you use 6 ml per predicted body weight and you kept the plateau pressure less than 30, it didn't matter whether you used high PEEP or low PEEP. So that is what it was thought about, that at that time, just use protective ventilation, doesn't use what PEEP you use. But then this study from Gatton only explained why this happens, because they say not everybody with ARDS is the same. There are some people who have got recruitable lung. Other patients do not have recruitable lung. The only ones who have recruitable lung will respond to PEEP. The patients who don't have recruitable lung will not respond to PEEP. In them, PEEP will probably do more harm than good. But if you only recruit the lung in patients with recruitable lung, the PEEP may be useful. But in a study, we are using PEEP for everybody. So you don't know, in some people that PEEP will do good, in some it will do harm. So the study will become negative. So actually, ideally, you should identify those patients who have recruitable lung and only use high PEEP in them. Other patients probably should not be using high PEEP. The problem is that at the bedside, to find out who are these patients who are recruitable lung really is the question. And unfortunately, that question still has not been answered completely to anybody's satisfaction. It is still something that is left a grey area. So many years, what is the best PEEP, how to set the best PEEP is still not evolved to a point that we know for certainty how to set the best PEEP. But your guess is as good as mine. So these are the ways in which you can measure. You can look at basically best compliance, best oxygenation. You can look at driving pressure change. You can look at all these ratios. So all of these are there. But still, like I said, nobody knows which is the best strategy for selecting PEEP. Depending on what you are comfortable with, you use your PEEP strategy. And this is in fact what these are the advanced methods. And this is in fact, there were 3 major studies, alveolar study, open lung study, and expiratory study. Basically, they show that in mild ARDS, clearly high PEEP is dangerous. So in mild ARDS, there's no question of use. In moderately severe ARDS, maybe high PEEP might help, but again, it might be better if you can identify those people who have recruitable lung, who are likely to respond to our higher PEEP, rather than blindly giving everybody with severe ARDS PEEP. But like I said, that is a problem we still don't have. The other problem now with high PEEP, now they found out, is basically high PEEP causes a lot of hemodynamic. We know acute col pulmonale, when we talk about acute col pulmonale, we normally talk about pulmonary embolism. But even high PEEP causes an acute col pulmonale because it increases the afterload of the RV. it can cause RV dysfunction, RV failure. So in fact, so whatever benefit in oxygenation is more than offset by the hemodynamic compromise caused by a high PEEP, which is one more thing. So now the new one more sort of paradigm now is not just protecting the lung, but protecting the RV. Don't use high tidal volume, don't use high PEEP, don't use recruitment manuals, because they might actually increase the RV afterload and actually cause right ventricular dysfunction and failure. So both, it's not just oxygenation, it's even hemodynamics are important. This is one more reason why probably high PEEP with time is going slightly out of the way. But and if you want to use it, of course, there is, so this is what the recommendations, like I said, the Europeans have said there is no they don't know what to do. But the American authorities is slightly more pragmatic. They've said that basically moderate ARDS or severe, mild ARDS, no high PEEP. But in severe ARDS, you can probably use higher PEEP. Now, how you use a higher PEEP? You can use the ARDS net table, or you can use the best oxygenation, or you can use the best driving pressure. Nobody knows which is the best one. But obviously, if you're using high PEEP, you need to monitor the RV function, to do echo seriously, to look for evidence of RV dysfunction, and then see whether really high PEEP is beneficial. Of course, then there was a study called, which looked at the phenotypes, which looked at in ARDS, they're supposed to distribute, depending on so many biomarkers, they divided them to a pro-inflammatory and hyperinflammatory and the hypo-inflammatory phenotype, and they found that the hyperinflammatory phenotype probably will respond to steroids, whereas the hypo-inflammatory steroid, to high PEEP, and to steroids and also to simvastatin, they will also respond to conservative fluids. But the hypo-inflammatory phenotype will not respond to high PEEP, they will not respond to steroids, they will probably require a liberal fluid therapy, and they may not require a SIP. So this is something that is in the future. We've still not been able to, at the bedside, been able to separate them so easily from hypo and hyper, but it's happening. So sooner or later, we'll have a better way of finding out who is hypo-inflammatory, who is hyperinflammatory, and then be able to adjust our strategies accordingly. So this is one thing that will happen probably in the near future, subtyping them. The other thing that probably is very important, but unfortunately has not yet been caught on, is this concept of, looking at esophageal pressure, looking at alveolar pressure, transalveolar pressures, because that's really, really important. That's important. We all looking at absolute pressures, but what is really important is the transalveolar pressure. Because in a patient, like I said, both of these patients have the same plateau pressure of 30, but the patient was spontaneously breathing, making acute inspiratory of 15. His transalveolar pressure is airway pressure minus pleural pressure, which is 45, which is dangerous to the lung. Whereas the other patient who has got a thick chest wall or a burns or something of that sort, his pleural pressure is 15. So actually his alveolar pressure is transalveolar pressure is only 15. In them you can safely increase tidal volume, you can safely increase PEEP. But we don't look at that, we only look at airway pressure. So this is something that probably we need to think about a little more. Unfortunately, measuring esophageal pressures is a little difficult, expensive, which is probably why it is not caught on. But at least in patients where we think that the chest wall compliance is not likely to be the same as, like somebody with obesity, somebody with some burns or some pleural effusion or whatever, or somebody with the intra-abdominal distension, hypertension, etc. We really need to think about chest wall compliance, because there, that alveolar pressures, the transalveolar pressures might be actually low. And so in these patients might actually tolerate a higher tidal volume, higher PEEP, etc. We need to think about, unfortunately, some of this concept of transpulmonary pressures is still not caught on, so it's a very, very important concept, which unfortunately I think people need to catch up on. Driving pressure, like I said, driving pressure is supposed to be this famous landmark study from the NEJM said that driving pressures, which is plateau pressures minus PEEP, actually is probably a sort of an indicator of the compliance of the lung. It depends on how much of the baby lung is really there. That's the only thing that you need to know. And they found that targeting plateau or driving pressures probably can make outcomes. So this is something that has not been proven beyond doubt. But overall, more and more there's evidence that if you keep your driving pressures low, outcomes will get better. So this is something that we need to talk about, driving pressures. And of course, now more and more it's happening that whatever you do in mechanic, there's something now it's not just driving pressure or not just PEEP, it is called mechanical power. Ultimately, you're blowing in air into the lung, you're delivering energy, you're stretching the lung. This is called mechanical power, and what this mechanical power is supposed to be causing damage to the lung. So that depends upon the peak pressure, the driving pressure, the respiratory rate, everything is contributing to lung injury. Ultimately, you've got to ventilate the patient somehow. So, but whatever you do, they say, if the peak CO2 is going up, you increase the rate, even that causes more power. You increase tidal volume, that causes more power. So this is a simple formula for calculating the power, which is basically delta driving pressure plus respiratory rate. But what that says basically is that the driving, both the pressure and the respiratory rate increase the mechanical power and cause more lung damage. So we thought that, so if you use low tidal volumes, lower rates, PCO2 will go up. You could probably remove the PCO2 by using ECCOR. But Dr. Ajit said that the trial of removal of carbon dioxide was a negative trial. So actually then what do? That means we know that, however you ventilate them, you're causing lung injury, whatever you do. So therefore probably that is why probably more and more we are going towards extracorporeal. I think that's probably only the safe way. Probably in the future, if you get better ways of doing an ECMO, simpler ways, probably ultimately you probably won't even intubate patients. You will probably just put them ECMO because that's probably the only safe way of ventilating somebody with ARDS. No tidal volume, no respiratory rate, nothing else. Of course, the problem now is the cost, dangers of ECMO. But like Ajit said, it's going to evolve in the next few days. Next few years, you might have, not next few years, but sooner or later, you may just have patients straight with a ECMO, no intubation at all. That's probably the only safe way of ventilating patients. Of course, we had the two trials, the Caesar trial and the Eolia trial. Though they showed no change in outcomes, we know there was a crossover rate. Ajit talked about the problems with the trial. So clearly, that's going to be the future once ECMO becomes a little more, easy, cheaper, etc. I think that's going to be the future. That probably is going to be the only safe way we can ventilate anybody with ARDS. And these are the traditional indications, but probably, like I said, as it becomes cheaper and simpler, your threshold probably is going to be coming down. And finally, of course, we also need to look at the impact of ARDS. The study showed that patients who had ARDS had lots of other problems even after discharge, which is probably why management of ARDS doesn't remain only to the ICU. You need to manage them even after their discharge. That is why we have this so-called post-ICU care. One of the main things is this particular paper, post-ICU care clinics. So this is basically just in a nutshell how ARDS, the management evolved. So first you accepted, everything normal gases, which obviously cause more harm. Then you talked about permissive hypercapnia, and you used low tidal volumes, and so it was a little better. But over time, basically, we have been getting more and more protective of the lung. But now we also look at RV protection. So this is the sort of our priorities are changing, not just lung protection, we're also going towards RV protection. But like I said, eventually, however we ventilate, there is no absolutely safe way of ventilating. Ultimately, I think we just have to hope that we get a better ECMO. Thank you.
Thank you, sir. As usual, Dr. Hegles has taken a topic very well. He has covered almost all aspects of ARDS in a nutshell. He has discussed
what about... not covered? You said almost.
Almost, sir. Almost. Everything is covered, sir. ARDS is an evolving science in the last 3 decades, I am seeing. Something new is coming, the old is going. So, nicely taken, sir. We are talking about low tidal ventilation, use of neuromuscular drugs, HFO is out, ECMO is the best modality. So, everything is covered. So, if any questions, welcome.
Sir, just I wanted to ask, sometimes you get the patient who are having pneumonia and they are recovering, and then later on because of hyperinflammatory subtype, they are again going into the secondary ARDS kind of thing where they are having very high mortality. So is there something we can do about finding this kind of subset by regularly monitoring the IL-6, CRP or any inflammatory marker? Is it recommended along with the procalcitonin?
Not at the moment. I don't think any way, because you can do only one marker. The IL-6 may be high, but even the anti-inflammatory markers may be low, may be high. So you don't know what the balance is. No? You just looking one marker in isolation doesn't.
But the multiple markers may be the.
That's what I'm saying. Then that's impractical at the moment. No? That if you look at the study, the phenotypes at the bedside to do all of that, very crudely people do CRP. Some people look at lymphocyte counts and all that. But that's really at the moment, like for pneumonia, just pneumonia, community acquired pneumonia. The people with the community acquired pneumonia with the high CRP probably do better with steroids than the ones with the normal CRP. But that's just a very crude and a very simplistic way. But
high PEEP versus low PEEP. And you say that the lung which is recruitable, those patients respond well to high PEEP.
Yeah.
So you should do recruitment management all the patients first to.
No. Okay, that way. You see, if they improve with the recruitment manual, maybe
then only
that's one way of finding out. Yeah, but how you do a recruitment? Yeah, if the problem is that what do you look at when you do recruitment? Whether you look at improvement in oxygenation. So that's the whole problem is because sometimes oxygen might improve, but the compliance, hemodynamics get worse. So that's the whole problem. So what do you look at when you do a recruitment? But yeah, some people used to do that patients who have a recruitable lung oxygen improves dramatically, yes, maybe they will respond better to a higher PPS. Early ARD is supposed to respond better. Extrapulmonary ARD is supposed to, all these are all broad but not hard, fast rules. Certainly early ARD definitely would respond better to a higher PEEP.
So you want to say that high frequency oxyventilation is out of treatment?
Pardon?
HFNO?
Yeah, of course. Nowadays, I didn't talk about that because maybe that's what the almost I didn't cover, but the NIV and the HFNC. But because we have trials now which show that most, though classically we use it for the other conditions, but if you're using it for ARDS, not in severe ARDS, no question, but maybe moderate or mild ARDS, definitely use a trial of HFNC ideally, not NIV, HFNC ideally, but not available, you try NIV. But again and again, it's got to be a closely supervised trial, and you have to recognize that it is failing. Don't flog it if it is failing, just cut your loss and intubate. But certainly not for severe ARDS. If PO to FRD ratio less than 200, I probably wouldn't.
Any questions
but
from
in
audience?
tropical illnesses, maybe even severe ARDS, sometimes I do because they respond very quickly. It's only for the tropical illnesses, not different. That's one subset of even severe ARDS. Sometimes I might try NIV, but other ARDS, no.
So any questions from audience? If there are no questions, we'll move to the next topic.
Thank you.
Thank you, Ajay.
Thank you, sir. The next topic is also a very important one. While intubating a patient, we have this knee-jerk reaction of just looking at the anatomy of the airway and the face, and we try to intubate, and then many times we crash because we have not considered the physiology of the patient. So, to talk on this important topic about the physiological difficult airways, I would like to call upon Professor Shaila Nayanam Maitra. We all know her as a professor of the Department of Critical Care Medicine at Tata Memorial Hospital, Mumbai. She is the past president of ICCM. She has multiple articles in index journals, and she has also contributed to the surviving sepsis guidelines. Over to you, ma'am, please.
Thank you very much for that kind introduction. Good morning, everyone. And it is indeed my great pleasure to be here back in Nagpur. And thank you very much for the kind invitation. I thank the SCCM of Nagpur, especially Dr. Ganjay and his entire team for inviting me, and also Dr. Jeswani and Dr. Chafri and the entire organizing committee of the meeting. So thank you very much for the invitation. I bring you greetings from the Tata Memorial Hospital. I'm going to be speaking about beyond anatomy and the challenges of the physiologically difficult airway. Now, a lot of you are physicians, so maybe this talk may be quite relevant for you, but also for anesthesiologists, because airway management is always looked at as something anatomical. You're just trying to get the tube in somehow, intubate the patient. A lot of physicians say just call the anesthetist and get the tube inside, right? But critically ill patients have what we call a physiologically difficult airway, and this is not a new entity. It's just that we have defined this and made people more aware of this in recent times. So I'll start with a clinical scenario. Okay, 57-year-old male, okay, acute hypoxemic respiratory failure, he's delirious, uncooperative, he's on BiPAP, saturation is 80 to 92. Airways examination, of course, is not possible, he's tachycardic. Blood pressure is 140/70, okay. Fasting status is unknown, and labs are grossly within normal. And of course, you will in this kind of patient go in for a rapid sequence intubation. And everything seems good. You've given propofol to this patient, 100 milligram. Rocuronium was given. And video laryngoscopy guided intubation, very nice view of the cords, and end-tidal, you get a nice end-tidal CO2, and you've confirmed that the tube is in, and you're really very happy because you've intubated this patient. So you're very happy, good to go, you go to the next bed, and the next thing that you see is that the patient's blood pressure is 80/40, EtCO2 drops from 30 to 15, and you push some ephedrine or some other, vasopressor, patient becomes pulseless, and you initiate CPR. Of course, it's not so dramatic always. Sometimes you just see profound hypotension. But this is a patient who has a physiologically difficult airway. And I'll talk about this. But to contextualize it, first I'll talk about the landmark study in airway management in critically ill patients. And that's the INTUBE study that we published in JAMA. And I was very proud to be the co-PI of this study. And this was led by the Italian group. And what this study did is, until this period, we had data on how patients were being intubated, critically ill patients were being intubated, and also complications, but they were largely national audits or single center studies. This was the first study that looked at real world data, and it didn't just look at patients from the developed world, but also patients from the developing world. And as you can see, a large number of centers, and many of you participated in this study, actually came from India. So 3,000 patients from 29 countries. participated in this study. So we had real world data also from the developing world, which is really, really important. Now I'll just give you a little snapshot of this study in the interest of time. So what we looked at is in these intubation and critically ill patients, within 30 minutes, okay, what was the incidence of these complications? And it was a composite of severe hypoxia, cardiac arrest, or cardiovascular instability occurring within 30 minutes of tracheal intubation. And if you look at the primary endpoint, 45% patients had a complication. That means 1 in 2 patients in whom you do a tracheal intubation has one of these complications. And what was the real surprise finding was that it was not hypoxia that we are all worried about. It was actually hypotension. Hypotension occurred in 42% of the patient. And this was the first study that revealed that in critically ill patient, it's not the hypoxia. That was only about 9%, cardiac arrest was 3.1%, and this was consistent with the data. So perhaps over time, we have become very good at peri-intubation oxygenation, and it's actually the hypotension that we have to keep in mind in critically ill patients. And this is also an important message for the anesthesiologist, because we always think hypoxia and we don't think hypotension. And a very important finding from the Intube study was that it was the first study that showed that this complication that occurred immediately after intubation has an impact on 28-day mortality. So usually you have some hypotension, you give a vasopressor, you have hypoxia, you reoxygenate the patient and you think you're fine. But if you have this complication, this has an impact on 28-day mortality. So it's not just about treating, but we have to try to prevent these complications in these cases. So I come from a background of anesthesiology and now I do critical care. Sometimes I go into the operating room as well, and I've always wondered, why are complications with tracheal intubation so high in critically ill patients? So in my mind, there are 3 fundamental differences. If you look at the ICU environment, and I'll show you a picture in a bit, the operator factors, varied levels of experience, it's a multidisciplinary specialty, and most important, the patient factors. And this might itself trying to intubate a patient a while back, and this is, you just trying to intubate a patient, getting to the head end of the bed is such a struggle in the intensive care unit. For those of you who work in the operating room, this is not the situation in the O2 where a very controlled condition. Lot of clutter around, this can be any time in the night or day. I don't have all the tools that I have in the operating room in my armamentarium. So this very complex environment makes tracheal intubation very challenging and increases the risk of complication. And most importantly is the patient factors. This is not the fasted, optimized patient who comes for surgery. This patient often has an imbalance between oxygen delivery and consumption, and you're already starting with a disadvantage in these patients. And these patients, like the one I showed with the case, have what we call the physiologically difficult airway. Now, this was defined not too long back in 2005, by John Sackles, and from the emergency department, this term came, the physiologically difficult airway, and they highlighted this entity and said that we should look at alterations, physiological alterations, like hypoxia, hypotension, right ventricular dysfunction, metabolic acidosis, etc. in these patients that increase the risk of complications during positive pressure ventilation and transition to putting on the ventilator. And we said, this definition is actually inadequate, because it's not only critically ill patients who have altered pathophysiology, but we need to have, this is an emerging concept and we need to take it forward. And that's what we did. We published this paper in intensive care medicine. And what we did is that we took all the airway experts across the globe, airway experts in critically ill patients, and we had consensus because a lot of these interventions did not really have very sound evidence. So the next best thing that you can do is perform a robust consensus, Delphi among these experts, to actually first was to coin the definition, and the second thing was to talk about what is the optimum strategy to manage patients with a physiologically difficult airway, where we didn't have good randomized controlled trials or high level evidence. And I really urge you to read this paper. I'm happy to share it with you. We've given very good, 2 graphics which really summarize all the points right from preoperative, before the patient comes in, the preparation, even the post-intubation care, etc. And in the next 12 minutes, I'll give you a snapshot of this. So first, coming to the definition, we said that this was not pathophysiological alterations, but also physiological alterations, like what you see in obesity and also in patients who are pregnant. They also have physiological alterations which can increase the risk. So it's physiological and pathophysiological alterations, as you see in critically ill patients: hypoxia, cardiovascular instability, right ventricular dysfunction, and increased intracranial pressure. all of these could worsen the complications, complications that occur when you have tracheal intubation in these patients. So I'll move on to performing the procedure, and what we talk about is a modified rapid sequence intubation today. And what we mean by modified rapid sequence is you give rapid onset of sedatives, hypnotics, with rapidly acting neuromuscular blockade, and gentle mask ventilation, which we didn't do in conventional RSI, should be considered in these patients with a physiologically difficult airway. And cricoid pressure is very controversial, but if at all you use it, remember to release it if you don't have a good view, or you're unable to insert the device, or you're unable to do a tracheal intubation. So modified rapid sequence intubation is what we do. And remember, the goal of a rapid sequence intubation is to prevent aspiration. So you really need to shorten the time between when the patient becomes unconscious and you have the tube in with the cuff inflated. Now let's come to pre-oxygenation. Okay, now this is really important. And initially we used to give conventional oxygen therapy. We used to just give an ambu bag and mask. And then, of course, we have high flow nasal oxygen and NIV that can give you a little more superior oxygenation, because they can also give you give PEEP to these patients. So there's been loads of studies trying to test which one is superior to the other in this high risk of patients. Remember, these are not patients with normal lungs who come to the operating room. These are patients with ARDS, patients with pneumonia. Now, you're all aware of this trial that was published in NEGM that compared conventional oxygen therapy with NIV. So I would really wonder, do you really need a study like that? Isn't it obvious that NIV would be superior? Well, the group at Vanderbilt actually conducted this study, and it was in 1,300 patients, and they, of course, not surprisingly, they showed NIV was superior to conventional oxygen therapy, 9% versus 18%, and definitely pre-oxygenation using NIV was superior in terms of reducing complications. But what about NIV and high flow nasal oxygen? Okay, so this is the Florali 2 study, and this is a French multicentric study that's compared head-on pre-oxygenation using NIV versus pre-oxygenation using high flow nasal oxygen, which was continued during attempts at intubation. And the primary endpoint of this study was the saturation going less than 80% during the intubation. And if you see, there was no difference. The p-value was 0.37. No difference between the two arms, whether you use NIV or high flow nasal oxygen for intubation. But in the subgroup analysis, in those patients who had PaO2 FiO2 ratio less than 200, NIV was more superior compared to high flow nasal. So the moderate to severe hypoxia, NIV is superior, probably because of more definitive delivery of PEEP as compared to the high flow nasal oxygen. And this is the most recently published meta-analysis comparing all the pre-oxygenation strategies that you can use in these patients, and this comes from the Canadian group from Bram Rochefort. 15 studies, almost 3,400 patients, and they have clearly showed that high flow nasal oxygen and NIV is actually superior to conventional oxygen therapy, and they showed pre-oxygenation with either of these might help prevent hypoxia during tracheal intubation, and compared to high flow nasal oxygen and NIV, they probably decrease the incidence of hypoxia. NIV is superior to high flow nasal oxygen, especially in moderate to sick patients. And I had the opportunity of reviewing the paper and also writing the editorial along with Professor Sabir Jaber. And the title itself gives the main message: pre-oxygenation for tracheal intubation in adults who are critically ill, time to abandon the face mask. So this was published in Lancet Respiratory Medicine, and the important message from this meta-analysis is that conventional oxygen therapy, just pre-oxygenating using conventional oxygen therapy, should probably no longer be used, because NIV and high flow nasal oxygen are superior forms of oxygenating in these patients to reduce the incidence of complications. What about gentle mask ventilation? Okay. Now, during rapid sequence intubation, we don't give mask ventilation, and the reason for this is because critically ill patients, we always treat them as full stomach, because there's a gastroparesis of critical illness, they may be diabetic, there may be other conditions. So by default, we do rapid sequence intubation to prevent, aspiration. So when you do mask ventilation, obviously there's, you can cause gastric insufflation and aspiration. So this was the first trial that compared classic RSI versus gentle mask ventilation during the apnea period after giving the muscle relaxant. Now this was criticized a lot, this study, but actually what they found is obviously in those patients in whom they gave gentle mask ventilation, the oxygenation was superior with no increased risk of aspiration. This study was not powered for aspiration. If you needed to power it for aspiration, you would need thousands and thousands of patients. But nevertheless, it gives you some confidence that in those patients which are at a high risk of desaturation, your gentle mask ventilation can be used in those patients. Because if you look at it, on one side there is a risk of aspiration, but on the other side these patients have pneumonias, ARDS, you give the muscle relaxant and they rapidly desaturate often. So in those kind of patients who are at a low risk for aspiration and high risk for desaturation, it is worth giving gentle mask ventilation. Now we've talked about rapid sequence intubation. Have you heard of this term called delayed sequence intubation? Now this is a very interesting concept, again coming from the emergency department guys. Now what is delayed sequence intubation? This comes from the group of Scott Weingart. Now delayed sequence intubation is a method of pre-oxygenating those patients who are difficult to pre-oxygenate. So you have those patients who come in acute hypoxemic respiratory failure, who are very hypoxic, very rowdy. It's really difficult to pre-oxygenate them. So what you do is you quickly knock them off, induce them and you intubate them, right? But these are the patients who need pre-oxygenation the most, and it is not possible to pre-oxygenate them. So rapid delayed sequence intubation involves giving small doses of ketamine, about 1 milligram per kg. So say in a 50 kg individual, you give 50 milligrams of ketamine. And what happens, the beauty of ketamine is it doesn't produce any respiratory depression. The patient becomes very calm. You can pre-oxygenate this patient. We've started doing it a lot in our intensive care unit. And some of these patients actually don't need intubation at all. It's just the way they present and they come to you, you think I need to rapidly intubate these patients. So you can go ahead and intubate them or do an RSI or not intubate them all. And this was a concept that was introduced by Scott Weingart. But the first study comparing delayed sequence intubation with rapid sequence intubation actually comes from India, from PGI Chandigarh. And what they showed was that every time point when delayed sequence intubation was done, the oxygenation was far superior. So this is a very useful technique to use in those patients who are difficult to pre-oxygenate. Don't rush to intubate them. Give them ketamine, use delayed sequence intubation, and then intubate them. So in summary, the pre-oxygenation with NIV should be preferred in patients with moderate to severe hypoxia. Apneic oxygenation should be used during attempts at intubation. Gentle mask ventilation should be given during RSI. And of course, you can consider giving delayed sequence intubation in those patients who are difficult to pre-oxygenate. Let's come to cardiovascular collapse. 42% incidence of cardiovascular collapse. Now, why do patients have hypotension giving after, when you're trying to intubate them? Now, there are several reasons. So it may be the critical illness itself. In addition to this, the drugs that we use, we have to be very careful about the drugs that we use, propofol, benzodiazepines, etc. The loss of the sympathetic drive. Now, this is really important. When these patients come to you in acute hypoxemic respiratory failure, they're tachycardic, their blood pressure is actually high like the patient I showed you. So this gives you a false sense of security. It is their sympathetic drive that keeps this blood pressure up. So you think, oh, BP is okay, and you give them propofol, and then you have precipitous fall in the blood pressure, especially when these patients are hypovolemic. And then positive pressure ventilation. You see this hypotension occurs soon after intubation. After you intubate them, especially in patients who are hypovolemic and low reserves, you see that there is a decreased venous return, and increase in the intrathoracic pressure will further decrease the venous return and decrease in the cardiac output. So this is, often see the cause of cardiovascular collapse that you don't see so much in the operating room. So obviously for years we have been using ketamine, etomidate, and we've stopped using other drugs because we know that these are more cardiostable, and we know that there is hypotension, is a very common occurrence. And a lot of studies and almost 3 or 4 meta-analysis, and this is the most recent one from Yuki Kotani, that's really not shown much difference, little superiority of ketamine in terms of mortality. But the real message is you could use either drug as long as not contraindicated for tracheal intubation, and you should avoid the other drugs. I'll tell you another interesting study that we did. We took all the data from the INTUBE study, all those 42% of the patients who had hypotension, and we tried to see that what were the factors that were, what are the causes of this hypotension. We did a multivariate analysis, and what we found that propofol was an independent modifiable risk factor for transitioning into hypotension. And what was very interesting is irrespective of the starting blood pressure, propofol transitioned into hypotension. So the important message here is to avoid giving propofol in the operating room. And the anesthesiologists were the biggest culprit because they're very comfortable with using propofol in the operating room, and they continued to use it in the intensive care unit, whereas the physicians and the emergency medicine people use less of propofol. I'll rush quickly because there's less time. So we know hypotension occurs in 42% of the patient. And conventionally, we've been giving fluid bolus because we know let's give some fluid so there won't be hypotension. But this has never been tested in a randomized controlled trial. And the Vanderbilt group was the first one to do a randomized controlled trial, about 300 patients. In one group, they gave 500 ml of saline. In the other group, they did the usual care. But no difference in the incidence of hypotension. However, in the subgroup of patients in whom they gave positive pressure ventilation, that means in whom they had used NIV or gentle mask ventilation during RSI, there was a benefit of giving fluid. So the same group went ahead and did the PREPARE 2 study, which they published in JAMA, and what they did is they took only those patients who received positive pressure ventilation, and in one group they did give fluid, and in the other group they gave no saline. But again, surprise, surprise, no difference in the incidence of hypotension. So the hypotension is real. Almost 1 in 2 patients have hypotension. Giving fluid doesn't seem to be making a difference. So perhaps there is a role of giving a low dose of vasopressor to these patients preemptively to prevent rather than to just treat these vasopressors to hypotension. And there are 2 trials underway. One is the fluid trial that we've just completed at the Tracker Memorial Hospital. I'm still not convinced that fluids don't work. So this is a randomized controlled trial comparing fluids with low dose vasopressor, and we are using 0.08 microgram per kg per minute given 10 minutes through a peripheral line and continued up to 5 minutes after the tracheal intubation and looking at the incidence of hypotension. And the other one is a prevention trial from the ESICM. I'm also on the steering committee of this, and this looks at vasopressor versus the usual care. So coming to video laryngoscopy and tools, there's clear evidence now that video laryngoscopy should be available in every intensive care unit, and every intensivist should be, it increases first pass intubation success, and we should have it. The other 2 tools that I'd like to talk to you about is the stylet and the bougie. And we have the trial from Samir Jaber that's clearly shown that during the first attempt at intubation, the stylet can improve first pass intubation success. And similarly, the trial that compared stylet versus bougie showed that there was no difference between the 2, but this was used during the first pass success, first pass attempt at intubation and improved first pass success. So taken together, I would say that a stylet and bougie or bougie, whatever you're comfortable with, should be used during the first attempt at intubation. And the last thing I'll talk to you about is use of capnography. Now, if you have even a single esophageal intubation in the intensive care unit, look at the risk of the complications. At any of the complications is significantly higher, and the real important message is to use capnography. And capnography is not available, and there have been many deaths because of unrecognized esophageal intubation, and this prompted us to write this guideline, which was published in Anesthesia, as how, measures to prevent unrecognized esophageal intubation. And I'll leave you here with this graphic, because what you need is waveform capnography in every ICU, and you should look at 7 traces of consistent waveform capnography with, I'll just take 1 minute more, with no decline. Because what happens is even when you intubate a patient, especially when it's a difficult intubation, there'll be a lot of air in the stomach. When you put the tube in, you will see 1 or 2 waveforms, but subsequently there will be a decline like you see in red. So the gold standard is 7 waveforms, consistent waveforms with no decline that should be seen. And in the Intube study, what we found was video laryngoscopy was used only in 17%, and this is even data from the developed world, and capnography was used only in 1 in 4 patients. Only 1 in 4 intensive care units across the world uses capnography, so we really have a long way to go. So my take-home message is that the physiologically difficult airway is not a new entity, but something we have to focus in. It is where the pathophysiological and physiological alterations in the patient increase the risk of complications during intubation and transition to positive pressure ventilation. And remember, hypotension and hypoxia are the most common complications, and there's a higher mortality if you have 28-day mortality if you have these complications. And the strategies that I've outlined can help in safer management of these patients. And most importantly, remember, tracheal intubation is a life-saving procedure. But this life-saving procedure can turn into a life-threatening procedure unless we take precautions. And with that, I thank you very much for your attention.
Yeah. Thank you, Sheila Madam. You have again covered the topic very well. We always talk about difficult anatomical airways. You are talking about physiological difficult airways. It's an eye-opener. And that patient you had mentioned, despite doing all the things, patient had cardiac arrest. So can we do anything about the volume status of the patient? Because that patient you are not talking about the volume status. After intubation, after 15 minutes, patient collapse. Is it because of cardiac element or something else happened?
Right. So it could be a combination. This is a critically ill patient. So a lot of time it is vasodilatation, that drug induced. Like I mentioned, all the causes of the hypotension that occur. So it also could be likely hypovolemia. So again, as I mentioned, the trials don't show that fluid giving preemptively fluid make a difference. So perhaps the results of these trials will tell us whether there is a role of giving a low dose vasopressor. One area which can help you very quickly before you get lines is ultrasound. You can have a quick assessment of the preload, the contractility, the afterload using ultrasound, and especially in some patients, perhaps there's a role of selectively giving fluids to some patients. We're probably giving, trials are giving fluid to all patients. Maybe there's a phenotype that, does well with the fluids, and we can identify those patients who are fluid responders and just give them fluids. And perhaps then fluids will make a difference.
Any questions, please? Yes.
Yeah, question from the audience.
But regarding the delayed sequence, what you have mentioned, you have said only the use of ketamine. If ketamine is contraindicated, can we go for etomidate?
Well, see, the thing about ketamine is the way it acts, and as you know, is a dissociative anesthetic. So it doesn't produce any respiratory depression at that point. And it has very unique advantages that you can maintain the spontaneous breathing, because that's what you're worried about, right? If I give propofol and you produce depression. So ketamine is the drug that is, delayed sequence intubation has been described by this. And it has these unique advantages, and that is why it facilitates. And people are always talking about contraindication. I remember when I was a resident, people used to say, in neuro cases, don't use ketamine. Today, we use ketamine, even for neuroanesthesia. So, things have really changed. And this short dose of ketamine that you give for this procedure should not be a concern. Thank you.
Ma'am, my question is, in delayed sequence intubation, do we consider muscle relaxants?
No. The idea is to pre-oxygenate the patient. So you're only giving a small sedative dose of ketamine to facilitate that pre-oxygenation, because the patient is very rowdy. So those of you who have used ketamine, you see when you use ketamine, patient becomes really calm. So it is just a method of facilitating pre-oxygenation.
But my question was, many of the time, I am a physician and I run my small ICU.
Yeah.
So most of the time, we are very afraid of giving muscle relaxants actually in critically ill patients.
Right.
So my question was, as you rightly said about propofol, means propofol is an individual risk factor.
Yeah.
Can we consider muscle relaxant as some risk factor? And many of the time, personally, I do many intubations without muscle relaxant, and they do good. Means that is my small experience.
So I think you asked a very, very important question, and I think with the physician audience here, I think I must answer this appropriately. So first of all, that technique I talked about, delayed sequence, is only for pre-oxygenation. Subsequently, clearly in all data, rapid sequence intubation with muscle relaxant has shown reduced complications. So often when you're a physician, you're very afraid to give the muscle relaxant, and people do all kinds of thoda propofol, thoda fentanyl, thoda midazolam, It actually makes the intubation more difficult. It makes mask ventilation more difficult, intubation more difficult, and especially in inexperienced hands, the intubation will become more challenging. And that is why it is really important that you give the short-acting dose of muscle relaxant. Now, in this case, we use rocuronium. I want to say those who use rocuronium, either you could use saxamethonium or rocuronium, but if you use rocuronium, make sure you use higher doses, like 1.2 milligram per kg, because that will give you intubating conditions in 60 seconds. So my answer to you is use muscle relaxant. Always use the muscle relaxant for intubation.
And last basic question, ma'am. Best time to inject muscle relaxant in critically ill patients?
So it's almost simultaneously, because you want to shorten the time, right?
Yes, ma'am.
So you're not checking any ventilation or anything. You just give the muscle relaxant. You give the agent and the muscle relaxant, and you will have intubating conditions very soon.
Thank you, ma'am.
Dr. Depujari, sir, please.
Dr. Sheila, that was an excellent coverage.
Thank you.
In pediatrics, we have an issue of low FRC. Especially adolescents, we need to keep the lungs expanded. And good PEEP is extremely important. And we are not afraid of hypotension because of PEEP. This was a study from Michigan children. And, well covered after your study. And one more study came in that, we sometimes give inadequate PEEP. And there's a problem in especially obese adolescents.
Right.
So I think that could be an add-on to your talk.
Yeah, so you're absolutely right. In fact, I was an advocate for including pediatric along with obesity and pregnancy. However, the argument by most people, and why we didn't get consensus on pediatric, we got for obesity, they said pathophysiological and physiological alterations. But what they said is that pediatric, like adult, is like a normal entity. It's not an alteration as you see in pregnancy and obesity. But you're absolutely right, the FRC is reduced, so you need to take the same kind of precautions in pediatrics as well.
I often remember our sessions in Tata. Thank you.
Thank you. That was a really excellent coverage of physiological in critical care. I just wanted to know, can you highlight a little bit of use of Presidex, that is dexmedetomidine, in the terms of, a lot of people are using it now when you don't want to give ketamine or something like that, or as a part of controlling the patient's...
If at all where Presidex may help is to make, so what the drug you're talking about is dexmedetomidine, right? So that may help to calm the patient a bit, but remember it causes hypotension and it causes bradycardia, especially if you give a push dose. So this is not a drug I would really recommend to be used prior to intubation. It can be used for ICU sedation, but for intubation only to calm them down, to pre-oxygenate them, but otherwise not. People are even talking about not giving fentanyl and just giving ketamine and etomidate, and studies have shown that the complication rates are less. So we should really avoid using these drugs that can cause hemodynamic instability, especially when the incidence is so high.
Yeah, thank you, Sheila Madam, for your excellent talk. Now, move on to the...
Yeah, thank you so much. Since we had all questions, may I questions after the talks? I would request all the speakers and chairpersons to please move ahead towards the felicitation station while we move ahead for our next session, which is neurocritical care. So, dear friends, we all know delirium in ICU is one of the most frequent and a serious neuropsychiatric syndrome in critical illness patients. It is associated with prolonged hospital stay, higher mortality, and long-term cognitive decline and increased healthcare cost. So, there are many more topics. There are many more topics just like delirium and subarachnoid hemorrhage and neuro monitoring in ICU. There is slight change in the schedule because one of our speakers has to leave early. We all know traumatic brain injury is also a very important topic, and in any critical care setting, monitoring of a patient is very, very important. So to talk about monitoring, neuro monitoring in traumatic brain injury, may I call upon Dr. Ritesh Shah sir for his talk, and may I first request the panel of experts to please join us on the stage. Dr. Vaishali Shirgaonkar madam, Dr. Pramod Giri sir, Dr. Prashant Jedge and Dr. Dinesh Pehlazani, please.
Hello. Good afternoon, everyone. So is it good afternoon? I was just checking whether cerebral perfusion pressure is all right. So very good morning, Nagpur. I thank team Maha Criticon for having me here. My friends, Dr. Sudhi, Dr. Deepak, Dr. Ashish, and the trio patrons for having me here. So neuromonitoring, we know that it's complex. At the end of the day, we are still resource limited and we have to stick to basics. But what's happening around and what can we do? That I'll just rush through because it's a huge topic. So we need to understand the pathophysiology of secondary brain injury, where our role is, review key neuromonitoring modalities, discuss clinical applications, as well as explore the technologies. What is our goal? जो हुआ वो हो गया. That is primary brain injury. Our role is to contain that primary brain injury as far as possible, as well as the major role is understand the progress towards secondary brain injury and try to prevent as early as possible by intervening whatever modalities that we have. Not only that, but even if we try to prevent it, and if it is developing, we need to pick up early that okay, this is what is happening and we need to intervene, and that's how neuromonitoring role is there. So as I say, the structure of the brain becomes abnormal in TBI, the impact of the abnormalities and the process of the impact is most important. That's where, because it's very dynamic. If you see that large hematomas or contusions, patient is all right for 4 hours, and 4 hours 1 minute they deteriorate like anything. So ultimately again secondary brain injury and secondary brain injury, that's where our role is. What do we have? Clinical examination, neuroimaging, and what I'm going to talk about, multimodal monitoring. So neuro monitoring as far as clinical examination is concerned, no, nothing can replace it, but the limitation, GCS is the best studied in TBI. It doesn't include the brainstem reflex like pupillary reaction, isn't it? And it doesn't include the lateralizing signs also. GCS includes that whatever is the best motor power, and that actually we don't want, we want the worst one. There is another score that is full outline of unresponsiveness. Is it better than GCS? Still not that good, not that bad. But yes, we can definitely improve up to a certain extent by including this in our armamentarium rather than only Glasgow Coma scales. But we know that we are falling short a lot of time. The clinical manifestations may be literally late or relatively late, I would say. By that time, the job of secondary brain injury is done. And what we monitor, GCS 1 hourly. Now I encourage and I request all of you 1 hourly, don't be at default, because 1 hour 8 am and 9 am, 8 am patient GCS 15, 9 am patient may be having maybe 3/15. So there is nothing like 1 hourly concept of GCS monitoring, which is most important. And we know there are loads of confounding factors, especially if TBI is a part of polytrauma like metabolic disturbances, sedatives, delirium, altered PKPD, age factors, pre-morbidities, and so on and so forth. So clinical examination do have limitation, and we know very well. Next is imaging. I'm not going into details of imaging, but yes, with a lot of time we get CT scan routinely or as and when needed, but CT scan gives you structure. By that it never gives the function of the brain, where clinical examination and other modalities might help. So what we see that whether the primary injury has increased or whether the impact of the primary injury in terms of midline shift or something like that has gone up. MRI, yes, we don't get too much about too many times MRI because it's not needed. In trauma, CT scan is still the best, except in few circumstances like, when CT scan is not showing anything, the hidden shadows or hidden impact is from diffuse axonal injury, and we get MRI more for prognostication. And this is what, CT and MRI, I'm not going into much of detail. And last but not the least is multimodal monitoring, which is most important. See the complexities of the monitors available to us. And I'm going to talk about one new concept, not very new now, it has published last year, Neuro Vanguard. Vanguard means it's chowkidar. So for preserving whatever brain function remaining from the impact of the primary injury, that's where the role of Neuro Vanguard comes. And it is a combo of clinical examination plus neuroimaging that I talked about, plus there is something called ghost cap protocols and the advanced monitoring system. That's what I'm going to talk about. And there are domains. See this, what we want, the global physiology of the brain and the local physiology of the brain, and alteration of those global and local effects, that what we want. So either we want flow directed technologies or monitoring autoregulation, monitoring metabolism, or monitoring global cerebral function. So a whole lot of tests available. Few of them I'll be talking about, few of them I'll leave it because though there is a slide, I'll be rapidly covering. So what is the first domain? Prevent secondary brain injury. I'll speak 100 times because that's where our role is. And something called ghost cap protocol. What is that? Metabolic factors, confounding factors that we need to treat, which can enhance the primary brain injury because of the alteration in metabolites. like glycemia, hemoglobin, oxygen, sodium, we need to monitor and control. Temperature, comfort, arterial pressure and PaCO2. So we need to define the target and have therapeutic protocols to target that number individually for that particular patient for that particular time, and that's where monitoring role is. And these are the gross targets of those protocols, like glucose, hemoglobin, oxygen, sodium, temperature, comfort, arterial pressure and PaCO2. This all need to be calm and cool. Why? Because it adds 1 plus 1, it becomes 3. One small insult and we know that the prognostication is entirely different. What is the second domain? ICP. Now we talk about ICP, left, right and center, but we need to understand limitation of ICP. ICP, raised ICP is not a diagnosis, it is an event. Please remember that. It doesn't provide the cause of the raised ICP, and we have a whole lot of modalities to monitor it. So what are the reasons of ICP? Either the brain volume or brain parenchyma, or just see what happens whenever the brain swells. It pushes the normal structure either in terms of the CSF or in terms of the vessels, and that's where the role of neuromonitoring comes, that the expanding brain we need to monitor, and the whole lot of conditions that can cause raised ICP. It is a clinical, we know that high ICP, poor outcome, but we need to find the cause of the raised ICP, and we monitor it. There is a number, okay, 15, 25, 20, whatever you want to call. Not only that, what we need to monitor, that high dose for short duration of time, that is also important, or relatively higher side ICP for a prolonged period of time can cause equal damage even if it comes into within so-called normal limits of ICP. What is the third domain, which is most important? I would say ultimately the effect is on brain compliance. We talk about a lot about lung compliance. Brain compliance do have worse prognosis as compared to lung compliance, and what we may need to monitor is cerebral perfusion pressure by these three technologies, ICP and CCP. If we monitor both of them, then probably we can identify the safe zone but high risk. Like ICP safe zone below 15, we are not bothered. More than 20-25, we are always bothered. What about 15 to 25? Is it all right? No, it's not all the time all right. So if ICP suggests high compliance, adequate brain perfusion, no issues. CPP, I would say, trend showing deteriorating compliance, early recognition and intervention help. So even if ICP is all right, MAP minus ICP, CPP matters. And this is the way that we monitor, automated pupillometry, cerebral ultrasound in terms of velocity index, ONSD, and graphical assessment of ICP waveform. I am not going to details of the technologies, but these are the three methods which may indicate there is impairment of either mesencephalon, compromised cerebral hemodynamics, or somewhere there is fluid accumulation. If it represents in the optic nerve diameter, if there is some swelling, that represents that something in the brain is going on. And if we monitor graphical assessment of ICP waveform, it literally says that there is exhaustion of compensatory mechanism and we need to intervene as early as possible. So this is what I say, that whenever the brain volume increases, it pushes the CSF out, it decreases the venous return, and thereby it increases the secondary brain injury. So high compliance, there is no issue, but this is where our role is. The yellow line needs to be as green as possible by intervention. Once you cross yellow line, the red line means poor prognosis irrespective of what we do. The fourth domain is brain oxygenation. That is cerebral microdialysis. See, brain tissue oxygenation is extremely essential. Let me tell you this. See, even if ICP is all right, even if the CPP is all right, but if oxygenation is a problem, then irrespective of the ICP and CPP, there is something wrong going on inside brain. So those monitoring may not help, just ICP monitoring may not help. So as I said, that decreasing oxygenation We need to intervene by optimize CPP, maybe transfusion or maybe oxygen therapy, higher oxygen therapy, something like that. So we need to increase the oxygenation anyhow by intervening, even if the ICP and CPP all right, but if PbTO2 is low. High ICP but acceptable. Sometimes what happens that ICP is high, but PbTO2 is alright. So we should not be behind, like weaning from mechanical ventilation in traumatic brain injury, where fluctuations of blood pressure, there is increase in ICP. But if oxygenation is alright, we can still afford to wait rather than targeting that ICP at that particular time. So it is very, very important that if oxygenation is the last thing, we know that, perfusion, yes, we talk about pressure, we talk about perfusion, but ultimately oxygenation matters. There are definitely limitations. We need to put catheter in high risk areas, and we cannot be monitoring for very long, and cutoff is a big challenge, and there is no 100% standardization. As I said, we need to target or find the protocols and target individually in that particular patient for that particular time. Same way jugular venous oxygenation is there. I am not again going into detail, but there are a whole lot of infective complications, catheter misplacements, and interpretation needs to be very, very careful, and there are a lot of confounding factors that we need to consider. So we know that less than 50% definitely ischemia. Desaturation, if it is sustained for more than 10 minutes, poor outcome. But SgVO2 above 75% means the brain volume has gone up, and you feel, you monitor that in subsequent minutes or hours, the ICP will go up. So we can pick up that very early when we monitor this jugular venous oximetry. Cerebral microdialysis. Now this is the last thing. Once we monitor ICP, then CPP, we want oxygenation, but what is the end product? End product is metabolites. So if we monitor metabolites, that is lactate to pyruvate ratio along with reduced glucose and pyruvate levels, that means something is going on wrong metabolically, and we need to intervene this kind of patients very, very early. And last domain, these are not standardized. This Vanguard approach is still underway, not yet validated for feasibility, but yes, it is an encouraging concept. What are other monitoring tools? Pressure reactivity index, electrocorticography, that is, it is same as EEG, but the electrodes are placed inside the brain. EEG, we know that continuous EEG is also a big challenge. Transcranial Doppler, more studied in subarachnoid hemorrhage, and continuous SSEP, sometimes it may help, but having lot of limitations, especially in traumatic brain injury. Regional cerebral flow cytometry and near infrared spectroscopy, and biomarkers. Again, biomarkers are not standardized. We know that a lot of debate on neuron specific anoles and axonal neurofilament light, but yet yes, we need to wait. So a whole lot of targets are there as far as this advanced monitoring is concerned. Say this, we need to have some protocol, as I say, ICP, CPP, PbTO2, and ultimately metabolites. These four you need to consider whether perfusion is a problem, whether oxygenation is a problem, or whether compliance is a problem. And there are emerging technologies that advanced CT-MRI perfusion, non-invasive ICP estimation, and machine learning integration. So to conclude, close neurological monitoring is the key. Clinical monitoring, imaging, multimodality monitoring all together play a major role. Monitoring DCAS, please do not restrict to 1 hour. Which monitoring to do depends on the local expertise and available of the equipment. Definitely cost matters. Still, in majority of the ICUs, clinical monitoring is the only available tool, and ICP monitoring by TCD, ONSD, and direct ICP monitoring are done at few centers, but yet to be standardized as far as interpretation is concerned by us, because it requires some expertise. Thank you very much.
Thank you, Dr. Shah, sir, covering the topic very nicely. The crux of the talk is you have to prevent secondary brain injury, which is more important. Primary is already done, so our role is to prevent the secondary brain injury.
True.
So, any questions from the audience and chairperson, please?
You have projected the importance of oxygen monitoring in the brain. What is your opinion regarding continuous cerebral oximetry to prevent or to identify that probably there is something which is going wrong? Every time.
Anywhere, I would say that if we have continuous ABG monitoring, I would love it. You know, you can pick up very, very early. That's what, because in critically ill patients, seconds to minutes matter. So if anything that we can get as early as possible information, it definitely helps. But again, we need to be careful about, the interpretation, and only numbers do not matter. What we do to that numbers matter. So intervention out of that interpretation matters. So definitely it helps.
It's my experience that I have been monitoring cerebral oximetry in my ICU in traumatic brain injury, and the fall in cerebral oximetry, that number from 75 to 65, concomitantly if we observe the optic nerve sheath diameter, it is increasingly,
it swells.
Yeah. So I feel it is sensitive
Definitely.
index.
See, as far as early as possible, so rather than getting, from metabolites to perfusion to pressure, it's a gradual, curve. So we need to find that green line turning into yellow line, and we need to prevent there and there only.
Thank you.
Thank you.
Dr. Shah, what is your opinion about ETCO2 monitoring in traumatic brain injury?
Sorry?
ETCO2 monitoring.
ETCO2?
Yeah.
See, ETCO2, fortunately, we are all well versed in because of advancement of ventilator, and we are now this experience in managing ARDS patients. So, low or high, both are dangerous for brain. So, don't try to over-ventilate. That is a more message. Rather, see, higher CO2, we have a threshold. No. Get down the CO2. But lower CO2, nobody, works on that. So, if the CO2 is 25, I would be literally worried. So normocapnia is the norm, except when patient is to bridge to the OT, transient, cautious hyperventilation, targeting the PCO2 around 30 till the patient is patient is undergoing decompressive craniectomy. That's the only indication. Otherwise, no low PCO2, no high PCO2.
So the crux of the matter is hyperventilation is of not much that
dangerous.
And
I would say dangerous.
If at all it should be used for a brief period of time,
Yeah.
not more. Right. So any other questions from the audience, please?
Thank you. Thank you very much.
Thank you so much, sir. Moving ahead to our next topic, as we all know, despite of a lot of advances in neurosurgical and neurocritical care, management of SCH remains challenging, and it's filled with clinical controversies, largely due to the variability in the pathophysiology, the timing of interventions, and conflicting results of the trials. So, to discuss the do's and don'ts in SCH management, I would like to call upon Dr. Khalid Khatib, who is Professor Department of Medicine at SKN Medical College, Pune, Maharashtra. He is a chairperson of IICCM Pune branch. He has won 5 awards at national and international levels. He is a state and national faculty for various conferences. Over to you, sir.
Thank you for that kind introduction. I'll be speaking on subarachnoid hemorrhage, clinical do's and don'ts. I would like to touch upon evidence-based strategies for optimal patient outcomes. I will be trying to identify common pitfalls and don'ts in clinical practice, discuss evidence-based approach to managing complication, and ways to optimize long-term patient recovery. Let's look at this case. A 58-year-old female, she presented with the abrupt worst headache of her life, which was followed by unconsciousness. Non-contrast CT was done. So now we know that the diagnosis will be subarachnoid hemorrhage. So what are our treatment priorities? Before that, let's touch upon subarachnoid hemorrhage. It is a neurological emergency characterized by bleeding into the subarachnoid space, that is the space between the arachnoid membrane and the pia mater. It consists of approximately 5 to 10% of all strokes, but it carries high morbidity and mortality. We all know that clinically it presents as sudden severe thunderclap headache, often accompanied by neck stiffness, loss of consciousness, vomiting, and or focal neurological deficits. If you look at the epidemiology, the incidence is around 9.1 per lakh per year. And if you look at age versus subarachnoid hemorrhage, young people are much less likely than middle-aged people to have SAH, and the risk increases with age, more than 60% higher in the very elderly rather than in those who are having middle-aged. If you look at risk factors, genetics, lifestyle factors are more important in determining overall risk. Smoking, hypertension, excessive alcohol consumption have all confirmed higher risk for SAH. Exertion, the immediate trigger for subarachnoid hemorrhage many a times is exertion, and it is exertion which causes the aneurysm, if it is present, to bleed. The various causes of subarachnoid hemorrhage can be divided into traumatic or spontaneous. Spontaneous, where there is ruptured intracranial aneurysm, or there is AV malformations, drug abuse, or other rare causes like sickle cell anemia, pituitary apoplexy, or sometimes rarely even CVST. We all know that trauma to the head can cause subarachnoid hemorrhage, and it is often in the setting of other forms of TBI. The subarachnoid hemorrhage which occurs because of trauma, it has worse prognosis because of the associated traumatic brain injury in addition to subarachnoid hemorrhage that the patients have. Some rare cause I would like to present to you are case which we had presented in the Journal of Emergency Trauma and Shock. So this patient with subarachnoid hemorrhage, he had subdural hematoma as well as cerebral venous sinus thrombosis. So patient had thrombosis as well as bleeding in the brain. So we also presented this rare case, and we also advised whether this patient who is having thrombosis as well as bleeding, whether he should be given anticoagulation or not. So we gave an algorithm which told us about whether to give anticoagulation and in which patients we should give anticoagulation. So coming to some do's and don'ts, in the hyperacute stage of subarachnoid hemorrhage, what critical actions we should do in the first 6 hours of these patients so that we can improve morbidity and mortality. So monitoring, most important, monitor with GCS, pupils and vitals, monitor them closely. Secure the airway if GCS is less than 8 or if there are signs of brainstem herniation. Rapid transfer to high volume neurovascular center. If your center is not equipped to manage these patients, whether you are unable to do neurosurgical intervention, endovascular intervention, then you should rapidly transfer these patients within the first 6 hours, or at least think of transferring. Blood pressure, what will you do? So targeting systolic blood pressure less than 160 millimeters of mercury. You want to do this so that you will reduce risk of rebleeding. Of course, you will provide adequate analgesia, antiemetics, stool softeners, because you do not want the patient to be at a risk of rebleeding. And obtain CT angiography or DSA so that you can confirm whether your patient is having aneurysmal bleed and which has led to the subarachnoid hemorrhage. What would you like to avoid? A delay in the diagnosis. Kindly please remember that patient who presents with severe headache can have normal CT scan in the first 6 hours where you may not be able to see the blood in the cisterns, and at that time LP is indicated. If a patient, you have a strong suspicion that your patient is having a subarachnoid hemorrhage but the CT scan is normal in the first 6 hours, do not dismiss that patient and send him away by giving him just some analgesics or something. Try and repeat the CT after 6 hours. If required, do a LP. Avoid rapid or excessive or aggressive blood pressure lowering, because this can reduce cerebral perfusion. So you do not want to reduce your blood pressure less than 160 millimeters of mercury. Please do not ignore small neurological fluctuations which may indicate that the patient is having rebleeding or other complications. And do not, because this patient has bleeding in the subarachnoid space, do not forget that he may also require DVT prophylaxis. At this time, DVT prophylaxis will be with pneumatic compression devices and not with anticoagulation, because it is hyperacute phase. Now you want, if the subarachnoid hemorrhage is because of aneurysmal bleeding, you want to secure your aneurysm. You want to either do some neurosurgical intervention or some endovascular intervention. So whether patient needs clipping or coiling, you want to do something for that aneurysm. So consult your multidisciplinary team, let the neurosurgery and neurointerventional radiologists decide whether your patient needs coiling or clipping. Prioritize this early intervention, repair the aneurysm as soon as possible, as soon as feasible. Consider the ISET data whether your patient needs coiling or clipping, what will help him, and use clipping for specific cases. Clipping has to be done neurosurgically. So if your patient is having wide neck middle cerebral artery aneurysm, or those who are having large hematomas, you may have to do neurosurgery, and once you have done neurosurgery for the hematoma, you might as well do clipping. What to avoid? Don't postpone the intervention, because it can cause catastrophic rebleeding and increase the severity of your complications. Don't ignore complex cases. Let your multidisciplinary team decide what needs to be done depending on their endovascular expertise. Also, do not ignore rebleeding chance. The window for rebleeding is narrow but significant, making early definitive treatment critical. So what is the ISAT data that I was speaking about? ISAT data, it is the International Subarachnoid Aneurysm Trial of neurosurgical clipping versus endovascular coiling, and outcomes in terms of survival-free disability of 1 year is significantly better with endovascular coiling in appropriate patients. Even in the elderly, in good grade elderly subarachnoid hemorrhage patients with small anterior circulation aneurysm, EVT should probably be done rather than NST, which is neurosurgical treatment. We must try and do endovascular treatment. EVT resulted in lower epilepsy frequency also. So other complications were also less in patients who underwent endovascular therapy for subarachnoid hemorrhage, which was due to aneurysmal bleed. Even long-term follow-up, EVT was better in these patients. In the management of complications, if you want to proactively reduce vasospasm and delayed cerebral ischemia, so administer nimodipine. Give nimodipine orally to all your patients, 60 milligrams, 6 hourly, 4 hourly, depending on how much the patient can tolerate. Monitor vigorously for vasospasm with either transcranial Doppler or CT angiography. Maintain normonatremia and fluid balance. Previously, we used to do triple H, hypertension, hypervolemia, hemodilution. So nowadays, we don't want to do hypervolemia or hemodilution, but monitoring or measure, if required, these patients who are having low blood pressure and they are manifesting evidence of delayed cerebral ischemia, you may think of increasing their blood pressure either with noradrenaline or other drugs. DVT prophylaxis after aneurysm is secured. Early nutrition, physiotherapy, mobilization. If patient has seizures, then treating them with levetiracetam. These are your do's in managing the complications. What you don't want to do? Mistakes in the post-intervention care. Don't neglect raised signs of ICP. If patient has headache, bradycardia, hypertension, treat the ICP. Either you can use osmotic diuretics or other drugs, 3% NS. If patient develops an hydrocephalus, he may require EBD placement. Don't delay electrolyte corrections. Correct your electrolytes, because they may be because of either SIADH or cerebral salt wasting or overhydration. Depending on what is the cause of electrolyte correction, treat it. Do not give your if patient has seizures and you start treatment with levetiracetam, give it only for 7 days or 21 days. Do not give prolonged for 6 months or 8 months. Don't use anticoagulants before aneurysm has been secured. Avoid prolonged immobilization or fasting. Patient doesn't need to be fasting. And don't wait for clinical deficits, delayed cerebral ischemia before checking for vasospasm. Administer nimodipine early and adequate dose which is tolerated. For long-term rehabilitation, The do's is involve your multidisciplinary team, physical, occupational, speech therapists should be involved early, address psychosocial needs, see whether patient is having cognitive impairment, fatigue or depression, and if anything is there, try and treat it. Educate on lifestyle changes, emphasize that blood pressure control, smoking cessations are important for future to reduce future risk. Don't neglect screening of first degree relatives for aneurysm if recommended by the guidelines. Don't ignore subtle deficits that the patient may be having. Long-term cognitive and mood issues are common and require dedicated follow-up. Don't assume that your patient will become all right once you have discharged him. You have to get him for follow-up and continue to monitor him. Educate patient and family that recovery from subarachnoid hemorrhage is a marathon and not a sprint. So it has to be long-term ongoing over months and weeks. So to summarize, depending on the stage that the patient is, in the early phase, rapid action saves life. So early recognition, CT scan, stabilizing ABC, controlling blood pressure, nimodipine and securing the aneurysm. Please do not do an LP before you have done a CT scan. Avoid blood pressure drops, sharp drops in blood pressure and do not delay surgery. In the ICU phase, vigilance prevents disaster, monitor the ICP if possible, prevent vasospasm, correct electrolytes. Avoid overhydration. This is one of the important things that you can easily do. Avoid overhydration, avoid causing hypotension and unnecessary anticoagulation. In the post-operative, recovery extends beyond the ICU, so blood pressure control, smoking cessation, follow-up imaging. Avoid strenuous activities, NSAIDs and anticoagulants without clearance. These are my references and thank you. The science of subarachnoid hemorrhage management has evolved. Our practice must evolve with it. Thank you.
Thank you, Khalid sir, covering the very important topic of subarachnoid hemorrhage. So, if over to chairperson.
Thank you, Khalid sir. Sir, any experience with the use of milrinone for refractory spasm?
Milrinone, I have not used it, so I really cannot tell you that. Anybody in the audience has used milrinone in the
We are using it for those on table after coiling.
Okay.
So when there is a spasm which doesn't respond to even IV nimodipine, we use in around 0.5 microgram per kg per minute, usually around 7 days.
Okay.
But what we found, even in the previous trials also, almost like 1/3, 1/4 patient they don't tolerate, and then hypotension happens,
Causes hypotension
which
and delayed
absolutely
cerebral
need to be
ischemia.
prevented. So in those patients we need to stop it. Otherwise it reduces the risk of vasospasm.
Oh. No, I have used nimodipine extensively and I have experience with that. I have not used milrinone.
So, role of IV nimodipine versus oral.
Okay. So you can use IV nimodipine, but these patients usually they will have, sometimes they can have rapid fall in their blood pressure. So rather than using intravenous, it's better to use oral because bioavailability is good. There is another some drug which is available as oral solution, and some people have tried using it even intravenously, but it is not to be done because you can have rapid blood pressure drops.
So duration of nimodipine, how much duration we should use?
How many days?
Yeah, how many days?
Okay, around 1 week to 10 days should be more than enough for that.
So you talk about the triple therapy.
Yes, yes.
Hypertension, hypervolemia, hemodilution. How to do hemodilution?
So what various trials have shown is that hemodilution is done by either you can give more IV fluids or you can reduce the RBCs, just as we do for patients who are having erythrocytosis. But nowadays we do not do either over hemodilution or we do not give too much IV fluids. So that is not to be done. Only hypertension, you can try to do hypertension if the patient is having delayed cerebral ischemia, and that is because of reduced perfusion. Yes.
Good morning, sir. Sir, you suggested that systolic blood pressure of 160 should be kept at least less than that. Is there any role of induced hypertension some people use to avoid hypertension, induced hypertension using our vasopressor agents?
So induced hypertension we are supposed to not do in the first 6 hours. we want to reduce your blood pressure in the first 6 hours. Induced hypertension will come into the picture if you are suspecting delayed cerebral ischemia, and that is because of reduced cerebral perfusion pressure. At that time, once you have clipped or coiled your aneurysm, and if the patient develops delayed cerebral ischemia, then that is the time when you can think of induced hypertension. That is the part of triple H: hypertension, hemodilution, and hypervolemia. So the two are not to be done. Hypervolemia is not to be done, hemodilution is not to be done, but induced hypertension can be thought of in patients with delayed cerebral ischemia if there is reduced cerebral perfusion.
Since for how many hours or days you should use that vasopressors? If you are using nimodipine, IV or oral, whatever.
Yes.
But what is the duration of that noradrenaline or vasopressin? What may be to used? For how long it is to be?
It is to be used for 48 to 72 hours. And you have to monitor the response to that. If your patient improves with that, then you can continue for 48 to 72 hours. But if you do hypertension and your patient does not improve, then there is no point in continuing it beyond 48 hours.
Because most of the time we don't have that ICP monitoring.
Yes.
So we have to just clinically only.
Yes.
So in that case, just it is dropping, and put the patient on noradrenaline in spite
Yes.
of normal neuro
Yes.
assessment.
So continue it for 48 to 72 hours. And then continue assessing your patient.
Thank you, sir.
One more question. You talk about the early intervention. How early is the early, sir, intervention?
So earliest is within 24 hours.
Okay, maximum time is severe ophthalmosperm is there. So even DSA may not show the site of bleeding.
Yeah. So if there is an aneurysm which has been recognized, then it should be managed or it should be clipped or coiled early within the next 24 hours. If you are not seen an aneurysm, then there is nothing that you can do. But you must talk to your multidisciplinary team, talk to your neurosurgeon, talk to your interventional radiologist, and then decide what needs to be done.
Okay. If there is no other questions, so we close this session. Thank you, sir, for your excellent talk.
Thank you.
Hello. Thank you, chairpersons and speaker. I request you to move ahead towards the felicitation station, and let us move on to our next session of infectious disease. May I request Dr. Sudhir to come forward and yeah. So, may I call Dr. Piyush, the MOC of infectious disease session. Please take over for the proceeding.
Thank you, MOCs. Thank you, Dr. Ajay Sakri sir and Dr. Amol sir. We'll move on to our next session, which is infections and critical care session. Respected faculty, dear colleagues and friends in critical care, a warm good afternoon to all of you. I, Dr. Khalid Khan, I am Dr. Piyush Kottegar. We are truly privileged to deliberate on infectious disease in critical care. To guide us through this intellectual journey, allow me to invite our esteemed chairperson panel, luminaries whose wisdom has shaped generations of intensivists and physicians. We are honored beyond the words to welcome a living encyclopedia of infectious disease and researcher and clinician par excellence, Dr. Jay Deshmukh sir, Senior Consultant Physician, Sunflower Hospital. We are truly honored to welcome Dr. Nitin Shinde sir, infectious disease expert at KIMS Kingsway Hospital, and Dr. Ashwini Tayade ma'am, infectious disease consultant physician in Nagpur. For our first talk, may I please call upon stage Dr. Ranveer Singh Tyagi sir, Tyagi sir, he is director, Department of Anesthesia and Critical Care Medicine at Synergy Plus Hospital and Galaxy Hospital, Agra. He is also teacher and mentor for IDCCM and DNB students. He is eminent anesthetist and intensivist at Agra. He has served ISCCM as past Vice President for the year 2017 and 2019 and 22-22. Over to you, sir.
Thank you very much for kind introduction. Radhe Radhe, Pranam, and first of all, thanks to all the team of organizing committee of Nagpur to invite me in this beautiful city, city of Orange, central city of India, and also nickname it Tiger City of India. So all tigers sitting here. So once again, thank you. Next 15 minutes, we will discuss on the surviving sepsis guideline, which is arises from 2002. So why sepsis and sepsis survival sepsis comparing matters? Because in 2002, in the SCCM launched at a critical care congress regarding this concept of sepsis survival guidelines. So first guideline published in 2004 until 2021, in 2 decades, 5 guidelines were published already. In 2004, 8, 12, 16 and 2021. So latest update, not guideline published, was some update in 2024. So in 2004, the initial recommendation are early goal directed therapy, nothing else. Aggressive fluid and give. And you measure the fluid, how much you want to give the fluid by the CVP or by the SCVO2 target. The concept of that is not good for this patient, especially in the cardiac patient or the patient who are the AKI or renal failure patient. So redefined the protocol in 2008 and 2012. So that time they launched the bundles. The group of ones, they for the protocolized ways, and vasopressor started after the fluid resuscitation and source emphasized on the source control. In 2016 and up to 2021, the evidence-based recalibration started. Early goal directed therapy are abandoned because that is not good. The patient may be harmed due to the high level, giving the high volume of fluids. And individualized patient care, the time is come to precise medicine and dynamic assessment of fluid management. And in 2024 update is the personalized hemodynamics monitoring. One size does not fit to all patients. And biomarker guided therapy and phenotyping and recognition is very, very important. So what is sepsis? Basically life-threatening organ dysfunction caused by dysregulated host mechanism in response to infection. So initially it was assessed by SOFA and later on by QSOFA, and after that in 2021 they find the SOFA or QSOFA is not only sufficient, we can assess by the NEWS, National Early Warning Score, or MUSE, Modified Early Warning Scores. And they found a septic shock. Septic shock is basically need a vasopressor, circulatory, cellular or failure of the metabolite to maintain the blood pressure in more than 65 or maintain the lactate. So what changed in last 20 years, 2 decades? In the initial was a fixed protocol. Now it is personalized based. From rigid protocol replaced by individualized, patient to patient. CVP is almost abandoned for the fluid resuscitation. And dynamic assessment is very, very important to the patient. By the functional or by you can do the, even if you can use the echocardiography or capillary refill time or lactate levels. So these are the dynamic. So the fluid strategy evaluation from era of early goal-directed therapy or aggressive fluid management to personalized, individualized patient is a change in last 20 years. So the major trial in the fluid, process trial, ARISE trial or PROMISE trial, they all show early goal-directed therapy is not beneficial, very much beneficial. And the FEAST trial, fluid bolus increase even the mortality, especially done in the African children who are with fever. And later on, Andromeda shock trial found a capillary refill guided resuscitation is very, very useful, even in the better than the lactate level. So the assessing fluid response by IVC collapsibility, positive pulse pressure variations, especially in the patient on the mechanical ventilation, or basic test is passive leg raising test, measure cardiac output or changes. This is very simple, you can measure a bedside easily. So now the second question is which fluid? We are finalized, we need a 30 ml per kg fluid personalized to the patient, not fixed. In what patient, one patient to other patient it is vary, but 30 ml per kg is fixed. So balanced crystallized is preferred over the normal saline. Why? Because of hyperchloremic metabolic acidosis and in normal saline increased chance of acute kidney injury. Now, third point is the vasopressor strategy. Initial was no vasopressor, initial fluid or fluid. Now the concept come of vasopressor. So the first line vasopressor is norepinephrine, preferred initial agent for the septic shock. And if you want to add, because in septic most of the patient in the metabolic stage, metabolic acidosis stage, so second agent for after the noradrenaline is vasopressin to maintain MAP more than 65. Or in the refractory shock, consider angiotensin if catecholamine resistant cases. So the key vasopressor trial for these vasopressor agent is sensor trial. They found noradrenaline is good because dopamine causes arrhythmias. And vasopressin reduces, if you add the vasopressin, in patient metabolic acidosis, reduces chances of CRIT. And Athos trial 3, angiotensin is added in the refractory cases. So resuscitation target, what is the target of a resuscitation? To keep the mean arterial pressure more than 65. Lactate clearance, normalize or decrease lactate more than 10 to 20%. Or avoid hyperoxia. Don't give too much oxygen to the patient. Try to keep the saturation between 92 to 96%. And the concept of antibiotic, initially the antibiotic is given either patient in shock or in septic shock. But the new concept arises, if the patient have a shock, give the antibiotic, broad spectrum antibiotic within the 1 hour. If the patient does not in the shock, you can give in up to the 3 hours, you can buy time to further investigation, it is really infection or it is non-infectious shock or the other cause of shock. So this means critical care people, earlier antibiotics save the life but balance against inappropriate therapy. So better to, if you assess the patient is not in the shock, you can wait time and investigate further and give the antibiotic in 3 hours. So resuscitation target is again. So antibiotic strategy, the phase of administration, initially give the broad spectrum antibiotic within 1 hour. If culture report come, narrow down the antibiotic range and PCT guided. PCT is only for the de-escalation. If considered stopping PCT fall more than 80%, you can stop the antibiotic 3 to 5 days. Or you can later on you can shift in the oral antibiotics. So de-escalation of antibiotic is very, very important. We all know the era is coming, resistance is very, very high. All antibiotics are resistant to because of overuse. So obtain culture before antibiotic, if culture come, narrow down the antibiotic, stop antibiotic if not needed or not infection and transition to oral when it is appropriate. The role of corticosteroid. They initially considered low dose corticosteroid 200 milligram per day only in the vasopressor or refractory shock. But nowadays recommendation 2021, low dose steroid is recommended even after the shock is recovers. So the key trial is one adrenal trial, no mortality benefit found. Approach trial, faster shock reversal, or in hyperus trial, there has been mixed results. So these are the different studies using regarding the steroids. So next is early goal-directed therapy is abundant and CBP, SpO2 target remove and lactate and CRT, capillary refilling time is preferred over the lactate management. So Andromeda shock trial, they found if you assist the capillary refill time is more important than the lactate. So you can assist easily with the bedside. For lactate, you need to done the AVG. So SSC bundle evaluation is from 6-hour bundle to individualized tailored to present severity. Initially 6-hour bundle, later on 3-hour bundle, after that 1-hour bundle, antibiotic and precise, and nowadays in 2024 era of personalized, individualized to the patient. So what remain strongly recommended? Only early antibiotic within after fluid resuscitation, early antibiotic within 1 hour, or a patient in the shock. If not in shock, use up to 3 hours. Early vasopressin, the choice of vasopressin is noradrenaline and balanced fluid, not normal saline. The role of vitamin C, initially it was recommended, but nowadays the Lobby trial found there is no role of vitamin C in the septic shock. So precision sepsis medicine between the hyperinflammatory or immunosuppression. So the overlapping feature between the two, you can find that. So the biomarker guided management of regarding the procalcitonin, if procalcitonin decrease more than 80% from the peak level, then you de-escalate the antibiotic, or C-reactive protein, monitor inflammatory trajectory and add or decrease the antibiotic according to the patient clinical condition also. The ventilatory support strategy. Initially, a patient in the sepsis without shock, you can give HFNC is over than NIV. HFNC is more effective than NIV. If patient in shock, give the mechanical ventilation. Or after that, if patient is not improving, we can go to ECMO, BB ECMO. If the severe ARDS even is not responding after the prone positioning of the patient. So directly not put on the, give the trial of prone positioning also. So role of renal replacement therapy, no one recommended routinely in the septic shock except a patient in severe metabolic acidosis, life-threatening hyperkalemia, refractory fluid overload, and uremia. These are the recommendations of CRRT. So the source control, without source control you cannot manage these type of patient. इस कमरे में अगर बदबू आ रही है तो परफ्यूम छिड़क के काम नहीं चल सकता. You have to control that source. You have removed that source. So drain abscess or infected, debride or remove the infected device if you suspected CVP line, catheter, any catheter or any device, or deep compress obstructed like a biliary cholangitis if it due to the stone, or urosepsis due to the urinary stone. So decompress these. So what is out in 2024? CBP target no longer guided. Routine vitamin C, SCBO monitoring and fixed 30 ml bolus replacement because it is individualized to the patient. So these things are out in 2024 in surviving sepsis company guideline. And what is in personalized hemodynamics of the patient, assist individual patient, give fluid, ward vasopressin, noradrenaline, biomarker guided therapy, PCT, which is not needed, it PP decrease more than 80%, de-escalate the entire. Fluid, balanced corticosteroid preferred over the normal saline. And phenotyping recognition is still very, very important nowadays. So my take-home message, early recognition, timely intervention, and personalized patient care. Always remember, clinical experience along with the implementing latest guidelines will help us all to reduce global burden of sepsis. That is very big cause. Thank you very much. Any question?
Thank you, sir. Thank you so much, sir, for timely completion. Questions will be discussed after the.
Okay, thank you.
Thank you, sir. May I now request the legendary Dr. Rajiv Somani, sir, ID physician in Jupiter Hospital and Dinanath Mangeshkar Hospital, visiting consultant in PD Hinduja Hospital, Mumbai. Sir is a big name in ID, whether it's a clinical scenario, research or teaching. Sir, I humbly request you to enlighten us through your own words of wisdom. Thank you, sir. Over to you, sir.
One more. Good morning. Whatever. Good morning, friends. It's indeed a great pleasure to be at Nagpur. I know you guys keep inviting me over and over again. I'm really thankful for that, and I'm thankful to the chairpersons here. And I'll begin straight away the talk on how do we choose antifungal agents in the critically ill patients, which, when, and why. And I'll straight away discuss only cases, and let's see what choices we can come up with in these cases. So this is a 54-year-old lady. She had diabetes, asthma on steroids, and she had a delayed exploration for an acute abdomen. That means the perforation has occurred some time earlier. So 2 jejunal perforations were found in this, and a resection anastomosis was done. Meropenem was started by the surgical team, and the intraoperative peritoneal fluid grew a host of organisms. So you had ESBL, E. coli, Klebsiella, as well as Candida glabrata, and Mica fungin was started on this basis of this susceptibility report. So what is listed here is that fluconazole is listed as intermediate or with a MIC of 8. Now this intermediate is sometimes called as susceptibility dose dependent, SDD. And the reason why we call this designation is that for this organism, susceptibility is not the usual way in which we look at it. We always need the highest possible doses for treating this kind of an infection, and that's why it is designated as SDD. Now, how do we manage this particular patient? Mica fungin was started, but is that enough? Is the dose right? These are the questions in front of the intensivist. So here we have the global guideline for the diagnosis and management of candidiasis, and that is from 2025. I am one of the authors, but you might need a magnifying glass to see my name there because it's a multi-author, multinational guideline. And so if you look at the intra-abdominal part of it, what is stated in green? So you could have 2 types. One is after perforation, one is related to the dialysis catheter. And the one after perforation, the treatment of choice, what is mentioned here, which is in green, is the liposomal amphotericin B. Okay, and in this yellow is something which is what we commonly use, and those are the echinocandins. You might note that the doses of the echinocandins are the standard ones. And like we heard elegantly from my previous speaker, that badbu aa rahi hai to source control karo. And I think that is very important in intra-abdominal infection. So you must have the source control, and after that you can possibly de-escalate to high dose fluconazole. Now why do I need high dose here is answered here. So basically we have suboptimal peritoneal penetration of the echinocandins. So we are all tuned to using standard doses of echinocandins. This is an excellent paper which has actually not been taken much into consideration in the publication of this guideline, but this is extremely important paper. And we have Jason Roberts, who's a big PK/PD guy, who's one of the authors here. So if you look at this patient, we need to have very good penetration into the peritoneal cavity. The drug should also have pharmacodynamics. In other words, it should be working for this Candida glabrata. And we should also pay attention to whether the drug is going to be toxic, whether there are going to be drug-drug interactions. So if you see here, even for liposomal amphotericin B, you need a higher dose. Okay, so that is something important. 3 milligram per kilogram for intraperitoneal infections is not the right dose. And then if you look at fluconazole, even here they are talking of a higher dose which is to be used. Perhaps even with TDM, nobody ever does TDM for fluconazole, but this might be one reason for actually doing it. And voriconazole, in fact, penetration is a little bit lesser as compared to fluconazole. So in this particular situation, who's got that delayed perforation, resection, anastomosis is done, patient is in sepsis, has undergone surgery, there is going to be drainage of the intraperitoneal material, and so on. You are going to have a high apparent volume of distribution, and therefore you need the high dose. You have, not in this patient, but in others, you would have a drainage of the intraperitoneal fluid. So with the drainage, the water-soluble micafungin or whichever other echinocandin that you are giving is also getting out of the body. Some of these patients, especially if they have severe disease, severe sepsis, or even liver disease, they will have hypoproteinemia. So the important thing is these drugs, echinocandins, are extremely protein bound. So if you have low protein, there is more free drug. So we are happy that the free drug is there. It is the one which is going to have an activity. But also remember that that free drug is going to be metabolized by the liver and by other means in a much better, faster way. So I sometimes like to call this as an augmented hepatic clearance. You are all familiar with augmented renal clearance when it applies to say beta-lactams and so on. So here is one condition where it might be less. And therefore, you probably need to have higher doses of these echinocandins. So you remember, you needed higher doses of liposomal, 5 milligram per kilogram, and even here you might want to give 150 milligrams of say micafungin or something like that. Besides this organism, Candida glabrata, Ashit is not here, but Ashit used to call this as Candida glabrata. Okay, so why are we so scared of this organism? Because it has certain genetic characteristics which actually require us to use higher doses, at times in combination, and perhaps with therapeutic drug monitoring. Now let's look at this case. She's an 84-year-old lady, diabetic, hypertensive, and has chronic atrial fibrillation. I was told that she was actually admitted for arrhythmias several times earlier in the past. Now she has, as you can see, an illness with these dense nodules which are surrounded by halos. It's one of the best images to see the halo sign and so on. And not a surprise here that the patient has a serum galactomannan which is positive, and all this has occurred in the context of a respiratory illness. In this situation, it is actually influenza. So this is actually virus associated or influenza associated pulmonary aspergillosis. So what is the choice of treatment? Okay, here in this case, in this session we are discussing the choice of treatment. So here we know that this is an old trial done way back in 2002 called the Herbeck trial, and in this it is sort of laid in properly that amphotericin B is inferior to the new azoles or the mold active azoles for aspergillosis. However, there are two new trials. One of them is called as SECURE, and the other one is also a posaconazole versus voriconazole study. And both these show that the newer azoles are non-inferior to voriconazole. Okay, so vori was found to be superior to amphotericin B, and the two new ones are found to be non-inferior or roughly equivalent as far as the therapeutic efficacy is concerned. However, my point is, can isavuconazole or posaconazole be considered over voriconazole as contemporary choices for aspergillosis? And why I might be saying that is because it has equivalent efficacy, it has far less potential for adverse drug reactions and drug-drug interactions. So I would submit to you, friends, that maybe the time has come not to keep on using voriconazole, but to go in for one of these two agents. So in this patient, remember this patient had multiple admissions earlier for arrhythmia. So there is a problem. So which is the drug among these which has the least chance of developing arrhythmias? And the answer is isavuconazole. This is one of the rare drugs which produces shortening of the QT. The only drug I think which we know is potassium. These are the only two agents which produce shortening of the QT interval. So that was the choice of agent which we use for this particular patient. Now here is a 58-year-old male. He has pemphigus, was treated with very high doses of steroids, multiple courses of cyclophosphamide. In other words, the patient is heavily immunosuppressed. Now he developed dyspnea, cough, fever, cytopenias, and was transferred to Jupiter. Now what does this scan tell us? So you have a ground glass appearance, mainly in the upper parts, with peripheral and basal sparing. Okay, so the leading consideration is PCP. Okay, but if you look closely at the airways, you will find that the airways are showing nodular and ulcerated surfaces. So it means there is something which is damaging the airways, and therefore there was a strong suspicion of there being associated aspergillosis. So very likely this X-ray or the scan tells you that this is both PCP as well as aspergillosis. And not a surprise at all, these are the bronchoscopic findings which show that there is so much of ulceration and formation of these plaques. And this is the smear which shows both PCP as well as a mold which looks like aspergillosis. But the question is, in this session, what should be used for treatment? Okay, you have this patient who has cytopenias because of all this chemotherapy, and how are we going to treat this patient? So are we going to treat him in a standard fashion with the standard high dose of TMP-SMX along with voriconazole? Or would we give micafungin, clindamycin, primaquine and isavuconazole? Or would we give TMP-SMX plus liposomal or something not here? Okay, so because of the cytopenias, and we know that the dose of Bactrim is very high in this particular situation, therefore probably it's not a good idea to give high dose Bactrim. Now voriconazole could be used, but I just argued that maybe voriconazole may not be the best choice here. And plus, being severely immunocompromised, there is always this at the back of the mind of the physician, whether there is going to be additional mucormycosis. Friends, I must tell you that we will have mixed mold infections to the tune of about 15% in patients who are severely immunocompromised. And the same was true even in COVID times. Okay, so my choice would be in this situation, micafungin plus clindamycin primaquine plus isavuconazole. And I'll argue with you why I might say so. Now we know that echinocandins also work for the cystic forms of PCP. Okay, so the PCP also produces, don't you know, it produces a very high amount of beta-D-glucan. Okay, so here you have a drug which is inhibiting the glucan synthesis, right? The echinocandin. So it also works for PCP but doesn't have a very, very great action for PCP. So you need perhaps additional drugs with it. Now is the echinocandin going to work for the aspergillus, which is also there here? Answer is probably no. It will only work partially because echinocandins have only a partial non-fungicidal effect for the aspergillus. So we have to give something else, non-Bactrim treatment, and that is going to be clindamycin. Okay, so clindamycin primaquine is an alternative therapy for PCP. And as I said, isavuconazole would cover most aspergillus as well as mucor. And the azole resistance in aspergillus is somewhat rare in India, but that incidence is increasing. What about TMP-SMX and liposomal? Again, cytopenias are present. We know that this is slightly inferior to the azoles for aspergillus. And also we must remember that some species like Aspergillus flavus, which is also not uncommon, is fairly resistant to amphotericin B. So the messages which come out from this case is that the risk factors, like in this patient, so severe cytopenia with cyclophosphamide and all that, will point to particular OIs. So we should carefully evaluate the entire radiologic finding. You know, the ground glass appearance is staring at you, but you should also look at the airways and see whether some other clues are there. Then we interpret the smear, spatial stains, biomarkers, PCRs and cultures. Then choose drugs based on likely efficacy, likelihood of additional pathogens, and also consider their adverse drug reaction profiles, which will affect that particular patient. Now, like in this patient, multiple simultaneous and sequential infections can occur, and therefore we need utmost care in both prevention and treatment. So finding one organism is not the end of it. You must keep searching for more. This last patient is a 27-year-old girl, lady. She had type 1 diabetes, CKD, and maintenance hemodialysis. And her diabetes was poorly controlled. She received a call to come to Pune from her native Akluz because a deceased donor was available, and the patient was taken up for a simultaneous kidney pancreas transplant. So she needed heavy doses of ATG, methylprednisolone, followed by triple immunosuppression. Now, worsening of her condition occurred and a scan was done, which shows you, if you look at it very carefully, there is a beginning of what is called as a reverse halo. Okay, so that is alerting you to the possibility that this could be a mucor-related infection. And sure enough, after a week or so, you can see that there is a ground glass in the center, which is indicates that it's a reverse halo sign. And often it can be due to many other organisms, but often it is associated with mucor. So based on her diabetic state, receipt of ATG, receipt of severe immunosuppression, mucor definitely comes highest in the mind. So a CT guided biopsy, no time in wasting, see, this is an organism which doesn't have biomarkers. Okay, so trying to do galactomannan, beta-D-glucan and beating, it's literally like beating about the bush. So you'll probably need to go ahead quickly with a definitive procedure. And the procedure here which was done was a CT guided biopsy, which confirmed the existence of mucorales, as you can see here in the stain. And now surgery was needed to be done within a suitable time frame again. The longer you wait, the greater is going to be the problem. And therefore the lobectomy was done, and as you can see, it shows you the pathological features of hemorrhagic lesion like that, which was this. So the question is, what is the choice of treatment? And that is, so would you use liposomal amphotericin B as the prime drug? Answer is probably yes. That is a guideline accepted recommendation. Would you use a combination? That is the next question. And there has been no conclusive benefit of a combo of using liposomal amphotericin B with a mold active azole, although often it is being used more frequently. Now, what do you need to put it into a cast iron recommendation? You will need to show that there is superiority. See, whenever you are going to use a combination, it is not enough to show inferiority or equivalence. Obviously, you are using an additional drug, so you need superiority. Now, to show superiority, you need a very large trial. That is something which is very difficult, and I don't anticipate that such a trial will ever be done. So guidelines do not recommend a combination at the present moment, but at the back of our mind, what do we think? That if there is going to be a benefit of a combo, it will be in those patients who are at a highest risk of poor outcome. Is this patient one where it is expected? Answer is yes. The role of the azole, in addition to the amphotericin, may be that of a supporting drug. If there is going to be an interruption of the dosaging because of alterations in kidney function, if there is going to be an interruption of treatment, and can I actually widen the antimicrobial coverage among the mucorales? Because we know that there are some mucorales species which may be resistant to one or the other. So we have some mucorales which are more resistant to amphotericin B, such as Cunningham. There are some which are more resistant to the azoles. Okay, so there are all funny combinations like that. And so Mucorales, remember friends, is not just one organism, genus or species. There are so many more in them. So in this situation, maybe a systematic review can help us. And this is a systematic review which was done by David Denning over the last almost 20 years. And what did they find in this? The least mortality was observed when amphotericin B and the azole were given together right in the beginning. So if you see this blue bar here, it shows the one with the least mortality. Rather than when the azole was added later, followed by all other treatment options. Now this paper has been criticized also because this is not a RCT, but there cannot be an RCT. And therefore only a systematic review which is done over 20 years where they have looked at so many papers, thousands of papers, may be pointing the way forward. Now there was always this question in our mind that you are giving an azole and you are giving amphotericin B together. Remember that the azole is the one which is allowing synthesis of ergosterol and amphotericin B is extracting the ergosterol away from the membrane. So it is thought that if the azole is depleting the target of the amphotericin B, how will the two work together? But answer is no. As the amphotericin B is extracting molecule after molecule of ergosterol, the fungus which is now under threat is actually synthesizing more and more ergosterol. And how does it synthesize? By azoles, by this 14-alpha demethylase. So if you now inhibit this enzyme which is synthesizing the ergosterol, then you can have an additive action which can be expected as was found by this systematic review. So friends, I will close by saying that ICU patients do not offer the luxury of leisurely investigation. Sometimes, you may have to do this kind of a lobectomy as a diagnostic and therapeutic procedure because you don't even know what is the mold which is working there. So empiric therapy and investigations are often needed to proceed in parallel. So you cannot wait for the galactomannan to come or the mucor PCR come and then I will make a diagnosis, or even for that matter to have the even after an biopsy, we should immediately ask our histopathologist or microbiologist whether you can see something on the calcofluor stain and so on. And therefore, finally, you need to tailor therapy to suit this patient, and that is based on a myriad different factors. And I showed you just 4 cases, but there were so many different factors which we had to consider while choosing. Among those, only 4 or 5 drugs which we have. Okay, you are playing around with those 4 or 5 drugs. Many new ones are coming, but right now we are just playing around depending on the patient profile and the disease and so on. Thank you.
Thank you, sir.
Questions?
Audience, any questions?
Well, very well done, Dr. Soman. In which patients would you consider giving empirical antifungal treatment? And what are the current guidelines which would suggest to a physician, for that matters, to when empirical antifungal therapy needs to be started in a patient who may not necessarily be immunologically compromised?
Right. So this question is most applicable in the ICU, where Candida is the main organism to be considered. So there is a nice way of looking at. I think there was a trial called Empiricus trial, and in that they found that by using drugs like micafungin, for example, there was no mortality benefit. Okay, so the argument is like this, that trying it first is not benefiting. I will try to get the diagnosis on the basis of either beta-lactam or a BDG or the culture, and then treat it. Okay, so this may be one way of looking at it. However, there are many different ways of looking at it. So you must know what is the pre-test likelihood of there being invasive candidiasis in that particular patient. So a routine patient who is admitted in the ICU has only less than 10% risk, even if he is colonized and so on. On the other hand, a person who's got a gastroduodenal perforation, especially a delayed perforation or recurrent biliary leaks, okay, and some cases of severe acute pancreatitis. There the pre-test likelihood is 30%. Okay, now this is an arbitrary threshold by physicians that if the pre-test likelihood is 30%, I am ready to start therapy. Now all other conditions are intermediate. Now if you do a BDG in such a patient where the pre-test likelihood is already 30%, that might go to 50%. But it is already above 30, which is the threshold which I am considering. On the other hand, if you have a patient who is at low risk, less than 10%, even if BDG is positive, that BDG is likely to be false positive. So it will raise the post-test likelihood to 20%, not 30%. On the other hand, it is the intermediate group where there is a ileal perforation, or there are other types which are not very high risk. There if you do the BDG, it will, see that BDG should be done, but it should either elevate the probability or decrease the probability. If it doesn't do any of these things, BDG is of no value in this patient. So what thing that you were asking is very important, that we have to have some idea in our mind like what is the pre-test likelihood. If it is very high, more than 30%, I will start. Now in those patients where candidemia is there, you find that the blood culture has come, you are awaiting the blood culture, but if the BDG has come negative, if you have started therapy empirically, then you will stop it. So that is the additional value. But the problem is, there are so many causes of false positive, like in a recent surgery and gauze and some other drugs and blood products and so on, that it becomes difficult. But yet you can sometimes use BDG for its negative predictive value and not for its positive predictive value. So this, I think, sums up the way one can look at it. In terms of hematologic malignancy population, if you are trying to use biomarker guided therapy, then maybe galactomannan and a HRCT chest will be useful. But again, there are definite reasons why you would use it for AML induction, MDS induction, for HSCT with GVHD late stages and so on. So those might be established indications for mold active treatment initiation.
Sir, this David Denning study, combination therapy worked well. So I haven't read the paper, but one explanation is basically the azoles, we don't do trough levels and they don't achieve trough levels in initial 4-5 days, right? So probably that can be another explanation, or it was just the...
Yeah, see Ashwini, they actually achieve trough levels. In fact, I have published one poster also on that.
They do achieve, but it is like...
No, you measure it after 5 days. But the levels start coming again. In fact, that is the idea of giving the loading dose, so that the trough level can be achieved in 24 to 48 hours. But the time to measure it is only after 5 half-lives. So about 5 to 7 days.
But in practice, so many of our patients, they don't achieve the therapeutic level what we want. Probably it's related to the molecule.
Okay, so that is one more reason for using a combination. Okay.
Good morning, sir. I don't have a question for you. Sir,
Yeah, but somebody else is speaking.
त्याच्या मागचं चालू आहे काहीतरी.
Something else is...
तुमचा मोबाईल चालू आहे?
What is this?
Done.
Some other lecture is playing here.
Oh, hall B असेल. Hall B. Sir, मला काही क्वेश्चन नाही आहे. I just want to tell you something which we have done it without your permission. If you can just turn around and see the tiger, it was clicked by you. And there are many more tigers around which we have picked up from all those you have sent me over last 3 years. And the idea was of Deepak. We were trying to search कौन सा tiger डालना है. तो दीपक said तेरे पास सर ने भेजे हुए tigers है उसमें से select कर. So we selected 3-4 tigers. Then he said सर को बताएंगे क्या? तो मैं बोल दूंगा. Then he informed me, don't tell, तो royalty मांगेंगे तो क्या? So Now,
अभी
if
कल
you
परसों का वापस भेजता हूँ. So I hope you call me again.
if you happen to be in the pharma industry, you can ask for royalty also. So thank you for sharing those wonderful pictures apart from the academic content. Thank you.
Thank you, sir. We'll move on to our next lecture, which is Tropical Infection in ICU. May I call upon stage Dr. Suresh Ramasubban. He's Senior Consultant, Pulmonary Medicine and Critical Care Medicine at Apollo Hospital, Kolkata. Over to you, sir.
Can I have my slide set? Good afternoon. I think I made the mistake of coming in a half sleeve, so all people who are in half sleeves and blouse. Yeah, alrighty. Tropical infection. So how many people agree with this terminology? Is it a right term? I kind of debated because in Nagpur, is it in the tropics or above the tropics? All right, so I kind of beg to differ because I don't like this because half of India, so this is the ancestral North Indian and ancestral South Indian. So anybody below Maharashtra is a Tamilian, isn't it? So all of you are welcome to being in the tropics. But anybody above that is not in the tropics. But so that is a subtropical zone between 25 to 40 degrees, which is between the temperate and the tropic and the temperate zone. This is where most of India lies. But the definition of tropical diseases are diseases that are prevalent in or unique to tropical and subtropical regions. So I would frame this thing as tropical and subtropical, but I would still frame the question as what is called as, so it's not like typhoid wasn't prevalent in UK. It is not that typhoid wasn't prevalent in America. So it is just what is your local epidemiology. When we talk about antibiotic stewardship, we always talk about what is your local antibiotic, local microbial flora, and then based on that we say. So here also it's the same thing. When we talk about tropical infections, it's not the question of what is the infection that is here. It is what is the infection that happened to people in the part of the world where you live in. And we unfortunately, most of us live in the tropics, most of us live in the temperate, in the subtropics. So maybe it's an okay term to use it. But the WHO uses this term, so we will have to respect that. And there are, they have basically initiated an initiative which says interventions against neglected tropical diseases. There are 15 and now they have upgraded to 22. They includes Burili's ulcer, Chagas disease, dengue, chikungunya, echinococcosis, human African trypanosomiasis, leishmaniasis, leprosy, and also concerns snake bite. So it's not a tropical diseases. WHO considers orphan tropical diseases. A snake bite also as a tropical disease. So we have to be very careful about tropical infection. So it's probably the better term is epidemiologically prevalent diseases. So I'm going to tell you this. So this is I'm going to give you a case and then we'll talk about and say, do you think this is tropical disease? And then I'm going to borrow heavily from Dr. Dilip Karnad because all my slides are borrowed from him about how to approach. And this is published in his textbook of API and tropical infection. So anybody who doesn't want to listen to me can open the book. So this is a 51-year-old resident of Assam who's brought to Calcutta for management of high-grade fever with rigor, vomiting, oliguria, jaundice, and pain and swelling over both ankles. Fever was high-grade, 105, associated with chills, and it's been going on for almost a month. Before he started, fever was there for a month before he started really deteriorating. He had done multiple courses of antibiotics, any of the second generation, third generation cephalosporin, quinolones. He was admitted to a nursing home in Guwahati and I think, or in one of the, I even don't remember where exactly in Assam. It's a broad stroke. And then was transferred in view of decreasing blood pressure and progressive multisystem organ failure. He received ceftriaxone, amikacin, piperacillin, tazobactam, and colistin by the time he came to us. All right. So general appearance, he's got a pretty ill-looking guy. Pulse of 130, blood pressure 100/50 on NORAD 0.3 MC mics. Saturation of 90% on 6 liters nasal cannula, temperature 101, he's got pallor, he's got icterus, there's no lymph nodes palpable, coarse breath sounds, no wheeze, no S3, no organomegaly, probably maybe a spleen, I thought I felt, and bilateral ankle joint and swollen and effusion present. Chest X-ray, bilateral alveolar infiltrates, consistent with early ARDS, urine only 5 to 6 pus cells, total count of 34,000 with left shift, platelet 85, bilirubin 3.8, direct is 3, AST 73, ALT 61, creatinine 2.4, blood glucose 201 and lactate 3.5. So how many of you feel that this is a tropical infection? So you feel it's a tropical infection. What tropical infection is this? All right. So what I, as a critical care physician, the approach that I have and what we should, or what Dr. Dilip Karnad is telling us is the way that we work with this is ask the question, what is the clinical or working diagnosis here? What will you say that? So if this were to write a note, assessment and prognosis, so let's not write, it could be a tropical infection. The commonest tropical infection is E. coli. Because Ganga Jal mein E. coli hai. So the commonest tropical infection, it's very important to understand is the commonest tropical infection is E. coli infection in your urinary tract. So yes, it is a tropical infection because by default he lives in Assam, which unfortunately is not in the tropics. Assam comes above the Tropic of Cancer. So it's a subtropical disease. But yes, so the concept of this tropical infection that I'm trying to get to you is that this is what we need today is what is the working diagnosis here? So he's got every organ failure. So the very simplest working diagnosis would be that this guy has got a multi-system organ failure. Or if you are going to listen to the next talks, you will say that this is septic shock or sepsis with multi-organ failure, whichever way. Sepsis itself says multi-organ failure. So you can put it in any way because you're sure that this is an infection, fever for such a long time and so on and so forth. So this is one of the things, or what we would like to say is this patient has multi-organ dysfunction syndrome because he's got respiratory syndrome, hypotension and shock, rash, hepatic syndrome. This is the various clinical presentation, or the clinical presentation can be because of multi-organ dysfunction syndrome. If people present only with one or two, and I'm going to give you the various differential diagnoses for all these presentations and what happens, you can then come up and say that it is possible to come up with a diagnosis. So these are the 5-6, the ISCCM has a position paper or a guidelines on Dr. Rungta had written in 2013, which has mentioned that these are the 7 tropical fever clinical syndromes that we present with in our country. Respiratory syndrome, hypotension and shock, rash, hepatic, renal, altered mental status, seizures, thrombocytopenia or coagulopathy, or in our instances, every organ is involved, so it's a multi-organ failure. So when you look at, as I said, this is borrowed from the API textbook of medicine. So when you have fever with respiratory syndrome, you are starting to think a little bit more. So probably we are thinking COVID, the triumvirate is Brahma, Vishnu, Shiva, is RSV, influenza and COVID. So this would what would come to our mind, especially if he's not responding, but then the duration is too long. But what are the various tropical diseases or diseases which are prevalent in our country which can cause an ARDS or a fever with respiratory syndrome or a fever with pneumonia? So leptospirosis, malaria, scrub typhus, miliary TB, melioidosis, plague are a possibility. And others, obviously, it's an atypical pneumonia, or it's not a pneumonia. We can have a diffuse alveolar hemorrhage or a hypersensitivity pneumonitis. So the differential becomes very high. But in our country, when we think infection, these are the 5-6 top diseases that will come to when we say fever with respiratory syndrome. When we say fever with hypotension or shock, then the differential is obviously if you have large volume stools, you have cholera, malaria, dengue would, in this part of the world, and right now would be the #1 diagnosis for somebody presenting with shock. Scrub typhus, again very common, typhoid, leptospirosis, Chagas disease in different parts of the world. And of course, the standard E. coli urosepsis would also be a state thing. And you can have a myocarditis from whatever cause, or you can have any of these things with fever with hypotension or shock. A viral myocarditis, a Coxsackie virus myocarditis, a CMV myocarditis will also present with fever with hypotension and shock. But these are not specific to tropics. But this is the differential that goes through. The common cause of fever with rash, again dengue and chikungunya, scrub typhus, rickettsial fever, meningococcemia is something which we really need to pick up because that's something very common. We see typhoid and rose spots, never in our color of skin. We would hardly ever see that. But yes, in a pale white man or white female, you might probably be able to pick up the rose spot, but otherwise not very common. Any drug reaction, dress syndrome, all those will present with eosinophilia and a rash. But as I said, vasculitis would be the #1 differential diagnosis in a patient with a rash who comes in with fever. So lupus, undifferentiated mixed connective tissue disorder, Henoch-Schönlein purpura, all these will become much more higher on the differential diagnosis, even though they are presenting with fever. So when we say fever with rash in a tropics, it is dengue and malaria which is #1. But you cannot forget that lupus and chikungunya, lupus is also as common, and Henoch-Schönlein purpura would be equally not uncommon. And acute HIV infection will also not be very uncommon, especially in most of the this guy is coming from Guwahati, so this could have been a middle alcoholic man who's coming from there is going to have a HIV. Is a very high possibility that this guy's infection, what I presented to you, was an HIV. Fever with hepatic syndrome. We are the capital of hepatitis A, hepatitis E. We see that. We see a lot of dengue. We see a lot of leptospirosis. Any hepatotropic virus. We see a lot of EBV now. We see a lot of HSV, CMV. All are the dengue is the classical hepatotropic viruses. We don't see yellow fever, but we also see a lot of paracetamol poisonings. We see a lot of drug-induced hepatitis with our INH and rifampicin that we see. So we also see obstructive jaundice. So again, the differential diagnosis with fever with hepatic syndrome, fever with renal syndrome, classical you will have is leptospirosis. Malaria will present with fever with renal syndrome because of intravascular hemolysis and in acute ATN. Snake envenomation, again, because being a tropical disease, will present with an acute renal failure. So any textbook of medicine, when it gives you a fever and an approach to a tropical disease, it will give you non-infectious cause of the differential diagnosis also. So we need to keep that in mind when we work that up with anybody with fever, because the gold standard is difficult. Fever with gastrointestinal syndromes like blood and mucus, you have amoebiasis, bacillary dysentery, watery diarrheas are typical for cholera. Typhoid is again initially constipation, later diarrhea. Malaria can have, algid malaria can have diarrhea as a presentation, if you cannot forget that. And acute pancreatitis, especially with a tropical infection like Ascaris, can cause a pancreatitis and can present with an acute pancreatitis. So these are the fever with gastrointestinal. Next talk is fever with altered mental status. Venkat is going to speak on the various encephalitis syndrome. But again, a lot of alcohol withdrawals, drug overdose, mimics of autoimmune encephalitis, all will become part of a differential diagnosis of fever with autism. The classical one with fever with thrombocytopenia or coagulopathy, again malaria, #1, leptospirosis, dengue, scrub typhus, all are #1. So what I tell you is the top 5 diseases that you know in any differential diagnosis. Itna table padha ke, dikha ke, the purpose is only to tell you what are the top 5. The top 5 is what is prevalent in your institution. So tropical is not so it's whenever you think of sepsis, you are saying, is it the common E. coli and the Klebsiella that the Americans see, or is it something that I see more often than others? And is that malaria, dengue, typhoid, and so on and so forth? And we see a lot of scrub typhus and we see a lot of leptospirosis. These are the top 5 organisms or top 5 infections in tropical diseases, irrespective of what the presentation is. You just cannot say there is no GI manifestation, so therefore it is not typhoid. You cannot see there is only ARDS, so it cannot be leptospirosis, and so on and so forth. So that is the purpose of this presentation. But so eventually the schemata, or what I look at is, when you look at multi-organ dysfunction syndrome like this, and you say, okay, Dr. Udvadia's textbook has a wonderful table, I copied it from here. So it gives you what are the causes of multiple organ dysfunction when they present to Bombay, and he has got a huge, his textbook will give you all the patients that he has accumulated over many years, and then he will tell you that these are the various causes that he has seen, organophosphate, snake bite, poisonings, and all those things will come there. But what is important is when you look at infections, it looks at bacterial, viral, and fungal. This is the American textbook. But when you look at infection as a whole category, you have to understand that leptospirosis is a bacteria, it's a spirochete. So why shouldn't it be there? As simple as that. So there is no real reason to say a tropical infection. We just have to say what is a locally prevalent organism as a cause of multi-organ dysfunction. And for us, it would be malaria, dengue, and typhoid, and leptospira and scrub typhus to add on to this thing. All right, now that you have heard this and you heard the case scenario, do you still believe it's a tropical infection? There was only one person who thought it was a tropical infection. I still have, okay. So I'm going to go forward. So what we do is, how do we evaluate this in a tropical area? So this is taken from the NEJM sepsis review article, and I am quoting it verbatim. It says the clinical evaluation focuses on confirming the site and cause of infection, which is what medicine people do, as well as evaluating organ function and perfusion, which is what anesthetists do. So a combination is what critical care physicians do. That means we do both these things together, and that's what we are doing this. And this is what we need to do, is to confirm the site and cause. So you need to have an anatomical site of infection and a microbiological etiology of the infection. And that is the number one message that I want to give you. You cannot diagnose sepsis without having this. The best term for this patient who presented from Guwahati, from Assam to us, is I'm going to say that it's an undifferentiated sepsis and I'm unable to localize a site. That's because I'm incompetent? Sure, Dr. Ramasubban is not really smart, I understand that. But yes, that's a very easy diagnosis. And this term is a valid term, acute systemic sepsis. And this is, I'm just going to keep to this slide here. This is a slide from Manipal Medical College, presented as 1,000, along with the University of Netherlands. They have looked at 1,000 sepsis patients admitted to Manipal. And they have looked at what is the number one cause in India. And you look at 49% of patients will have an acute systemic infection. That means you have an acute systemic infection, they will have Casanur forest disease. We don't have that because Casanur forest is in the Udupi area. So they will have that. But what they are seeing is Orientalis Tsutsugumashi is there, 41 cases out of 250. Out of 200. So that means scrub typhus is very common. But again, for them, E. coli is very common, Klebsiella is very common, melioidosis is very common, leptospirosis is the number one disease, 100 out of 500. So it depends on where you are. So in the tropics, this is a very good example of what is the organism that is prevalent. And you see a pie chart which is not able to tell you anything in common. You cannot really localize to anyone. But yes, dengue, leptospira, all these top five will come really prevalent in this. And if you look at UTIs, then E. coli, skin infection, CNS infection, all these things, again, some tropical infection will creep into this diagnosis. So let's going back to this. This is from the ISCCM position paper. We need to identify the focus and say whether it's a pneumonia or something. And this is what is the sources of sepsis. You need to identify the anatomy and say whether it's a GI source, a genitourinary source, pelvic, lower respiratory, intravascular, cardiovascular, or what is the source, and then what is the anatomy or what is the microbiological etiology following that. This is a very good table from Up to Date, which I like to say that this is the evaluation that you need to know, because when you localize with a history and physical, it's a medicine. So you need to localize with your history and physical examination where the infection is. Once you do that, you need to send an appropriate thing. We have had a lot of people with unable to swallow and a significant Vincent's angina who are very septic. And my first Zygress in my life in 1998 under Phil Dellinger was for that. So I still remember that we gave activated protein C to save a peritonsillar abscess. So it is possible that you can be so septic and with source control you can get better. So it is important to understand that this is the way in which you look at and to localize it. Bone and joints are generally not a cause of sepsis. Dr. Soman will probably agree because they're not that vascular, but yes, it is possible in certain tropical infections, and which is what it is. So our examination in my patient was to identify whether there is any localizing site or infection. So this is from the API. This is from the Association of Physicians of India. They have a very beautiful position paper on how to approach. It's published in JAPI. It's free online. About what you do for evaluation of a patient. And it says a search is required. A complete and thorough physical examination is mandatory. You have to evaluate key features to find out for undifferentiated febrile illness, or what we call as fever with sepsis with unknown source. So that is very important. The first step is to go through these diagnostics tests, and then they will tell you for malaria what you need to do, for dengue what you need to do, for chikungunya, leptospirosis, scrub typhus. I'm not going to waste your time into saying that this is what needs to be done for a tropical fever. Going back to my case, I'm going to finish that very quickly, and I'm going to say, so what did you think was the case? Do you want me to go back to this case? And so if you were to go back here, yeah. So resident of Assam. And now, what tropical disease could this be based on this thing? It's not a quiz. I'm not saying that anybody can do it unless we send a specific set of things. So what is it that pointed our attention here was only one thing in the physical examination was abnormal in a septic patient. That he had significant ankle joint, solar and effusion was present. So maybe is this a skin, so this is not a tropical infection anymore. So this is a skin and this is an infection which is localized to bone and joint, because that is very unusual to have. Maybe if it was just arthralgia, it was okay. But anyway, so now with that knowledge, multi-organ dysfunction coming from Guwahati, failure to respond to antibiotics, what tropical disease? What's that? Absolutely, spot on. Spot on. Melioidosis would be the what we identified here also. And so the diagnostic tests that we need to do in all these people are obviously the all these standard blood and this thing. But more importantly, you have a confirmatory test for all these things we're not going to click through, is the fact that you have to have the essential investigations, which are rapid diagnostic tests for malaria, dengue and typhoid and things like that. But that's where it stops, the guidelines also. So we need to have a joint aspirate in this patient. So the anatomical diagnosis in this patient was blood cultures grew gram negative, ankle joint was 7500 WBC, and the diagnosis, working diagnosis, was a sepsis with a BGI source, and it turned out to be melioidosis. So I know I'm kind of, the topic that is approach to tropical disease. So I use one illustrative case to bring to you that the fact that anytime you approach a tropical disease or whatever infection comes to us, the standard infection and the data from Mangalore is very strong that malaria, dengue, typhoid, scrub typhus and melioidosis are the leptospirosis. These top 5-6 diseases need to be considered in every patient who comes to us with a fever or sepsis or an undiagnosed multiple organ dysfunction syndrome. Thank you very much for your kind attention.
Thank you, sir. Any questions?
Well, there are three small...
One small comment, Suresh.
Yeah.
The last part of it is not a BGI source.
Yeah.
It is actually bacteremia with a metastatic source in the BGI.
Absolutely. Agree. The semantics is, sir, is absolutely right. But since it...
Semantics. It is the mechanism, pathophysiology of it all.
I have the slides on that also. I agree with you 100, sir. In the sense that the approach was that there was something that we found a source where we could get a diagnostic aspirate, and that's important to identify. That is the message that is got through. Whether the seeding happened in infective endocarditis, also we see skin manifestation, doesn't mean that the skin is the source of the infective endocarditis. So it is very well pointed out, sir, that it is not the vice versa. It is the hematogenous seeding of melioidosis which has led to the joint inflammation. So we have a series of 8 cases we had presented. The last slide was that. But we do see in Jharkhand, in rural areas, but now everywhere in India we are seeing melioidosis. It used to be only in a few areas, but now it is one of the, and the Mangalore registry also showing that there is a significant prevalence of melioidosis in our country, and scrub typhus is obviously the number one etiology in North India, especially we will see a lot more in that part of the world.
Well, in your talk, do you consider that in any patient who is suspected to be having a tropical fever in the ICU, empirically all of these should be on ceftriaxone and doxycycline? One. Second, do you also consider the possibility of, say, macrophage activating syndrome or AOSDs in patients who have tropical-like fevers?
Sir, ceftriaxone is not needed. Everybody is on meropenem. So I don't think ceftriaxone is the choice anywhere. Any local nursing home will give you meropenem. So meropenem is good for leptospirosis. Meropenem is good for typhoid. So I'm okay with that. But yes, the antibiotic. So, and the question is, should anybody die in this world? Any infection should die without doxy? The answer is no, because rickettsial infection are something. So my boss in the US always used to say, nobody should die without hydrocort and doxy. That is that if you're dying. But if you have time, you should always evaluate it empirically. The ISCCM guidelines do say if the evaluation is positive, then only give, otherwise it is not to be given. And macrophage activation syndrome, as I said, in dengue we see a ferritin of 15,000 on day 6. Does that mean it's a macrophage activation, or is it a hepatotropic virus multiplying in the liver? But if the ferritin is 40,000 on day 11 with a persistent fever and a bicytopenia in a dengue, that definitely is a tropical infection with a macrophage activation or a HLH kind of a syndrome that you are having. So it is, I think it is the context in which we have to look at. Tuberculosis leads to macrophage activation syndrome, typhoid leads to macrophage activation syndrome, any infection leads to macrophage activation, dengue leads to macrophage activation syndrome, lupus, mixed connective tissue disorder. So MAS should be considered in any patient with fever, bicytopenia. So I think that's where it has to be considered in the differential diagnosis, but not empirical.
Dr. Zaglin, it appears to work in many situations because it is an excellent immunomodulatory and anti-inflammatory actions. And those actions have been explored in many studies out of infectious disease and critical care. So that's the reason, I mean, if you put patients of IV doxycycline, you can see the CRPs is going down, even in you're not targeting the pathogens.
Okay, thank you, sir. We'll quickly move on to our next lecture, which is diagnostic approach to meningoencephalitis. May I request Dr. Venkatraman Kola, sir, to please come on stage. Venkat Kola, sir, he's Clinical Director, Department of Critical Care Medicine in Yashoda Hospital, Hyderabad. He's also founder and director of SPASH Critical Care Team, and he has served ISCCM as Vice President for the year 2025 to 27. He's faculty examiner for DRNB and ISCCM. He's also author, editor for many critical care textbooks, and in addition, he has got many national and international publications. Thank you, sir.
Yeah.
Over to you.
Thank you. Good afternoon. I think it's a session just before lunch after two very eminent speakers whom we have been actually looking up to when we actually initiated our medical school days. So next 15-20 minutes, I will be trying to focus on how do I approach a meningoencephalitis. It's more like a intensive care based, not to a detailing about each and every pathogen related. This will be my outline for the next 10-15 minutes. So WHO talks about a fever within 5 to 7 days, change in mentation, any of those criteria which I'll talk about can be considered as a meningoencephalitis. Terminology wise, encephalopathy, when you have an altered sensorium longer than 24 hours, encephalitis, you need to have a couple of them, either a fever, seizures, or a CSF showing pleocytosis, ECG findings suggesting a temporal predominance focal issues, or a neuroimaging suggesting some encephalitis. So that's a terminology wise that. So we talk about meningitis, encephalitis. Generally the terms where we show only meningitis, where there is no cerebral functions were involved, there is no dementation, whereas encephalitis, where there is an altered mental status, or there is a focal deficits, or there is a behavioral changes. Meningoencephalitis we talk when there is an overlap of both of them. The typical pathogens which actually predominantly causes a meningitis are these, this varicella, HSV2, measles, mumps, whereas encephalitis is predominantly by HSV, influenza, EVB and all. This was a epidemiological data from our vector-borne diseases, which actually suggest Japanese V encephalitis, dengue virus, HSV, measles. These are all the predominant viruses which we talk about. Many of them don't have a therapist to offer. And probably in a larger database across the globe, 60% of the cases we don't find a etiological agent identified. We all know it can be spectrum from virus, bacteria, fungus, but we also see in a current status, in my ICU, I have a patient where the CSF panel is a typical presentation of encephalopathy leading to encephalitis-like picture, but all the workups of CSF bioforms, PCR panel were negative. There is a mild pleocytosis, the proteins were mildly elevated. We didn't have any clue of organism, and this is not uncommon in many of us. Herpes simplex remained to be the common cause for sporadic cases. In India, Japanese B encephalitis remained to be the most common. Western world, West Nile fever may be there. We are seeing some emerging infections like we were talking about scrub-related aseptic meningitis or meningoencephalitis, typhus causing them. And Nipah and Zika, we have seen some surge in the recent times. These are again a spectrum of list where viruses, bacteria, parasites, fungus all can cause meningoencephalitis. Because it is an approach to meningoencephalitis and it is a broader term, I'll just trying to focus that these can be get overlapped by many like a cerebral malaria, toxoplasma, cysticercosis, echinococcus, histoplasmosis, or some of the tubercular meningitis also. So before we actually level them, for example, that middle-aged gentleman, 51 years, which came to us with an altered sensorium with GCS around E2, M2, VT, as I said, MRI could not pick up anything, and we need to rule out. We were all talking about toxins to them because there can be acute toxin ingestion, something like we see many benzodiazepams or any toxin which can immediately cause an altered sensorium. So toxin will come as a rule out phenomenon. Metabolic encephalopathy, we send an ammonia. We do see with liver being normal, hyperammonemia can be a problem. Uremia, hypoglycemia, any other metabolic components need to be ruled out. And probably a MRI will rule out a tumor or a ADEM and other status. And probably venous thrombosis, intracranial parenchymal lesions need to be ruled out. And a head injury with probably a concussion leading to diffuse axonal injury also need to be ruled out. So we all know it's an inflammation, edema of infected cerebral hemispheres, sometimes brainstem leading also cerebrum and all of the myelitis also. And there can be a direct invasion related causes, and maybe there will be a focal small areas of hemorrhagic necrosis and sometimes vasculitis leading to areas of multiple small necrotic or ischemic zones. So the approach in these situations will be, we start with the history. This will be a demographic history, travel history, exposure to rodent, ticks, mites, mosquitoes, vector-borne issues, transfusion, transplant, immunosuppressions, all. Animals, pets exposure, sexual activity exposure, and patients with any symptoms of viral exanthems need to be taken care. And typically the hydrophobia, aerophobia, all those will come with the pharyngeal spasm in a rabies-like things. The symptoms which we generally look for when we actually look at encephalitis is fever, headache, neck stiffness, nausea, vomiting, body aches, or the seizure, neurodeficits, rash, and joint pains. Generally, when these cases come, we talk about ABC. Either we protect the airway according to the GCS and look those basics done. And we look at the basic clinical examination and neuro examination, pupils, fundus, lymphadenopathies, give a tropical heading with a scrub, rash, eschar, I will talk about how they can give you a clue about viral exanthemas and giving a differential. Whether it is a purely meningeal or meningoencephalitis, focal deficits, abnormal reflexes, systemic examination can be a clue. These are some of our clinical presentations with encephalitis which may tend towards an organism. For example, I have a patient with hepatitis along with encephalitis. My HSV, probably enterovirus, coxilla will be a common. Lymphadenopathy, scrub, we see generally a lymphadenopathy with EVV and others can be a. Parotid, we know mumps. I said rash or exanthemas, we talk about HSV, varicella, rickettsial, syphilis, rubella, all that come under rash. Respiratory illness, influenza, maybe other respiratory related viruses including Nipah has been linked to that. In the same way, retinitis, ataxia, dementia, where we see Parkinsonian features with Japanese bee encephalitis and many like that. So these are all clinical presentations of different organ system along giving a clue about this is again a papilloedema, herpes simplex vesicles, which can be given a Shingrix and chickenpox rash. West Nile viral fever and rash has been there, hand, foot, mouth disease with this kind of hand and lesions in the mucosa can be given a clue. Rocky Mountain spotted fever, the typical rash which you are seeing can give. We all know about this Kernick sign when you actually flex the knee and hip with 90 degree and extend it, when you actually elicit a pain of a nuchal inflammation, or a Brzezinski sign with elicits a hip and knee flexion. When you actually flex the neck, you get a elicited hip and knee flexion. This can be a signs. Laboratory examinations, again we do a routine ones, and probably some of those routine examinations can give you whenever a neutropenia is there, probably a rickettsial illnesses can be a thrombocytopenia. Eosinophilia talks about a toxoplasma retoxocara and others. And hyponatremia, SIADH can give you other clues about the others. So these are all a few of the clues which I was trying to talk about. As Dr. Ram was talking about in this, initially when a patient comes to you with an altered sensorium, many of the times you don't have a pinpoint focal diagnosis. So in that time, probably a routine investigation. Along with that, probably CSF cell count, gram stain, acid phase stain, and probably keeping a sample. Most of the times what we do, urine screening, metabolic studies, and lastly, I will come to that autoimmune workup. EEG most of the times is non-specific, except maybe temporal lobe focus in herpes, encephalitis. CT scans to rule out most of the times to any space-occupying lesions or intracranial bleeds and all. MRI, as I said, the mimics where I have a demyelination, I will look whether it is a gray or white. Depending, I can rule out my ADEM. If it is in white matter and it can stick to a gray matter, I probably keep the meningoencephalitis on that. And again, location-wise, we all talk about herpes simplex will be a temporal predominance. In the same way, if I have a thalamus and basal ganglia involvement, I talk about respiratory viruses as common influenza, parainfluenza, and probably Caesar disease, arboviral, tubercular. West Nile, again, basal ganglia, thalamus, and A. And post-infectious, we see multifocal and subtentorial white matter involvement. When I have a hydrocephalus, we talk about probably bacterial and probably tubercular and fungal, then they being a viral. And these are different images of MRIs where we talk about the different locations. Locations-wise, we pick up the possibility of encephalitis. This is the approach. When I have a patient with headache and nuchal rigidity and fever, I ask a question whether my patient has an altered mentation. If it is yes, probably I'm talking about encephalitis or ADEM or encephalopathy with mass or abscess. I obtain blood culture, I do an MRI brain. I get a mass, I know it is an abscess or a tumor. I don't have a mass-like lesion. I look at whether it is a gray matter abnormality or a normal MRI or white matter. If I have a white matter abnormality, I talk about ADEM and work up to that. If I have a gray matter abnormality or a normal MRI, like in our case, I keep my encephalitis diagnosis on, and other than blood cultures and routine, I also do a lumbar puncture and probably a EEG. If I have a lymphocytic pleocytosis with normal glucose or slightly elevated to normal protein, I keep my viral encephalitis on and I probably send HSV or a panel in them. If there is a neutrophilic predominance, gram stain and cultures gives a clue. How do we manage? It's again the standard supportive care. The specific things empirically when I actually deal with a patient with meningoencephalitis, till I get a clue and my reports back, probably I will be on IV ceftriaxone, vancomycin and doxycycline. Only in situations where you have endemicities of malaria, you use those antimalarials. These are again treatment. We were all more of confining to acyclovirs in HSV and VZV, but when we see a CMV on others, probably ganvanciclovir and others should be considered at that. I'll probably end my talk in next 2 minutes talking about few of our experiences. This is a 15 years old male was transferred to some of this part, middle central India with high grade fever, headache, vomiting, recurrent convulsion. The typical motor system revealed, examination revealed a cogwave rigidity, predominantly in right upper limb and a masked face. These are typically seen in Parkinsonian patient. Somebody comes with an encephalitis at the age of 15 with a Parkinsonian patient, it is a clinical clue, clinical pearl that probably I'm dealing with something related to probably a disease which is Japanese B encephalitis. So this is again a symmetrical hyperintense thalamic, basal ganglic and midbrain lesions. And this patient was a classic of Japanese B encephalitis, which again a clinical clue is they will behave like a Parkinsonian patient. I will not go in through the when do you suspect, what is the therapy. Most of times we actually get it from a panel and the management remain to be supportive with probably 30-40% of mortality in spite of a best of the care. This is again a 6 days history of fever, headache in a 49 years old guy, altered sensorium and later had a GTCS. And you actually can see there are probably AST, LT elevated, and the platelet count were slightly low, malaria was negative, and this patient turned to be a dengue virus NS1 positive. I think why I brought this case is I wanted to put across the commonest cases we see. Japanese bee encephalitis in this part, dengue fever in our part. It's very common. In the last maybe couple of months, I must have been seeing not less than a half a dozen to a dozen of cases with dengue encephalitis. Most of the times the MRI remained to be normal and supportive care, and we saw 70-80% of this patient do well when the other organs remain to be stable. This is again one of the cases like comes from the Uttarakhand background, encephalitis features with that kind of a scar. You know this fits to a probably a scrub typhus category where you actually use doxyazithromycin as a therapy to them and they get better. Influenza, generally we see them to affect respiratory system, ARDS, but again, some of these patients land up into multifocal leukoencephalopathies with encephalitis features, and these post-infectious, post-immunization encephalitis are not uncommon in current era. Again, in our case, as I said, all were negative. My procal was bottom low. I had no clue after 5 days of therapy. So probably in situations where I have some points in favor of autoimmune encephalitis, young females, acute to subacute onset, memory loss, pleocytosis, ECG with slow wave activity, reasonable exclusion of all infectious causes, probably I will think about a possibility of an autoimmune encephalitis in them, and I will work up anti-NDMA, NMDA receptors antibodies, and imaging to rule out a possibility of a paraneoplastic phenomenon in them also. So some of these patients need a IVIG therapy and tumor resection, and this is anti-tumor, anti-NMDA receptor encephalitis features. I wanted one or two things to be predominant: insomnia, memory deficit, psychosocial behavior, psychiatric manifestations in a patient with encephalitis, encephalopathy, in a young female, subacute, acute, all in workup of infective is negative. Keep a watch on possibility of a autoimmune meningoencephalitis. I do understand we talk about, and the therapies remain when I actually level it as a meningoencephalitis. We pulse them, we ensure that all the infective etiologies, and we keep a shared decision with the family pros and cons. And the other options of IVIG, plasma exchange, and rituximab, cyclophosphamide comes in a later part. We also use PET-CT as a modality to diagnose them over and above MRI, and a functional MRI to diagnose some of these autoimmune encephalitis. These are again textbook mentioned different inclusion bodies which can be done antemortem. I don't know. I have no experience of looking at these inclusion bodies. Probably this can be an indirect clue if I have a CMB somewhere else. With this, I carry my regards from the Institute of Yashoda Hospital. Thank you.
Very wonderful and elaborate talk, sir. Any questions?
I'm Dr. Bande from Pune. We recently, in the first half of this year, we had a series of chikungunya encephalitis, though it is not a biofire regular panel. But when tropical fever panel was sent, it showed the chikungunya. And then we found that similar cases cropped up again and again. Most of them elderly and diabetic. Very bad prognosis. And half of them had even peripheral motor neuropathy. And quite a few we had to withdraw because family couldn't support. It went on for 2 to 3 weeks. Very few recovered. So not a very common, and I think sporadic cases are reported. I don't know if Dr. Amit has spoken to Dr. Soman before, but we had a series of cases, may get published. But that is one of the differentials we can always have in the mind.
Absolutely.
So there is
Agreed.
no specific treatment.
So vector-borne seasonal epidemical sporadic cases of dengue, chikungunya, other viruses, unknown viruses, and zonal related, as we were talking about some of those viruses, are very common. And yes, many of our panels may not cover all of them. So they still remain to be unidentified causes of viral encephalitis.
That is a problem because there are a lot of non-neurotropic viruses causing encephalitis, like dengue, chikungunya. These are non-neurotropic, measles, mumps, even influenza. So you do not suspect them to cause meningoencephalitis. So that is a problem, and they are not covered in the panel. So I think we have to look into that also, recurring at the circulating pathogens.
True, absolutely.
Due to shortage of time, we are not taking any.
Sir, some autoimmune disease like SLE or
or other part medium-sized vasculitis, they can present with both fever as well as ultrasensorium or ultrasensorium.
Yes,
So,
absolutely. So we are talking about CNS vasculitis or lupus flare in the form of seizures. So whenever you have a multi-system involvement, I expect a lupus patient only presenting with isolated CNS lupus or a vasculitis is phenomenally low. But we do link them. As I said, the mimics, you need to rule out those autoimmune encephalitis possibilities, including lupus vasculitis, which can present like a differential in them. I agree with you, sir.
Thank you, sir. Due to shortage of time, we are not taking any question. कल्चर से हमें पीसीआर पर शिफ्ट होना है. कल्चर से हमें पीसीआर पर शिफ्ट होना है. रैपिड डायग्नोसिस से हमें इन्फेक्शन का पर्दाफाश करना है. With this share, I want to invite respected Dr. Raju Soman sir for his talk on rapid diagnosis of infections.
The molecular companies should hire you for the promotion.
Yeah, so this is the top. Next slide. So rapid diagnosis of infections, and I think what Ashwini just said, it sums up the whole thing, that should I show my conflicts of interest and all that here or what? Because see, the idea is to focus on diagnostic and therapeutic stewardship. So obviously in critical care, there is no luxury of waiting for the entire syndrome to evolve. And Suresh also told us so nicely that, you focus on one or two things and over a period of time, things will evolve. But we don't have that luxury. We have to have some kind of a syndromic diagnosis and begin treatment. So optimization of tests and treatment is needed both to curtail overuse as well as underuse. See, stewardship, people keep thinking that it just means that not to use antimicrobials or something like that. It's not like that. The real meaning is right dose, right patient, and right time. But all these new tests really need a thoughtful integration into the practice. Okay, so that thinking and, every physician must understand how will I incorporate this new test in my practice, in which patient, and so on. The environment is definitely more complex. The patients are complex, their relatives are even more complex. So our work environment has to contend with all these issues, whether we did the test, didn't do the test, you found something, you still didn't treat it. Okay, so these are questions which we will have to really understand. But ordering a test is simply an instinct, like a dog chasing a car. First, the physician must consider what to do if something is found or what to do if nothing is found. So these points are very important before we, in our rush to embrace the molecular and genetic tests. Now, a molecular test may show the true pathogen or pathogens, may also show superinfectors, may show colonizers, and might even show only ghost nucleic acid material when you are doing it from normally non-sterile sites. Okay, so all these considerations are very, very important, and it will also depend on when in the course of the illness has the test been done, what prior antimicrobials the patient has received. Now these, we accept that these are potentially more accurate, and when the tests, the accuracy of the diagnostic test potentially exceeds that of its predecessors, there can be two conclusions. It can appear as less specific because it is picking up many more things and you don't know what to do with them, or less sensitive, but all this against an imperfect reference because the right answer is actually not known. So in this situation, can you rely only on the test? Answer is probably no. You will have to rely in clinical practice like how we do every day. So you take the test, but you also use multi-test comparators. So you use a molecular test like a genetic test, but you also use a biomarker. You also use clinical adjudication, because this is actually emulating the clinical practice of putting multiple inputs together. So only not just the test, but also your clinical, radiological and other inputs. Let's take this patient. So here it's interesting that this was the pneumonia panel was used, and actually we treated the patient for everything that was seen. Now that is something which the microbiologists will sort of blow their top, but let's look at this patient. So this is an 81-year-old male. He was admitted elsewhere for severe lumbar spondylosis, received a large dose of steroids for his root involvement. He developed a UTI with a CR pseudomonas and was treated with colistin, but that led to nephrotoxicity. So he became oliguric. He developed marked drowsiness, and yet he received feeds, likely leading to aspiration. But because he was also oliguric, probably pulmonary edema. And with this, the patient was transferred to our hospital. So he was found to have severe hypotension. He was intubated and ventilated. A review of his previous X-rays and the current X-ray shows that the aspiration pneumonia has occurred. So within a space of just 1 day, this large opacity has come up. But remember, it could be fluid, it could be aspiration. So blood culture, BDG, a tracheal aspirate lower respiratory panel was done, multiplex PCR, and cultures were done. Now this patient happened to be quite unstable, even to be sent for a HRCT. Now remember, he had this pseudomonal infection in the urinary tract, and so these drugs were used in appropriate doses. Along with metronidazole, micafungin and SLED was also initiated. Now I will have to justify why all this has been given. Now, what was found in the LRTI panel? 3 bacteria with bin values of 10⁻⁴. So this is Enterobacter cloacae, it is Klebsiella pneumoniae and Staph aureus, and these are the resistance markers. So your CTXM, NDM, OXA48 as well as MEK-A, MEK-C and MREG. Okay, then this was a lateral flow assay from the tracheal aspirate, which is showing that this is Aspergillus. And the tracheal aspirate galactomannan was 4.76, done in a quantitative fashion. The serum galactomannan was also positive, and the serum beta-D-glucan was more than 300 or something like that, quite strongly positive. So let's look at this patient in somewhat detail. So what are the various host factors and what are the various clinical features? So he was drowsy, yet he had a feeding. Steroids were received. I showed you this. So endemic coronavirus is also present in his LRTI panel. He had a poorly maintained line because he came from another place and he had received steroids. And so if you look at the clinical features, probably this is aspiration of upper respiratory organisms. So maybe the LRTI panel has picked up colonizing flora, but these colonizing flora are the ones which have been aspirated inside. Okay, so at this stage, we may elect to actually treat them. Okay, so although this bin value is only 10⁻⁴, and certainly they are likely colonizers, in this particular instance, because of a strong suspicion of this being aspiration pneumonia, I would like to treat it, and therefore this would be the relevant treatment. Now, did he receive steroids? Does he have endemic coronavirus? Yes. Now, he also has what looks like a nodular infiltrate, and his galactomannan and everything was positive, and therefore I would like to cover for Aspergillus. He had a poorly maintained line. He had fever and hypotension. So again, this syndromic assessment comes up here. And therefore, I might think of Candida, and his beta-D-glucan was positive, which could be an indicator of his Candida. Maybe micafungin is justified for that. And he has received steroids, he has dyspnea, hypoxia, although there are no GGOs, at least on the X-ray. That is one thing which may cross our mind, but this is a acutely given, the patient has received steroids only acutely, and although beta-D-glucan is positive, PCP seems to be very, very unlikely, and if at all it is there, maybe the beginning of treatment with micafungin might help. So this case tells us that the diagnosis of IPA rests on three pillars: the host factors, the clinico-radiologic syndrome, and the mycological test. Now the difficulty in such a patient who has is that we may want to do a bronchoscopy for that, but bronchoscopy itself might certainly put the patient at risk of landing on a ventilator if he is not already on a ventilator. So is there any other option? So we know that in a non-neutropenic patient, the serum galactomannan has very low sensitivity, and therefore maybe there is a case for using tracheal aspirate galactomannan. So in those patients who are at risk, so the pre-test likelihood is high because the patient has host factors and a relevant clinico-radiologic syndrome. In such patients, using this kind of a tracheal aspirate galactomannan could be helpful. I'm not saying it may have a high positive predictive value, but it will allow you to start empiric treatment. And on the other hand, if it comes negative, then there may probably be no need for doing a bronchoscopy. So you could perhaps even avoid bronchoscopy in this situation. Now in blood culture, what came up again was E. faecalis and Candida glabrata. Again, that was not very surprising. The patient had come from another place, which was, probably infection control measures weren't that good. The patient stabilized, his HRCT was done, and now you can see that there is both crazy paving and ground glass appearance, which goes with the previous endemic coronavirus, and you also see confluent nodules, which go with either a bacterial or a combined process of bacterial and fungal. The next question is, when would you believe the rapid diagnostic test? So here you have a liver transplant recipient for CLD. He has received many courses of various antibiotics earlier. As you can see, he's developed a stricture, cholangitis, bacteremia, and was admitted into the ICU. Now, what would be the empiric treatment if PCR panel was unavailable? So obviously I am looking at biliary sepsis, which has produced bacteremia with the stent in place, multiple cholangitic episodes. So I would want to treat for a gram-negative resistant organism, anaerobes, maybe enterococcus, and maybe candida with micafungin. So this would be the broad treatment which I would possibly like to start. Now what was done here was this panel which showed that there was only Klebsiella pneumoniae and nothing else, and that was showing CTXM and only OXA48 without NDM. Now why is this without NDM business important here? Because now I don't need to give a combination of ceftazidime avibactam with aztreonam. You know that this combination is fairly hepatotoxic. Okay? So this also told me that I don't have to give many things here and just continue with ceftazidime avibactam alone rather than others. Now this panel also includes the anaerobes and so many other organisms which you would have otherwise wanted to cover. So now no enterococcus, no anaerobes, no candida, nothing was found. And therefore you could narrow down this treatment. So you could use it sometimes. I showed you an example where everything that was found was treated. And there was a reason for doing that. Here we treated only selectively exactly what was found. Now when would you not believe the rapid diagnostic test? So here you have a 38-year-old acute liver disease with, alcoholic liver disease with multiple prior hospitalizations and was now admitted with high fever and sepsis syndrome. So what you found in blood culture was a high-grade E. coli bacteremia, and obviously that is due to severe liver dysfunction and extensive porta-systemic shunting. You can see that on the imaging too. So a rapid Carba-R test was done, and interestingly it found that there was no carbapenem resistance. Hence, what would the clinician be tempted to treat this patient with meropenem, right? Because what was found here was that E. coli, but there was nothing there, no resistance marker was there. But remember here that the sensitivity of this is an immunochromatographic test. So what is it actually looking at is the expression, it is detecting the enzyme. Okay? So it will now depend upon whether that enzyme is being expressed or not, and in good enough quantity or not. So this depends on many different factors such as the inoculum, temperature, the time of incubation, and many such other factors which might reduce the expression of NDM in particular. And therefore this test in rare instances may actually miss the NDM. So no carbapenem resistance was found. Now this was very surprising. Why? Because this patient has had multiple prior hospitalizations. I cannot imagine that the patient will not have received carbapenems during many of his previous admissions. And therefore that risk was there. So what did we do? We actually did expert carbar. Now this is a more expensive test, but what is this test looking at? It is looking at the gene for producing the carbapenemase. And that was actually positive, and NDM was detected in that test. Okay, so now this was probably the best way to do it. Obviously, it's a more expensive test than the rapid carbar, but once in a while, it will be useful. So for that, again, the clinician has to suspect this. What will the test is there, the microbiologist is there, but he or she doesn't know what is wrong with the patient, what is his prior medical history. So only in such instances the clinician's input will insist on doing this particular test. And sure enough, the phenotypic test which came up after a day or two did show that this was carbapenem resistant. Okay, so the rapid carbar missed the carbapenem resistance, the expert picked it up, and the phenotypic test also picked it up, and synergy was seen by the broad disk elution. But sometimes between the genotype and the phenotype, there is a leap of faith. Okay, and when are we justified in having that? And when are we not justified in having the leap of faith? Okay, so here we have a patient with elderly person with stroke. He developed fever, cough, dyspnea, and as you can see, he has findings of HCAP or VAP. Now what was found here on the LRTI panel was 10⁷ bin copies of Acinetobacter baumannii. And what was found here was only NDM. So what can be chosen? Now only NDM is found. Can I treat this patient with aztreonam alone? Because aztreonam will work for this. Answer is no, because this is India and this is Acinetobacter baumannii. So Acinetobacter baumannii, look at, this is a nice study done by, Parikshit is the lead author here from Dinanath Mangeshkar Hospital, and here you will find that there is so many different mechanisms of resistance exist in Acinetobacter baumannii. You will find OXA23, OXA58, 51, and in various possible combinations. So Acinetobacter baumannii cephalosporinases, OXA23, 51, and NDM are often present. And therefore, the best available therapy here cannot be told to you by the rapid test. You have to know local epidemiology for that. So our best available therapy consists of one of the polymyxins with either tigecycline or minocycline, with or without high dose sulbactam. And even the new drugs such as durlobactam, sulbactam have come in, cefidercol has come in, and still it's not going to be very useful for our Indian variety of carbapenem resistant Acinetobacter baumannii. So what is the real applicability of these type of rapid diagnostic tests? So I have given you examples where the clinical inputs are very, very important in order to interpret each one of these tests. So you need a clinical judgment to correlate the clinical radiologic syndrome, the specific organism, as well as the resistance mechanisms which have been found in this particular test. It is useful definitely because of its very good pickup rate, very good sensitivity, so that you can rule out on-panel organisms. And it will help you to stop antimicrobials. And if you don't find the on-panel organisms, then look for off-panel organisms. Like if you use the meningitis encephalitis panel and you don't find anything, we know that scrub typhus, spotted fever group, brucella, influenza, chikungunya, all these are extremely important causes of encephalitis. Okay, so your search for those will be more intensified if you find that nothing from the panel is present. So no use in just criticizing the panel, but apply the knowledge of local epidemiology to all these things. And obviously, immunocompromised patients may benefit most from this test because the treatment optimization is even more crucial in those. So I'll give you an example from biblical times. So like Moses, who parted the Red Sea, creating a magical path of dry ground for escaping. Okay, so this is how the lab, by having the rapid tests, is promising the clinicians as well as the patients the path to diagnosis and salvation. But is all this a myth or a reality? And I would leave it to you to apply all these things, principles which I just discussed, in order to use and optimize the use of all these kind of tests. So what do I really need? How can I have a reality check in my practice to see whether it's a myth or a reality? So I need clinical impact studies. So these studies should show efficacy, whether they are improving the diagnostic efficacy. So you didn't have a diagnosis, you got a diagnosis. Does it influence the diagnostic thinking efficacy? What does this mean? I find the panel to be negative. Okay, so now my thinking is geared towards off-panel organisms. Does it influence the therapeutic efficacy? That means the patient who received the test, did he receive the right treatment? And even more importantly, if the patient received the test, has his outcome been better? See, no use only having a diagnosis, changing treatment. Ultimately, the patient is not interested in any of these things. He is interested in the outcome. So did the test influence the final outcome? And finally, this societal efficacy is something which is much more than you and me can think. So whether resources can be diverted to food and nutrition or some preventive vaccination rather than the resource being diverted to these costly tests. Now these are more imponderables for us. It's often said that these kind of tests, molecular tests, are too expensive in resource-limited settings, and therefore empiric treatment, we are resource-limited, we don't want to do this 20,000, 15,000 tests, it's much better to use the drug. Okay, but my argument is the costliest antibiotic is the one which does not work. Okay, and therefore I would even argue to say that in resource-limited settings, where microbiology facilities are not going to be at par, you will probably not have ID expertise, everything is scarce. In these situations, paradoxically, the multiplex PCR, which seems to be the costly test, might actually be an inexpensive way to get the desired information and optimize treatment for the patient. So in this climate where things are changing so rapidly, I would argue that both diagnostics and therapeutics have to keep pace with the forces of nature, and really there is no place for complacency at all. With this, I'll stop here, and if there are any questions, I think I'm for time. Thank you.
Yeah, so we are running short of time. Can we take questions later?
Sure.
So we'll move to our last lecture, approach to gram-negative multi-drug resistance organism in ICU. I call Ashish Hegde sir. He's director critical care medicine at PD Hinduja Hospital, Mumbai. He's also faculty mentor for PG, postgraduate and IDCM students. Over to you, sir.
I think Dr. Soman has already set the stage, so hopefully my job will be slightly easier. So we all know these mechanisms of resistance. I really won't go too much into them, but there are 3 or 4 mechanisms, primarily by which gram-negative become resistant to bacteria. Efflux, our pumps are blocked, pore channels are altered, the target sites are altered, but by and large, the most important mechanism of resistance in gram-negative bacteria is producing inactivating enzymes, the beta-lactamases. They're much better in gram-negative because gram-negative bacteria have an inner and outer cell membrane. So in the gram-negative, whereas in the gram-positive, these enzymes can diffuse outside the cell wall. in gram-negative remain concentrated between the two cell membranes. So they're waiting for the antibiotic to enter and inactivate them immediately. Therefore, they are much more active, more effective in gram-negative as compared to gram-positive. And we know this is the standard Ambler classification of gram-negative of the beta-lactamase enzymes, and there's so many types. I'll just talk about some of them as we go along. So this is how the beta-lactamases evolved. I don't have much time, so I'm just going. Ultimately, first it was just the classical beta-lactamases, then it was the ESBLs, then of course it was AMC, and finally it became the carbapenemases. So this is how they've evolved over time, and each time a new beta-lactamase evolved, obviously our therapeutic options became that much more limited. So these were the, in the first, for the simple beta-lactamases, you could have used second Trojan cephalosporins, you could use BLBL as monobactams, carbapenems, then of course BLBL went off. You had to use only carbapenems or tigecycline. Finally, for AMC, you had to use only carbapenem tigecycline. And now, of course, you got the carbapenemases, the carbapenem-resistant organisms. So I'm really not going to talk too much about the MDR, which is the ESBL and AMC. I'm going to focus more on the carbapenem-resistant organism because that seems to be the predominant problem in our country now. So I'll start with the case. This is a 27-year-old male, completely well previously, admitted a severe head injury following a road traffic accident. He was intubated admission itself, not on any antibiotics. Day 4, he develops what's like an early onset VAP, was prescribed piptazo, rightly or wrongly. Day 11, still on a ventilator, has received piptazo for about 7 or 8 days. Develops fever, purulent sputum, hypotension requiring vasopressors, worsening hypoxia, and oliguria. Now, which antibiotic would you prescribe now? So this is, one of 5 choices. Some of that, this is some of, we're really not going to go into detail, but these are some of the choices that might be used in our country, and often are actually used in our country. So this is why I talked about them. So when you're talking about empiric antibiotics, somebody who is quite sick, where you can't afford to be wrong, this man was on vasopressors and all that. So you have to ask yourself the question, what is the probable location of the infection? Because your antibiotics needs to reach that site. Here it's the lung. Is this community-acquired, hospital-acquired infection? Because this hospital-acquired more likely to be resistance. Is there any risk factor of resistance? Of course, he's in hospital, he's already received piptazo, etc. He's very sick, so he can't afford to be wrong. He has no comorbidities, that doesn't affect too much for nosocomial infections. And he's been exposed to piptazo before, and we know in our country, somebody exposed already to a carbapenem or a BLBLI, the next thing is likely to be a CRE. So the most important thing is what is your local epidemiology, because sometimes the most important epidemiology, because that will decide your initial empiric choice in this patient. So we'll talk a bit about, because when you talk about carbapenem-resistant organisms, we have the carbapenem-resistant Enterobacteriaceae, which is one group, and the non-fermenting pathogens like the Acinetobacters and Pseudomonas, etc. It's important because whereas the mechanism of resistance in the Enterobacteriaceae is predominantly enzyme production, like the NDA, MOXA, whatever. Whereas in the non-lactose fermenters, it's both enzyme production, plus it is the other panels like efflux, sporin, etc. Which means these so-called rapid diagnostic tests might be misleading for the non-lactose fermenters because they don't pick up the efflux and porin, etc. So, sometimes you have a Acinetobacter which shows no resistance mechanism detected. That doesn't mean you can safely use ceftriaxone, ampicillin, sulbactam because the mechanism of resistance don't pick up efflux, porin, etc. So that's one. So actually, this rapid diagnostic tests are more effective for the Enterobacteriaceae. They're not that effective, in fact, probably not effective at all. Some you can only use them maybe to pick up the MBL for Pseudomonas, etc. also, but otherwise, that's one thing you need to know. Just saying no resistant mechanism doesn't necessarily mean everything is fine. So we'll talk first about the CREs. Basically, like I said, they produce carbapenemases, and the predominant carbapenemases in the world are KPC, OXA, and the metalloenzymes, which is WIM, IMP, and IM. It's important because we need to know the epidemiology. Because we blindly follow Western guidelines, we are going to be quite often wrong. So because whereas in the West, especially in the American continent, the predominant carbapenemase is KPC. In our part of the world, as most of us already know, it's OXA or the metalloenzyme. So whereas the treatment strategies for KPC might be quite different from what works for KPC may not work for what is prevalent in our country. So if you blindly follow European or American guidelines, sometimes you might be wrong. So you better know what is happening in your country. And this is what the ICMR guideline study on ICUs across the country. The predominant ones were OXA, and in our country it was essentially OXA and the metalloenzymes. KPC was not very often in our country. So that's one thing. And again, why they talk about local epidemiology? Because in our country now, there are, like in my institution, I'm lucky I don't have Acinetobacter, I don't have Pseudomonas. So when I am treating empirically, we're not talking about directed cultures, I don't need to think about after COVID, it's gone. We don't have Acinetobacter, we don't have Pseudomonas. There are some other ICUs in the country also have Acinetobacter or Pseudomonas as an organism. So in those ICUs, if they use something like, ceftazidime, avibactam, or aztreonam as a strategy, they might be, at least empirically, they might be wrong, because sometimes it might be a CRC, pseudomonas, or a CR, Acetobacter, which will not be effective. So in those ICUs, this empiric strategy is not going to work. But in ICU like mine, where I know it's only going to be the Klebsiella or something, generally going to be some like a Klebsiella-like thing, where there is no pseudomonas, no Acetobacter, I can afford to use a strategy using ceftazidime, avibactam. So there is no one right answer to this. You need to know, what is the prevalence in your ICU. So first thing, of course, before that, when you're getting it from a non-sterile source, you always like sputum, etc. Whenever you get a CR, you tend to overtreat, make sure it's a pathogen, not a colonizer. And of course, this patient is hypoxic, is hypotensive. There's no question that this is a... But sometimes our patient is doing well and such a sputum is growing something. You don't have to jump to treat it. Other thing that is again very popular in our country, used for knowing there is a carbapenem resistant, people think about using carbapenem. They say we'll use high dose, prolonged infusion, and all that. But all these things will work only if the MIC is just 1 or 2 times more than the break point. When the MIC is in our country, the carbapenemase produce, the enzymes are 128, 256, etc. No way is carbapenem going to work in most situations. Therefore, there's no role for... Sometimes the Western guidelines used to talk about that for KPCs, because for KPCs, the breakpoints were not so high. Anyway, they've also given up that, but there is no point. I still see people using polymyxin, meropenem. There's absolutely no point. Because meropenem is like using polymyxin with water. Meropenem has no role for the carbapenemases in our country. And another thing is what not to follow again is the IDSA guidelines and the European guidelines blindly. I'm not saying you should not go through them at all, but don't follow them blindly. Why is that? Because they talk about drugs like vaborbactam, relibactam, etc. But if you look at them, these drugs don't cover oxa. The only one that covers oxa is the avibactam. And oxa is the predominant enzyme in our country. So we can't really regularly use relibactam, vaborbactam. They might be effective for their pseudomonas and for their KPC, but it's not going to be effective in our country. So again and again, in our country, the only drug against oxa we have at the moment is the only BLI we have against oxa in our country is avibactam, nothing else. So you cannot blindly follow Western guidelines. So what you probably can go through is Raji's paper is there on ICONIX 2, and there's an ICMR guideline on carbapenem resistant infection. So that's maybe one. So I'll just talk. So basically, like I said, so there are 2 different settings. So whether your setting has a carbapenem resistant Acetobacter or pseudomonas or not. So if your setting is basically, if the setting is like I said, where both are there, you can have CR, Enterobacter, and you have CR, Acetobacter, pseudomonas, etc. Then you have no choice except to use a polymyxin-based combination. There's nothing else. I'm sorry, I went. You have no choice except to use a polymyxin-based combination, because polymyxin is the only antibody that will work against everything. The Western guidelines, they don't use polymyxin at all, which in our country is not practical. So that's why you'll have to use a polymyxin-based combination if pseudomonas and Acetobacter are still a likely organism in your ICU. So you have to use, but it has to be by and large in combination. So that's what you will have to use in this situation. But in situations like my hospital where Acetobacter is not a combination, then I would probably use a combination of Taz-Avi with aztreonam empirically. Like I said, this is all because before I got the cultures back. Of course, after I got the cultures back, because like I said, the predominant bugs in my ICU are usually the the oxa and the NDM. So why do I use this? Because like I said, you're looking at oxa and MBL only, and avibactam works against oxa. But of course, avibactam doesn't work against metalloenzyme. So I can't only use ceftazidime avibactam because I don't know whether this is a pure oxa or oxa with an MBL. So I'll have to use something. That's why I've had Acinetobacter. I add aztreonam to the ceftazidime avibactam. Aztreonam only acts against MBL. Aztreonam, if you're given aztreonam alone, it will be destroyed by the oxa or with the AMC or the ESBL, which is almost always present. We're not talking, so you cannot give aztreonam alone. Even if you get a report showing just a pure MBL, by and large, you don't give aztreonam alone, because invariably in our country, there will be some other beta-lactamates which will destroy the aztreonam. So generally, you have to protect the aztreonam with the BLI connected. So that's why we contain ceftazidime avibactam with aztreonam. Remember, in this situation, ceftazidime has no role at all, because we used to not get avibactam alone. Nowadays, some companies are making it. But otherwise, like when you want to use Selbactam for Acetobacter, we used to use ampicillin, not for the ampicillin component, but only for the Selbactam component. So here also you're using ceftazidime avibactam only because you wanted the avibactam. But when you combine the aztreonam, but of course we'll talk about the new drug that's available, but this is why you're using it. So like I said, there's no right answer depending on your situation. One of both B and C will be right. Like I said, now it's going to come, or probably already launched in the country, Emblavio, which is aztreonam and avibactam. Theoretically, Emblavio activactam has a You dose it 4 times a day, you give a loading dose. The pharmacokinetics are supposed to be better than the combination. Ceftazidime avibactam is like jugaad in our country. It's not been sort of this is a standard drug that's been tried and tested, of course more expensive. So, but this probably theoretically would be what would be better than ceftazidime avibactam. Especially very desperately, maybe this is what you probably would need to go to when you want to use the combinations, aztreonam and avibactam. And this is also then you would, Rajiv already talked about molecular diagnosis, so I really won't go too much about that. It's gives a much faster report. So if you get this, now if you, like I said, after you get your reports, if it shows both oxa and NDM, you will continue with ceftazidime avibactam and aztreonam. If there is no NDM, then you would stop the aztreonam because as Rajiv said, the combination has potentially hepatotoxicity. Why combine aztreonam? There is no NDM, you just continue with ceftazidime and avibactam. You don't get the aztreonam. But you might ask me that suppose this patient was in an ICU where you had Acinetobacter, etc., and he's already on colistin. You might ask me, why should I switch down? Why can't I just continue with though it has grown a CRE, why can't I just continue with the colistin-based combination? Why should I switch? He's already doing fine on a colistin-based combination. Why should I switch? Well, there are reports, because, like I said, because ceftazidime, it covers oxa and MBL colistin very well. So you might ask me, why should I switch? Well, theoretically, yes, but there have been studies which compared ceftazidime avibactam to colistin. This was for KPC, then this covered for oxa, then this covered for more like our country, and finally from our own country, from Pune, with Rajiv and Parikshit, which looked at that outcomes are better with Taz-IV as compared to colistin, Taz-IV aztreonam as compared to colistin when used for CRE infections. And probably toxicity also is probably lesser than with the polymyxin-based combination. So therefore, ideally, even if if a patient were on a polymyxin-based combination and then it showed that it is a CRE, ideally you should switch from a polymyxin-based combination to a ceftazidime avibactam-based combination. Of course, but if you want to insist, you say, why should I use? Then only can't use polymyxin alone, you have to use it in combination with one other drug. Generally, you don't use for CREs, you would combine polymyxin with one of the other drugs, the companion drug, and of the lot, probably in our country, either fosfomycin or high-dose tigecycline in combination with polymyxin would be a situation if you want to, don't want to switch. This is the first case, and this is case 2. This is a 56-year-old female, recurrent pyelonephritis, but never required ICU previously. She had a previous episode 1 month ago for which she received meropenem. Now admitted severe urosepsis requiring high dose of vasopressors. Obviously, you're going to do a CT, you're going to rule out, stenting, bending, all that. Source control is probably the number one thing that you would do, but which antibiotic would you use empirically in somebody who's probably had multiple urinary infections? Of course, I'm talking only about E. coli. You also in this situation might need to combine treat for enterococcus. You might even think about Candida because she's already had meropenem, multiple antibiotics. But we are going to talk about resistant E. coli. You might, like I said, depending how severely ill she is, add antifungal empirically, add enterococcal treatment empirically. But your primary thing would be a carbapenem resistant E. coli in this patient who received meropenem. So again, what would you use in this patient? Empiric antibiotic. I'm not talking about. So obviously the answer, polymyxin tigecycline is completely wrong, no question, because polymyxin, neither of two go into the urinary system out. High-dose meropenem I talked about, no use. So choices between colistin, fosfomycin and ceftazidime avibactam plus aztreonam because you're worried about CRE E. coli. So this is choices. Now again, like I said, the same questions, I won't go into them again. Pyelonephritis, etc. We talked about why because it is pyelonephritis, you cannot use polymyxin and tigecycline. So you might think that this patient is CTX and NDM, therefore I can get away with ceftazidime and avibactam plus aztreonam. But now the trouble is, this is what you would think about. Until recently, this would have been okay. But now there's a new villain in the whole thing. Then now we have the so-called PB3 inserts, which are now present in a lot of E. coli in our country, which basically they alter the penicillin binding protein. Therefore, aztreonam is not going to be that effective in the presence of a PBP3 insert, and some studies have shown up to 56. Of course, there might be sort of, selected studies because only the resistant E. coli are sent to them, but up to 50-60% of the E. coli in our country, which have an NDM, also harbor this PBP3 insert. In this situation, your ceftazidime avibactam aztreonam is not going to work. So in a really sick patient, where you can't afford to be wrong with your initial choice of antibiotics, probably in this patient, when I suspect, the initial choice would probably be a colistin plus fosfomycin, till you get studies to find out whether this combination is going to work or not. So this is the, like I said, underreported trait. So ideally, until recently, they said you should do what are called synergy studies, which means this is one way of doing a synergy study. You combine, you find out whether there is synergy between Taz-IV and Astronam. If there is synergy, that means you can safely use Taz-IV and Astronam. There is no PBP3 insert, it can work. But there is absence of synergy, that it means you have no choice. You cannot use Taz-IV Astronam for this E. coli. So this is essentially E. coli. Maybe later on for other, it went over. But at the moment, this phenomenon is confined to E. coli. Now they recommend that other method is not so great. You should do what is called this MIC-based drop. This is supposed to be more accurate than the conventional disc or the two-layer disc. But now, once we have this Emblavio in our country, we are going to get the E-test for Emblavio. So once you have the E-test for Emblavio, if the E-test shows that Emblavio is sensitive, then that is as good as saying that even if ceftazidime, Avibactam, Astronam is sensitive. So you can use that as a surrogate. You don't need to do the broth. And so life has become simple. Even if you're not going to use Emblavio, you can still look at the E-test for Emblavio and still use, if you want, because that's cheaper, you can still use ceftazidime, Avibactam, Astronam. So this is, because this has come into our country, maybe at least we will use more of the E-test, not the broth dilution is very tedious. So this is one way of knowing whether this will work. But until this test is done in a really sick patient, when you're suspecting a CR E. coli, you will have to use polymyxin, phosphomycin. That you might ask me now that Emblavio has come in the country, is any role for Zavicefta? Is sort of Pfizer cannibalizing its own drug? But ideally, if it's a pure oxa, there is no NDM, you should probably continue to use ceftazidime, Avibactam, because Astronam ceftazidime is supposed to be more hepatotoxic. So for a pure oxa, continue to use Zavicefta. If it is an NDM, then use Emblavio. So Pfizer not completely cannibalizing its own product, you can use both. The other drug, of course, that is now is the plasmomycin, which has been sort of again, marketed for. So they say plasmomycin works for the PBP3 insert. Of course, it does work for the PBP3 insert, but again, the problem, the twist in the tail is that many of the aminoglycosides, they have, especially they have an NDM in our country. Many of the E. coli, they have an NDM. They also co-carry a 16S methyltransferase gene, which destroys the aminoglycosides. So even so, if you have an E. coli, if there's an MBL, then plasmomycin may not work. You cannot use it empirically, no question. You cannot use it empirically. You have to look for phenotypic sensitivity. If it is sensitive, then maybe. But again, in our hospital, at least, we have seen that those strains which are sensitive to plasmomycin are also sensitive to amikacin. So one is some 75 rupees, one is 15,000 rupees. So that's up to you. Unless you want to take a trip to San Diego or something, that's a different issue. But otherwise, I don't think there is. So the only reason to use plasmomycin is if it is only plasmomycin sensitive, but not amikacin sensitive. And that cannot be used empirically, because 60 to 70% of the time, it's not going to work in our country. Because this is abroad, it's okay, because abroad the E. coli don't have MBLs. That's what I'm saying. So don't blindly follow plasmomycin for CR E. coli, because that's what they don't have MBL. We have that. We have so PBP3 insert, yes, but this is the new twist, the 16S methyltransferase gene. So you cannot use it empirically, at least. Of course, if you are fortunate enough to get the sensitivity back and is sensitive only to plasmomycin, not amikacin, yes. The other drugs, the other drugs, so I've talked about plasmomycin. Eravacycline is not yet available, but it will be one slightly better version of tigecycline, maybe used for especially intra-abdominal infections. And cefiderocol is again supposed to be a salvage drug, but again, for Acinetobacter especially, actually they found the results are probably worse than, with the other drugs. So it might be used as a last resort, very expensive, you have to get from the black market, etc. But situations where your back is to the wall, nothing else, maybe you might consider it as a salvage drug. Certainly not as a drug of first choice, even if it is available. What about Pseudomonas and Acinetobacter? Like I said, again, one caveat is that by and large, your enzymatic testing is not going to work, but sometimes it may tell you, for Pseudomonas, if an MBL, then again the strategies used for Pseudomonas abroad are not going to be useful in our country. If there is no MBL, then maybe drugs like ceftazidime, Avibactam might work. But unfortunately, in our country, almost invariably, there's an MBL with the Pseudomonas. So by and large, strategies won't work. So that may be one use of the enzyme testing for Pseudomonas. So you're stuck with Pseudomonas. Probably at the moment in our country is the most difficult. A carbapenem-resistant Pseudomonas is probably now the most difficult to treat. For carbapenem-resistant Acinetobacter, though it has efflux and porin, and ceftazidime is not affected by porin, Astronam is affected by the efflux. So the combination of ceftazidime and Avibactam again is not going to work for Acinetobacter. So what are the strategies that you have? Dr. Soman has already talked about carbapenem-resistant Acinetobacter. Basically, you have to use a combination of, in a sick patient, polymyxin, high-dose minocycline, and high-dose Elbactam. There is no other option for at the moment in our country. Cefiderocol, maybe second choice if nothing else is working. And for Pseudomonas, at the moment, there's nothing really much that you have. If it's a non-MBL, yes, you lots of things. But if an MBL, you use high-dose polymyxin, but combined with what, maybe phosphomycin, I'm not sure what we can ask Dr. Pseudomonas. And what if molecular diagnosis is not available, then you probably have to wait for phenotypic sensitivity. Strategies are the same, but you just have to wait till you get phenotypic sensitivity, when you can then decide. And also remember that when you're, basically, probably wiser not to step down on the basis of enzymatic test. You can step up, but you want to step down, it's probably safer to wait for phenotypic sensitivity reports by and large, because if there's some resistance mechanism not covered, you step up. But stepping down is safer to, in a sick patient, safer to wait for phenotypic sensitivity, because sometimes there's a disparity and it's safer to step down. So finally, of course, it's a 3-headed dog Cerebrus, which guards the gate of hell. And the CRE are almost as terrifying, and it required Hercules to sort of tame them. So maybe there's going to be a Hercules on the horizon. We have this drug called Zidibactin cefepime. People have bought Vocard shares and made a lot of money on the basis of this drug. So it's probably going to come into the country. It's a so-called, it's not just a beta-lactam inhibitor, it's also beta-lactam enhancer. So it has its own intrinsic activities. It protects cefepime by the enzymes and also binds to the PBP2. So synergistically with cefepime, and they're effective against almost all the, at the moment, against all the carbapenem-resistant organisms. So it's probably going to come sometime soon, but unfortunately, as soon as it comes, it's going to be misused in our country, and at least for the short life that is in our country, maybe we have some hope. Thank you.
Thank you, sir. We're actually running short of time, so can we please proceed to our next session?
Thank you.
I request all the panelists and speakers to please move on to our Memento Corner. For our next session, I call Dr. Gunjan Chanchalani ma'am. It's panel discussion on polytrauma. Gunjan ma'am, she is Director of Critical Care Medicine at Vocard Hospital, Mumbai. For panelists, I request Dr. Leena Patil ma'am, Dr. Sai Prasad, Dr. Khalid Khatib sir, and Dr. Nirmal Jaiswal sir.
So the interesting part of the talks are over, and I think everybody's gone for lunch. So I'll start quickly because we are running short of time and I have a flight to catch. So we'll try to finish it off. It's 45 minutes, not 15 minutes. We'll try to finish it off. I don't intend to finish it out in 15 minutes. So first I'll introduce our panelists. We have Nirmal Jaiswal sir. He needs no introduction. He's from Nagpur. Very senior intensivist at SureTech Hospital. Correct me if I'm wrong. Of course, everybody knows him well. He had a beautiful oration and needs a lot of praises, which will probably take 45 minutes more. Then Dr. Khalid Khatib, he is from Pune. He's also a senior professor. I missed the hospital. From SN Medical College in Pune. And of course, he's mentored many students in critical care, and trauma is probably what he treats in and out, much more than probably I do. Then we have Dr. Sai Prasad from Kolhapur, again managing a lot of trauma, and Dr. Leena Patil from Jalgaon, and both of them are probably the ones who are going to highlight the resource limited, how they are really actually managing trauma in their settings and how the clinical acumen really helps there. Before we begin, just a few disclaimers. This topic is about non-neuro trauma. It was very clearly told that you cannot cover neuro, so I'm not supposed to cover traumatic brain injury and traumatic spinal injury. What is left is only the torso and probably the limbs. From an intensivist perspective, if I look at these part of the trauma, if I leave the neuro aside, probably there are only two things which we need to manage. One is the intubation part in these hemodynamically unstable patients, and other is to maintain their hemodynamics. And instead of taking a case scenario which learns as a case, probably I've tried to touch the challenging points that we come across during these cases of polytrauma. As we all know, managing any polytrauma requires the time, and time here I don't mean by the time that we give overall, but the decision that we need to take at that appropriate time when the fast decision making we do. Then we need a lot of teamwork, a teamwork between an intensivist, a physician, a surgeon, a blood bank officer, our nurses, and even our helps which are there. We need to have a clear algorithm set how it needs to work, and probably we also need to look at the logistics which are there. So quickly through the case, which is again a case only to begin the scenario. A 45-year-old who has an alleged road traffic accident, a flail chest and a tension pneumothorax, a pelvic trauma with an abdominal distension and the E-fast is positive, showing a lot of blood in the abdominal cavity. Hemodynamically unstable, but GCS looks pretty fine. Saturation is quite maintained, but a little tachypneic and a little restless. So now I'll go to the first question. We always think of ABC when we talk of approaching any critically ill patient. In ATLS, a patient whom I have a tension pneumothorax and who is maintaining saturation but is hemodynamically unstable and a little restless, where does the A come in? I think I can ask this question to Dr. Sai if you can begin. How do you take it now? What is the latest ATLS concept in a bleeding patient?
Yeah, actually, whatever we have been doing A, B, C, D, E, but here the priority becomes immediate managing the catastrophe which we are dealing with. So if somebody is heavily bleeding, you try to put a tourniquet, pressure bandage and whatever, try to stop it. So whatever the immediate catastrophe is there, so you try to control by pressure, compression, tourniquet, whatever is possible, and then manage your airway, then go for your routine breathing circulation, and other things are managing the disability and exposure. So these are the sequences which we would usually go as per the ATLS concept.
So from A, B, C, D, E, we have moved to catastrophe. So this was a very important question when I was doing my critical care, and the thing was, if I used to ask this question, I was asked this question actually in my exam, where I was asked, if you have a tension pneumothorax and you want to take care of the airway, will you put an ICD first or will you intubate? So it was a catch-22 situation, because then the protocol was A, B, C, D, E, and if I say I put an ICD first, then they say no, the A comes first. And if I say I will give a positive pressure ventilation and an airway first, they would say you are going to cause a more worsening the tension pneumothorax and probably causing death. So now it is very clear that we have to tackle the catastrophic outcome first, which is the bleeding and the tension pneumothorax, which has to be taken care of first, and of course maintaining the oxygenation till you can take care of the airway and intubate this patient. So we have changed from ABCDE to CABCDE now as per the latest ATLS concept. So as we have already discussed, I want Dr. Khalid to give his inputs here. Would you want to intubate immediately this patient or would you want to wait for some time?
There are two considerations which I want to look at this patient. One is because he has pneumothorax, do I want to target that? But if I want to target that, it's going to take me some time to put in that ICD or needle thoracotomy, either of those things. Do I want to immediately intubate this patient? For immediately intubating this patient, I'll have to give him drugs and then I'll have to intubate. And as Sheila madam said in the morning, once you try to intubate this patient immediately, you're going to cause, because he has already bled, he is in a hypovolemic state. So that is the dilemma that I have to think, whether do I want to immediately intubate this patient. If there are clear indications that patient needs intubation, GCS is less than 8 or he is severely breathless, then maybe I can think of immediately intubating. Otherwise, it's better to wait, take the patient to the OR if required, and there it is where I will immediately intubate at that time, and whatever surgical treatment needs to be done, maybe that can be done. So the answer to this question is, what is my clinical scenario and how I want to go about, what are the resources which are available to me. If I say I'll intubate immediately in the ED, and if there is no backup and I'm not able to, I reach a stage where it is can't intubate, can't ventilate, then you are in deeper trouble.
Absolutely. So here with these patients who are hemodynamically unstable and probably require a surgical intervention immediately, shifting him to a place where he can be simultaneously managed is a more priority than to intubate immediately. When we talk of traumatic intubation, rather when we talk of not traumatic intubation, but intubation in a patient of trauma, we always say it is a difficult airway. It is, you have to do rapid sequence, and these are the words that we often hear. But I want to stress more about these difficulty, and I would request Dr. Leena to say, how do you say and why do you say is this a difficult intubation?
in trauma situation, most of the time the anatomy is distorted. There is a C-spine injury also. So you have to consider it's always a difficult intubation, anticipated difficult intubation. And in this situation of 70 systolic blood pressure, so use of drugs is very important because many of the anesthetic drugs cause hypotension. And we will avoid succinylcholine in this patient because most of the trauma patients we avoid succinylcholine. And rapid sequence induction with rocuronium, and if I want to give, I will go for, but the ketamine will be like 160 heart rate. So let's shift to etomidate, which might helpful, 0.3 milligram per kg, but I will not give full dose. And with anticipated difficult intubation, we will keep all the difficult airway, card, C-spine, considering everything, and LMA also with us. And then, plus if you want to intubate this patient with rocuronium, you have to keep Sugamadex ready, because if you cannot ventilate, the patient won't die. But if you cannot intubate, patient won't die. But if you cannot ventilate, the patient will die. So in this situation, I'll keep this card ready.
Dr. Nirmal, if you want to add anything more about it.
What Dr. Leena has already said, it is also very, very true whenever the patient is in trauma. And if you are getting a first hand, for example, then definitely the patient is hypovolemic, right? And in that scenario, if you go with something like called as intubation, then it will be the nightmare. So what is most important is optimize the volume, whatever the things are in front of you, and then you can do whatever the jugglery to save that patient for the respiratory distress.
And where we intubate is also equally important. Sometimes it's possible that we may have to intubate at the site where the things have happened, or in the ambulance, or in the ER. So what help we have, so these things also have to be considered.
I considered the catastrophe management is simultaneously going on. So might he has come to 100 systolic BP, and then I am going to intubate him in the OR, I guess, because this patient is going to need OR, I guess.
So, yeah.
Suctioning is most important part. Yeah. Suctioning is more important part.
Intubation has to be done where you have suction. That is the first thing in trauma. They're vomiting or bleeding, intraoral, whatever. Suction has to be there.
And sometimes for airway, you may also have to do a surgical airway. You may not be able to intubate, and maybe you have to
surgical
do a
airway,
tracheostomy.
you have to keep ready.
So when we talk of difficult intubation in a trauma patient, when we do not have a cervical spine injury, as in this case, of course, difficult intubation can happen anytime as an anatomy. But what we need to look at is the physiological instability, which makes us a physiological difficult airway. Way different what we have in our ORs, where we do not have everything as per our planning, or we cannot anticipate and plan it well. And most importantly, as pointed out, it is also the situation. A situation whether you are on the field or whether you are in your entry of your OR, where you do, ER, where you do not have enough suction or devices to support you, or even enough help. And the situation enough that in the ER, when you have 40 people watching you doing a procedure, it probably makes it more situationally difficult to tackle even an easy airway. So trauma airway is always a difficult airway, looking at all three factors, that is anatomy, the physiology, as well as the situation that we are in. So this patient, Dr. Khalid has already pointed out, but I would still want him to shed some light on it. This patient is in shock. He probably is bleeding from some of the artery in his abdomen, which is causing him to bleed. And we have already tried to perfuse a lot of fluid in him and trying to get the BP up. But we want to intubate him. Of course, he's in the ER right now, despite the fluid and everything. Would you want to intubate him in the ER or rush him to the operation theatre immediately with a BP of 70? I'm putting it to Dr. Khan.
Yeah. With a blood pressure of 70, of course, I will start him on, I'll put in 2 intracats and start him on IV fluids. And maybe because he's already bleeding, I'll have to activate the massive transfusion protocol. And if required, start even vasopressor so that I can keep his blood pressure so up to from 70, MAP is 70, isn't it? Or
No,
systolic?
no, 70
Systolic is, okay. So I'll try to keep MAP around 55, 60, not too high. I don't want to go too high because bleeding will be. So this will be what I want to do for shock, and then rush him to the OR and see what other things I can do for his. Okay, intubation should be ideally in the OR rather than in the ED, if possible. If it is not possible, then you do it wherever you are.
So Dr. Sai, you want to add anything?
Yeah, I entirely agree because as such, see, it all depends on what help you have. So if you have in your emergency department experienced person to intubate, a good person to stabilize the neck and give cricoid pressure, and you have all backup system to do emergency cricothyroidotomy or tracheostomy, so you can still consider there. But by and large, it will always be better to do things in OR where your situation is under control.
So often the patient is so actively bleeding that we need to probably do some pressure and control the bleeding as the initial C of the ABCDE, and probably just get him to an acceptable blood pressure to move him to the OR, because when we give drugs for intubation, probably that would cause more crashing and we may not have enough availability or even the surgeon and our devices to control the active bleeding which is going on. So, for instance, this patient which I have taken has a bleeding from his mesenteric artery and his abdomen is continuously he's bleeding inside with no tamponade really developing immediately, and his BP would crush even if I keep giving fluids. And of course, whatever accesses I have, I can only take it in the neck. So, the patient, as I said, was restless, not allowing for a wide bore access, and taking in the leg would be impossible because he's bleeding from the mesenteric artery, and abdomen distension with the abdominal compartment, allowing the perfusion to happen from a axis in the leg probably would have been more challenging. Okay, so this patient, as I said, which was in our hospital, we just took 3 wide bore accesses with 16-2 and 1 14 gauge IV, and pushed a lot of fluid, O negative blood, and even some bicarb to keep his metabolism good, and rushed him to the OR where he was eventually intubated under monitored circumstances and immediately opened up for a surgery to happen. So there are studies I went through. The studies clearly say when there is urgent hemorrhage control which is required, delaying time in intubation in the ED has eventually resulted in adverse outcomes in the patients. And of course, there is significant variation in the amount of the time which is taken in intubation in the ED and the OR, because OR we have almost every equipment ready at the bedside and at the patient side, whereas in the ER probably it may be a little difficult. So whenever feasible, if intubation can be deferred in the favor of rapid resuscitation and probably bleeding control, in that case transporting the patient to OR immediately and or to the place where the bleeding can be properly controlled is what should be done. So this is from the latest study which is there in 2023. So how to intubate? Again, I would, Dr. Khalid, if you can give me some points on this.
Before going to how to intubate, just one comment on your point as to he has mesenteric, bleeding from the mesentery. I don't think he'll go directly from the ER to the OT. We have to diagnose that he's having a mesenteric bleed. So I think we'll have to take a detour. Yeah, detour to a CT angio, because, or a POCUS.
So POCUS was already done.
POCUS, his FAST is positive.
FAST is positive and the hemodynamically unstable.
And hemodynamically
we can skip going to the CT angio and go directly to the OR.
You can go to the OR.
Yes.
Yeah. The question?
The question is how to intubate. What other, apart from the, Dr. Leena has already stressed a little on the drugs.
Yeah. So what you want to do is you want to give him oxygen. You want to oxygenate him as much as possible. Keep his apnea oxygenation there. And you want the senior most person who is available there to use what is best available. If you have a video laryngoscope, you use it. If you don't have a video laryngoscope, then you use your routine laryngoscope. But you want that success should be achieved in the first attempt itself. So try and optimize your first attempt and try to see that what you are trying to do, that is intubation here, should occur within the minimum amount of time, and it should be at the first attempt. There is no point in repeating the attempts because that is going to cause trauma locally as well as make your job more difficult. That's all. Yeah.
Anything more, sir? Nirmal sir? Apneic oxygen. You want to add anything? So again, there are studies which have shown that if you have the best intubation the first time, it is much better. So the most skilled person in the unit should probably take the first attempt and you should optimize it. Another pointer here is because the patient is hemodynamically unstable and probably has bled a lot with a low oxygen carrying capacity, the window that he gives during the apnea to intubate is quite less. So in those cases, giving him high flow oxygen, even when during the process of intubation, or what we call as apneic oxygen, maybe by high flow or by a nasal prong, is what is advised to keep the oxygen levels up. And of course, choosing the medications to the optimum, as Dr. Leena has already said. So we have various scores which anticipate severity of bleeding and trauma. Now, since we have intubated the patient, and of course we are resuscitating simultaneously, but we could not discuss simultaneously how we would handle the hemorrhage part also. And since it goes from A, B, C, I'm coming to the C. How do we handle the hemorrhage now? So what scores have been used in anticipating severity of bleeding and trauma? Dr. Sai, if you want to say.
See, there are multiple scores which actually assess the severity of bleeding, COAST, TASH. So, but basically what they use is one of the basic score which we can use bedside is shock index. So your heart rate by blood pressure systolic will be a very useful bedside tool. So apart from that, most of the other tools which basically used here use the systolic blood pressure, heart rate, and your unstable pelvis. And many of them use hemoglobin as a good marker, because your initial hemoglobin, if it is something like 12, 13, so that is also a very good indicator. So these are some of the scores which we use bedside, which have fair sensitivity and specificity to assess really there is a red flag or not.
Dr. Gunjan, I would like to say that your clinical characteristics are the most important in this patient. If you feel that patient has trauma, which say if he has a fractured femur, then you know that he has lost 2 liters of blood around the femur. If he has an unstable pelvis and blood in the abdominal cavity, then you know that he has a lot of bleeding inside the abdominal cavity. Shock index will tell us whether he is unstable. If his hemoglobin is low, then that will tell us. Of course, your blood pressure, if it is less than 70, it is telling us that this is hemorrhagic shock. So he has lost enough blood of his circulating volume that he is in this bad position. So I think clinically, scores will, of course, they will tell you, and they are good for presenting, but I think clinically it will tell you whether your patient is unstable or not.
And many a times this abdominal distension takes quite some time to manifest. So they may have early pain abdomen or some guarding, but many of them, especially in trauma, if they have lower rib fractures, really 9, 10, 11, 12. So even though they don't have any abdominal signs, still they can have injury to hollow viscus or any of the major organs in the abdomen. So it's an indication, becomes an indication for doing a CT abdomen.
So we always talk of when we resuscitate trauma, we have to look at one important aspect about trauma-induced coagulopathy. So I'll ask Dr. Nirmal sir to please shed some light on what is trauma-induced coagulopathy before we go ahead.
Yeah, like what we are at this point of time discussing the management of shock. That is the management of shock for any shock other than the trauma shock is absolutely management-wise is absolutely different. Say when you know the trauma is equal to the hypovolemic shock. So when the hypovolemic shock is bound to give the crystalloids since beginning. And maybe allowed is around one bag or maybe 500 ml of normal saline first hour, or maybe the first instant whenever you see. But at the same time, when you start giving the fluid, because definitely the blood pressure is going to be the volume responsive. So in that scenario, if in a resource limited setting, and you just go on pushing the normal saline or maybe ringer lactate, whatever it is available, and these people are going to develop the traumatic coagulopathy later on. So the management definitely changes here. So you are supposed to, even if you don't have the backup, so your blood bank has to be notified from wherever you are seeing that trauma. And whichever the ambulance along with the medicos or maybe the paramedicos they are picking up, so the blood 4:3:2:1, that protocol has to be followed. So more amount of a colloid to be used in the form of maybe plasma and the platelet. So that you will not face this coagulopathy. Because again the time is the muscle here. If you lose the time, even though in initial hours the patient looks very stable, but this coagulopathy is going to give a lot of trouble in outcome, and the hours, the lengthy hours of management, again the mortality goes very high. So that has to be managed. So most important thing what we do nowadays is check out the coagulation parameters very frequently, so that how much amount of maybe plasma, maybe the what you call it as the platelet to be infused along with the PRC, That is what the management changes here. Anyway.
Actually, our patient is going to be in OT. That will again save our time. So more the delay, more the coagulopathy. So we have to control the bleeding first. So we will avoid the massive transfusion complications also. And when the patient of trauma comes, the internal system is also get activated to control the bleeding, and then they land up into DIC and other things. So to avoid that, we are on the right track to take the patient in the OT, and simultaneously blood should get available.
The one thing also should not forget here, it is not only the bleeding parameters which is going to haywire, they are the candidate for the peripheral, thrombotic formation simultaneously. So these people are supposed to be managed, even though they are bleeding, they are simultaneously on the low molecular weight heparin simultaneously, so that they may not develop the different complications.
So trauma-induced coagulopathy is a hidden enemy which is there. Even when we are shifting him to the OR, we need to keep this in mind that he may already be coagulopathic based on the bleeding, and also because of the injury that happened, there is extensive immune activation and release of cytokines which may lead to further deterioration. So we will have to look at the massive transfusion protocol, how we tackle this coagulopathy simultaneously as we resuscitate. Maybe Dr. Khalid can tell us how he does massive transfusion in his setup.
What in trauma-associated coagulopathy, there what we have to look at is two things. One is the immediate, because of damage to the muscles, damage to the blood vessels, activation of the endothelium. So there is going to be an acute coagulopathy of trauma, so which occurs immediately after trauma. And another part is what happens once we start treating them with IV fluids, start giving them. So that is the coagulopathy which develops a little later. To prevent the second part of the coagulopathy, what we do is we have to use what is called as 1:1:1. So for one RBC, one plasma, and maybe one platelet. You also have to take care of calcium. You do not want your patient, because you are going to give lots of blood products, you are going to give lots of citrate also, which are there in the blood products. So that will cause hypocalcemia, and you want to supplement these patients with calcium. You also want to take into consideration that patient does not develop, because that is what we call as the triad, hypothermia. You don't want your patient, so you want to warm your patient so that they do not go into hypothermia.
Dr. Leena, you want to add how well you can follow this in your setup?
In our setup, we have, to prevent hypothermia, we have the warmers, and through blood, we give the hot line warmer. We are at resource limited settings. So when the patient comes into accident patient or a trauma, not this much of trauma I cannot manage, but whenever this trauma patients comes, the blood activities, we don't have a different activation system. Our assistant doctors would only, they activate the system and get the blood earliest. And for temperature, we have warmers and fluid warmers.
So then, in settings where, from Leena, I am in Mumbai, more luckier, and there we have viscoelastic testing as well. We have TEG and everything. So there is convention transfusion protocol, which we talk of 1:1:1, and there is another protocol which is now being defined, which is viscoelastic based transfusion protocol. So which is better? If I can just ask Dr. Sai or Dr. Khaled, if you can, or Dr. Nirmal, if you can put inputs on it.
No, the thing is, first thing is availability. As you rightly said, I mean, I don't think Pune has, but we don't have an access to TEG or ROTEM, whatever. But the thing is that using conventionally the ratio of 1:1:1, so maybe there will be some wastage of blood products. Maybe you will have some problem with fluid overload. So you have to be little careful. But otherwise, if you look at the statistics, probably both will have similar results. And second thing is availability. But as far as the TEG is concerned, probably you will have better information you will streamline the administration of blood products in a better way. But it's all up to availability.
So obviously, when we do viscoelastic testing with TEG, we get faster results. We know what is the component which is affected, whether it is only fibrinogen or only platelets or maybe only INR, or we get targeted information and we can individualize therapy. And today the era is of individualized, personalized therapy in critical care. And of course, we also know the functional analysis. So often the patients are on double antiplatelets, but the platelet number may come out to be 2 lakhs, but actually functionally they are impaired. So we get a good functional analysis of our whole coagulation pathway which is there. But when I was looking through the studies which were there, which compared whether viscoelastic based transfusion was better than a massive transfusion protocol which is followed without doing a viscoelastic testing, there was found that there was absolutely no change in the survival and also in the organ failure which developed. So whatever best is available in the best scenario with the best intent has to be done. So there's another, when we talk of coagulopathy, there is another point which has come up in the latest research, last 1 year. When you talk of coagulopathy, we have been talking of coagulopathy with platelets, with our factors, coagulation factors and our fibrinogen. But there is something more beyond it, which is endotheliopathy, which I would want Dr. Khalid, since he's most updated with his medical college professor knowledge, to shed more light on it.
Thank you for that compliment.
Okay.
So, what they have tried to tell us is that traumatic shock is like what we have as a septic shock, where you have bacteria like E. coli which are having a glycocalyx, and the body responds to that glycocalyx with the release of inflammatory markers. Similarly, whenever your patient has trauma, he has a condition which is akin to that. So just like patients have septic shock, which is vasodilatory shock, some patients of trauma, they will have something like a vasodilatory shock because of shedding of this glycocalyx, and you will feel as if it is not purely hemorrhagic shock, but there is something more to this shock. If you have, it's very difficult for this patient to have all the arterial line and cardiac output monitoring. But if you had all those things in your setup and you have done that, you might feel that this is not just hemorrhagic shock, but some other type of shock is there along with hypovolemic shock. So that is the new, this thing about endotheliopathy.
So Nirmal sir already pointed this out on the previous thing, that when the shock is, when we have trauma shock, it is not just hypocoagulopathy, but also procoagulopathic response which we see, and that is a part of endotheliopathy. So you want to say something?
Yeah, just wanted to add the before that what we are talking about, the rotain. That definitely is amazing. In Nagpur also it is available, and where sometimes because it costs so that we balance the show. But in resource limited setting, it is very easy in India to get the injectable fibrinogen. So if you just infuse almost like depending on the weight, whatever you calculate, but say for example around 3 to 4 grams is enough. Even if you don't do any bloody investigation, if you find the trauma and he's hypovolemic because of the blood itself, then definitely just on the spot, whenever there is an accident or in ER, just give 3 grams or 4 grams of fibrinogen. And definitely there are some papers wherever the people are using this as compared to your transfusion induced, what you call it, massive transfusion induced complication has also been reduced a lot because of on first hour when you start using this fibrinogen.
We kept one fibrinogen available with us. So in any hospital that get, so we give that fibrinogen to those.
Yeah, fantastic.
Supplement with
because it's costly, so.
Right, but it is on the long run definitely cost effective.
Yeah.
On day one it may be very costly for that relative, but if you have to just sit for 10 minutes with that relative.
Yeah.
So when we talk of active bleeding in a patient, traumatic patient, where we are infusing, there is, and before we can do the final control of this bleeding or the source control, there is something which we do, that is damage control resuscitation. Dr. Sai, if you want to speak about this. What is damage control resuscitation?
Well, actually, there are 2 aspects of resuscitation here. Considering that prime thing is to maintain the critical organ perfusion, but at the same time, there is every possibility that you will be causing more damage by over resuscitation, more zealous resuscitation. So other part of it is that getting your blood pressure up would dislodge the clot or take out the tamponade effect, and it would lead to more bleeding. So the primary aim is to do a damage control surgery and control the bleeding. Until that time, maintain a low MAP. Normally we, in all our things, we try to maintain a MAP of 65, but here probably even maintaining a MAP of 40, 45 would be sufficient, so that the bleeding is not worsening and it is adequate enough to keep critical perfusion to all the vital organs. And meanwhile, you control the bleeding, and then you can get your blood pressure up. So this is one of the important concepts of permissive hypotension. So that is one important thing. Again, need to maintain the temperature. Definitely the lethal triad of coagulopathy, acidosis, and hypothermia. So this has to be prevented with our initial resuscitation, and that has to be maintained. And use of fluid, again, as I told you, again, colloid infusion has to be avoided as far as possible. It has to be only blood and blood products, because these colloids again interfere with our coagulation, abnormal coagulation parameters. And then again, early, when you trigger massive transfusion protocol early, so you start using in the fixed ratio all the blood components, so that you maintain the physiological constitution of the blood, which is more important in preventing further coagulopathy.
So you
Dr.
already
Gunjan,
stressed on this. Yeah,
I would just like to add that, as Dr. Sai said, obviously, that you want to give adequate fluids so that you can have adequate perfusion, but you do not want to overdo it. It's very easy for us to sit here and tell that. It's very difficult in the field to really understand this, how much is enough and how much if I give more fluids. So what is defined as this more fluids? Because patient has already lost around 2 to 2.5 liters of blood. What we are giving is normal saline or whatever crystalloid we are giving. It is not going to be equal. So it's easy to say, but it's very difficult to practice.
no doubt.
Basically, the same, the concept of giving crystalloid has to be come out from that mind for the trauma. So that's the reason I said, when you get a call, there is a trauma, your blood bank has to be, that is the most important thing. By the time you reach, the ambulance of the blood bank people will reach there. So that you can give only 1 liter of normal saline, which will prevent the further complication. And at the same time, what Leena said, that has to be same along with the injectable fibrinogen, which if I would have been there, to give there itself, basically.
So we go for time-bound resuscitation in the questions. Next question is, we already spoke about it, role of coagulation factors, what is there, how we have various factors which are available. We have fibrinogen factor, we have 4-factor PCC. Sir, you mentioned about it in the last question, Nirmal sir. Can you tell me how they are better than the other blood products which we have?
Rather than giving plasma.
Yeah, rather than giving plasma, should we go for fibrinogen factor or 4-factor PCC or 3-factor PCC?
Yeah, it is definitely costly, no doubt about it. But basically, you are hitting the target. What is actually, you should know what is the physiology of the formation of the thrombus or formation of the like whenever there is a crack in the skin and what is happening at the level of side to stop the bleeding. So fibrinogen is the one of the first things to come to form the complete that meshwork. So if you have got a fibrinogen, definitely as per as the what you call it as when you compare with the plasma is another notorious thing because it causes the more hypercoagulal state also as well. And at the same time, you are loading the patient with the plasma. So I'll definitely go for the less volume, what Dr. Sai Prasad has said. Permissive hypotension also I can maintain, and at the same time physiology also can be maintained with the single, maybe I will use here NO7, that is the factor 7, which is readily available. Definitely is very costly, but good experience in my life to use if the patient is affording.
Practically speaking, we are not using it. So what's the take home from? Because we have so resource limited settings. So prothrombin complex concentrate. So is it justified not using it? Because practically in our settings, we are not using it.
It's very difficult basically, but in my experience, PCC experience is not much. Okay. But at the same time, I am using quite frequently the fibrinogen.
Fibrinogen,
yeah.
Okay.
And it's very easily available. We are also picking it out.
Fibrinogen is available. Yeah.
4-factor PCC we have been using routinely for coagulant warfarin-induced or NOAC-induced bleeding. But definitely this has a place here because, see, even if we have to, however fast you do cross-matching, get the plasma and then thawing, all that will take 1 hour.
Yes, yes.
But this you can reconstitute and give it in 5
Why
minutes.
we should not? Yes, perfect.
So if finances is not an issue, probably we should
use it. Okay.
Dr. Leena, your job is easier. You are saying it is not available. So that is not an option for you. You give plasma as
that's what
quickly
we
as
can
you
make it
can.
available. It's practically
Then
making difference.
If that
See,
is there, then
we are
definitely
not
you should
having
have
any
it.
practicality about
Just
it, so
as
we
you
can
are
make
keeping
it available.
fibrinogen you are keeping, you can always keep that.
So research clearly says that giving the complexes or the concentrates or coagulation factors is better because of course it is faster. Abroad they don't look at the cost because most are insurance and they do resuscitation at the field. So anybody who has a massive requiring massive transfusion, they prefer to give the factors at the field itself. And they have clearly found that there is no role of 3-factor PCC, but 4-factor PCC does have a role in trauma and fibrinogen factor. So the first factor, as already mentioned, is fibrinogen factor, and you can give PCC factor. The PCC factors are more important in patients who are on anticoagulation, maybe on warfarin or the newer, even the NOACs. So patient who comes with who's on a valve having on warfarin and has a trauma with massive bleeding, you can obviously go in for PCC as a first thing because by the time you reverse with the giving plasma and the reversal of the INR, which takes time, which takes hours, so the PCC has found to be more effective and found to control bleeding faster and improve survival as well. So though the survival improvement is not shown statistically significant. Okay, and the volume obviously is less. What is the role of tranexamic acid, Dr. Leena? Do you use tranexam?
Yes. The first thing we give is blood and tranexamic acid because that is the only available things what I feel. So we are giving. So
it should be used early.
Yeah,
is what
early, immediately.
Yeah, I think when you are dealing with that, I'll suggest what Dr. Sai Prasad has said. You should have the ROTEM for that. Okay. Whenever you have the ROTEM, to use or not to be used, that is also it will give the idea. But definitely, at any point on this earth, who is by the side of the patient, he will do 1 gram of transfusion. That is the most important. Whatever the result.
So the first dose has to go early, preferably within the first 3 hours of injury. And of course, then there are doses, various protocols which are available for infusion, and it is important to be given. So what are the BP targets that we should maintain in a patient who is actively bleeding of trauma, penetrating or blunt injury? We already talked of permissive hypotension. So what are the BP targets is again another controversy or challenge, and there are no clear guidelines. Dr. Khalid, if you can say more about it.
You want to keep your blood pressure as much so that your perfusion is not hampered, but not that high that you will cause bleeding. So MAP of 40, 45, I'll even go up to 50. I think you cannot go beyond that.
If there is a brain injury, probably you need to keep a higher MAP. Otherwise, maintaining around 40 of MAP should be sufficient in most situations.
So Maha Criticon organizers were very clear. It is a non-neuro. So we are not talking about that. So we are safe here. So I didn't put that controversial question here. Okay. So you want to add something? So there are no clear guidelines on what is the MAP that you need to maintain. Obviously, at this moment, we can't look at the perfusion with the urine output per se because you're not loaded. But again, when I was going through a lot of studies to define MAPs, there is no study which really defines what is the specific or the appropriate target of MAP that we need to keep in a permissive hypotension. But in a penetrating injury, there were studies which said that you should keep a MAP as low as 40 millimeters of mercury till treated. For a blunt injury, there was no guideline, no suggestion. It was just everywhere maintained to maintain adequate tissue perfusion. So I don't know, tissue perfusion, Sheila ma'am talked a lot about it in the last lecture. You can look at CRT or other things, but you will always have the lactate high. So looking for inadequate tissue perfusion is what needs to be looked at. You want to add something, sir? Anand, sir?
A good enough bedside indicator. If platysmo is there, that means it is enough. So we need not push it more, something like that.
So in India, how can trauma be managed better? Okay, I will ask Nirmal sir about his experience of last 27 years. I think sir is in critical care, and maybe Dr. Leena can then add on what more can we do further.
You know, like from Nagpur, another innovative man, non-medical person, he has come out with a model with the help of AI. That name is Busari, right? He just showed me his unit on Sahyadri, right? Sahyadri road only. he is going to meet with the Nitin Gadkari and he is going to develop small traumas clinics, or maybe something like maybe 12 by 12 rooms, and it will be managed with all the CCTV cameras and everything, and it will be hooked up with the government medical college set up trauma centers. So that whatever the protocols, it is, I said, like in initial days, shock is equal to crystalloids, right? So those things can be managed. And we need more ER people to handle that particular units. So that the patient who has been handled there, maybe he is going to have after 3 kilometers there will be one unit, right? So that will the most important thing. That is what his plan is. I don't know how much government is support, but it is very, very difficult at this point of time. But that should be the scenario. Like he's dreaming about like what we are in Western world, but that is not going to happen. But if it happens, so that is the most important thing to have.
I just want to, I'll be very happy because of the 108. Because of the 108, lots of life are going to save because the patient in whatever condition they are reaching to the hospital. But in reality, in our setup, the real scenario is sometimes the doctors are trained, sometimes they are not trained. And what I feel, the private ambulances are there. So private ambulances, the ambulance driver is there. So what I feel after this lecture, so the ambulance driver at least to apply tourniquet and the doctor to the trauma patients and the doctor who is there. So at least he is equipped with like taking an intracath and starting a fluid will save lot of patients. There are, because 10 years before the scenario is not like that. Lots of patients are dying on the road only, but because of 108 we have. And what I saw in Nagpur railway station when I came, there is a trauma unit is there and AID. So Jalgaon is not there. So I think I will be in that, will talk with the politician and will go ahead with the all trauma team so that more lives can get saved. But it's improving. It's improving. And lots of trainings will be required. In India, continuous training is required because no one should die because
continuous
of hemorrhagic shock.
is going on.
You want to add anything, Sai?
Yeah. After hearing Dr. Leena, what sir wants
comments,
to say.
2, 3.
Yes, sir.
As we are moving to AI and Rotem and etc., the basic problems will persist, and most of the NABH or even GSA accredited hospital now we have polytrauma code, and no matter whether accreditation is there or not, polytrauma codes, which includes a team of people who are conversant with managing these emergency cases, maybe anesthesiologists, radiologists for e-fast, and of course intensivists coming in, and of course surgeon. But these are organized efforts, and I think locally, wherever possible, these organized efforts to be done. That is the polytrauma code. People have given different colors to them. We have white as a, but that's a different. But I think organization of these teams is very essential to overcome basic questions. We keep on communicating, get answers from one call to other, get answers from there. But it's on the spot, no matter intermediate or junior level, it has a good outcome. Second is regarding CT scan movement, as you mentioned, whether it's bleeding or not. And when surgeon is at home, he always asks for CT, and we have seen crashes in CT, and time was lost. So OT or CT, you have to decide, and there must be some person taking that decision because the mortality is directly related to this conflict and confusion on this contentious issue. Third is hypothermia, very underrated. There are around resource limited setup also can have these. Simple cabinets are now available for 24 warming of fluid in OT, ICU, and even emergency rooms. And of course, online these are there, and blanket with hot air blower. But this aspect was obviously neglected. And fourth is coagulation. I think we have spoken about it quite a bit. Thank you.
You are asking me about my experience of so many years. Yes, I'm just putting in the different way, little funny way. The RMOs who used to be with us, like me, Rajan, Nikhil, Sapna, आता तुम्हाला experience येईल तो. 7-8 years used to be with us. And they used to start ambulance services, right? So that was very, very difficult for us. And then he becomes the businessman. He sits on the chair and his boys start working. So I don't know how much percolation was there for saving this sort of trauma injuries. But we are very lucky, like Symbiosis people in Nagpur, they have opened their college and we have got an official PGs for ER. So, and one of the person, Rajas has taught that person in Pune, that fellow is in charge of the ER of the government 108. So, scenario is in Nagpur as far as 108 is concerned, is little comfortable.
Sai sir, you want to add anything?
I think, sir, Bande sir said the same way. I think if we establish a trauma unit in the hospital also with a emergency ICU, CT scan, and next to that is a OT, so everything in line, probably we may save some patients.
And Dr. Sai, you want the surgeon to be there. If surgeon is at home, it doesn't matter where your OT is or where your CT scan is.
I think trauma patient reaching to your hospital in what stage is also matters, because the first 60 minutes goes into the transport. So your transport team should know everything. So I will again emphasize the catastrophe first you have mentioned in your slide is control the bleeding. So whatever open wounds, at least basic they should have. They should have the knowledge.
So I know it's difficult, but not so difficult with young minds who will work harder for it, making it better. With this, I think we'll conclude the resuscitation, and thank you so much. We have Criticon in Chennai, where we also have a trauma workshop. Hope to see all of you all there. Thank you.
Thank you, Gunjan. Thank you, panelists. Thank you so much.
After this wonderful session, I request all the stars, all the organizing committee members and everyone to assemble in Hall B for the bell.
We have wonderful quiz going on, the last round, and the winner is going to be declared. So we are going there. It's at the very interesting phase, the quiz is. We'll continue our valedictory function there. नहीं उधर भी है ना भी है Yes, sir.